సివి రాలేదు రిజిస్టర్
ఏం కాదు అబ్జెక్టివ్ మీకు తెలుసు కదా సోమరాజ్ సార్ చెప్పేసి సోమరాజ్ సార్ జస్ట్
Good morning, everyone. A very warm welcome from AIG Hospitals. I am Dr. Vinay Gella, Consultant Pulmonologist in AIG Hospital. Welcome to Day 2, Session 7. I cordially invite the chairpersons, Dr. Vishwanath Gella. He is a Senior Consultant Pulmonologist in AIG Hospital. He is our guide, mentor. And next chairperson, Dr. Gautam Bachu. He is a Senior Consultant Pulmonologist and he is my close friend. Please invite the speakers.
Thank you, Vinay, and welcome one and all once again. In the today's sessions, we have first virtual talk by Dr. Abhishek Goyal. Dr. Abhishek Goyal is a professor of pulmonary medicine in All India Institute of Medical Sciences, Bhopal, and is very passionate about sleep medicine. He has done a lot of research in the sleep medicine and published extensively. He has got more than 4,000 level 1 polysomnographies to his credit, and he has done a lot of community studies as well, and he's trying to develop a new score for Indian patients. We have the stop bank score, but stop bank score has not been very well validated in the Indian population. He's doing some work on creating an Indian sleep apnea questionnaire to predict the pretest probability. And with this brief introduction, I would like to ask the AV team to play the pre-recorded talk of Dr. Abhishek. He will be talking upon auto CPAP versus manual CPAP. Lot of times we see that people write without doing a sleep study or without doing a titration, just
AIG and Dr. Vishwanath Gela
write an auto
organizing
CPAP.
this wonderful event for postgraduate students. I'm extremely sorry that I could not be there in person. I'm going to discuss some points about the common modes used in sleep medicine, that is auto PAP and manual CPAP. Now we have many modes which are used in sleep medicine, like auto PAP, CPAP, bi-level PAPs, which consist of S, ST, T mode, and PC mode. We also have an auto bi-level PAP now, VAPS technology, AVAPS, automatic EPAP, and ASP mode. But the most common used modes are fixed pressure CPAP and automatic CPAP. With the advent of technology, we can have many million transistors in a small area. That had revolutionized the industry of smartphones. The phones have become smarter, but same cannot say about the humans. Our machines have become quieter, smaller, smarter. But are these machines really better? Is everything which is new better than the old? All these machines of CPAP have inbuilt a microprocessor, a blower, and a resistor. So the algorithm in these microprocessor determines how an auto PAP will behave to a particular event. These microprocessor detects the event according to the algorithms. So the detection of an event entirely depends upon the basically two technologies: force oscillator technique and pulse oscillations. These technologies works constantly by monitoring flow, and if there is a deviation, it detects it as an apnea or hypopnea or flow limitation or snoring, depending upon the algorithm. But the problem is all these algorithms are patented and they are not disclosed by these companies. So, for example, the ResMed definition of an apnea and hypopnea is entirely different from a definition by a Respironics machine or Devil Bliss machine. And these definitions are different from the scoring rules which we used for scoring of PSG by American Academy of Sleep Medicine. For example, a ResMed machine S9 model defines an apnea when the flow is reduced below 25%, whereas a Philips machine detects an apnea when the flow is reduced by more than 80%. The definition of apnea, as we all know, is more than decrease of flow of 90%. Similarly, a ResMed machine detects hypopnea when the flow falls below 50%. A Philips machine detects a hypopnea when the flow is reduced by 40%. And the detection or the definition of hypopnea is either decrease in 30% flow along with 3% or 4% desaturation. So the definition of an apnea and hypopnea detected by these machines are different from each other, and the definition is different from the scoring rules which we follow for scoring polysomnography events. Similarly, a Philips machine or Rested machine or Fisher-Paykel machine or Devil-Bliss machine, all these machines have different definitions of intentional leak and unintentional. The more important point is how these machines behave when there is a stability after few events. So suppose a machine increases pressure after a few events of apnea or hypopnea to 12 centimeter. After a few minutes, it will again come down to 11 centimeter. Again, it will come down to 10 centimeter. So this happens continuously throughout night in a patient in whom we have given a window of 4 to 20 centimeter, which is the most common settings which is prescribed. So if a event is there, it will increase the pressure. When there is no event, it will again decrease the pressure. So when the event is there, it supposedly it has increased to 12. After that, it will decrease up to 11 when there is no event. After a few minutes, if there is no event, it will again decrease to 10. And after 10, suppose there is an event, again it will increase to 11. So this continuously increase and decrease of pressure happens. And this, because of this variability of pressure, the stability, there are a few arousals are happening in a patient who is having events, and this, due to these arousals, the patient can have disturbance in sleep and disturbance in autonomic system, which will be see later. So why we use auto CPAP machines more as compared to a fixed CPAP machine? Is it more effective? Is the adherence better with auto CPAP? Is it cheaper? Or is it easier to advise? We will see all these points one by one. So to the first point, whether it is more effective, does it decrease the AHI more effectively as compared to a manual CPAP? There are various bench studies which have compared automatic CPAP versus manual CPAP machines. One of the studies, this is a beautifully written paper published in 2015 in Journal of Clinical Sleep Medicine, in which the investigators created an artificial lung with different kind of registers. These registers made artificial events like obstructive apnea, obstructive hypopnea, snoring, central apnea. So they compared the different 11 different machines in response to different events. Like this is an obstructive hypopnea which was artificially created in an artificial lung. So these 11 machines were compared to different events like snoring, apnea, hypopnea, central apnea. So when a apnea or hypopnea was there, the machine should have increased the pressure to overcome that event. Most of the machine responded to obstructive apnea except for Devil Bliss and Wheelman auto CPAPs. Most of the machine responded to obstructive hypopneas except Ploton automatic machine. Similarly, when there was central sleep apnea was created, the pressure should not have been increased, because for central sleep apnea, if you increase the pressure, the treatment emergency central sleep apnea, the pressure, if it is increased, the central sleep apnea will further worsen. But only 4 devices did not raise the pressure out of those 11. When snoring was there, only 5 devices raised the pressure. That is, these machines have different efficacy when as compared to for a single kind of event. So when the apnea or hypopnea was artificially created, how these machines detected whether the apnea was there or hypopnea was there was also compared. So whether the apnea was there and the machine detected apnea was there, that was machine correct, it defined it correctly. So that was the accuracy of the download report. It was also compared. So as we can see in the second column, the scoring accuracy was there, and most of the machine had efficacy more than 80%, except for a BMC Respirate automatic CPAP machine, which accuracy was only 47%. The treatment efficacy was when obstructive apnea and hypopnea was there, how it behaved. Most of the machine behaved well except for Weinmann machine and Devil Bliss Sleep Cube automatic machine. When central sleep apnea was there, only 4 machines behaved properly, that is, they did not increase the pressure. So overall only Philips automatic machine and ResMed automatic machine behaved better in terms of obstructive apnea, hypopnea, central sleep apnea events, and scoring accuracy. Rest, most of the machines like BMC, Ploton, Devil Bliss, Weinmann, they have behaved dismally as in this bench model paper. So, why we are using auto CPAP machine? Does it decrease the cardiovascular complication more as compared to a fixed pressure machine? See, whenever you prescribe an auto PAP machine, patient symptoms will improve. The sleepiness will usually decrease. But whether the effect on cardiovascular, that is MI, heart failure, arrhythmias, the studies are not there to compare automatic CPAP versus manual CPAP machine. The only studies which are available are in terms of control of hypertension and autonomic system. The two studies, there are only 2 randomized studies which compared fixed pressure in automatic CPAP and hypertension control, and one of the studies found that fixed pressure CPAP was better as compared to automatic machine pressure, and the difference was significant, 6 millimeter of systolic and diastolic of 8 millimeters between 2 arms of fixed pressure. That is, fixed pressure was found to be better as for control of blood pressure. In the second randomized trial of 322 subjects, which was done in France, the primary objective was decrease in systolic blood pressure. There was no significant difference in the 2 arms of fixed pressure CPAP and automatic CPAP, but the secondary objective was 24-hour BP measurements. The fixed pressure CPAP was found to be more effective in reducing the 24-hour diastolic blood pressure as compared to a automatic CPAP machine. So automatic machine were found to be less effective in the only 2 studies which were done to compare manual CPAP versus automatic CPAP. Similarly, for control of autonomic nervous system activities, fixed pressure CPAP was found to be more effective as compared to automatic CPAP for stabilization of heart rate and for stabilization of cardiorespiratory coupling. All these devices of automatic CPAPs have different devices which works on different algorithms, and they behave differently, and they have different residual AHI to similar events. Now we have cloud connected devices so that we can have more data, and this more data, this big data, is leading to some wonderfully conducted studies. In one of these paper, the automatic machines detected residual AHI was scored manually, and it was found that the machines were not able to detect the events properly. The residual AHI in a machine, when the cutoff was 15, was 1.8% in the machine, and when it was manually scored, it was found to be 7.8%. And when the AHI cutoff of 5 was taken, it was 32%, and in automatic scoring, and when it was manually scored, it was 60% events was missed. That is, residual events are very common during CPAP treatment, and the automated device detection is very poor. So the patient should not be relied totally upon the residual AHI which is detected by the machine. So why we are using auto CPAP machine? Is it better because of better adherence? Studies have shown that there is no difference in terms of adherence when automatic CPAP was compared to CPAP. In various randomized studies, it has shown have similar efficacy. Why we are using auto CPAP is basically because of cost, and cost, it is not in our region. It started in USA, where the cost of a level 1 PSG is around 3,500 to 4,000 US dollars, and a level 3 PSG costs around $800. So that is the massive difference in terms of cost. The cost of a manual CPAP, which we can prescribe a level after a level 1 PSG, is $500, and a automatic CPAP costs around $550. So there is not much of a difference in terms of CPAP machine and automatic CPAP machine in US. So because of this huge difference, the insurance company pushed the societies that automatic CPAP should be advised and level 3 studies should be done. But if in India we see the cost of level 1 PSG in most of the centers is around 10 to 15,000 rupees, and the cost of a level 3 PSG will be around 6,000 rupees, 5 to 6,000 rupees. But uh, when after a level 1 PSG, we can give a manual PAP machine which will cost 35,000 rupees, and an automatic PAP which will cost from 55,000 rupees. So the total cost will always be less when we do a level 1 PSG followed by a manual titration as compared to a home sleep testing followed by a automatic CPAP machine. So the reason why US is pushing for an auto CPAP machine is entirely because of the cost issue, but the same thing we cannot blindly follow. We should not blindly follow. According to my understanding, why we are prescribing auto CPAP is because it is easy to advise. Because we don't have sleep labs, we don't have people who can titrate, we don't have places where the manual titration and manual scoring is done. There is no defined courses for sleep technologists, and we all know that automatic scoring efficiency is very poor. Automatic scoring detected by even by level 3 machines is poor, and even if we are doing level 3 machine polygraphy, these scoring, it should be manually scored because the automatic scoring is very poor in this machine. So there is no true answer whether automatic CPAP machine is better than manual CPAP. Current literature did not support so. The entire difference is how you handle those machines. We have seen automatic cars and manual CPAP, manual cars. Just like automatic cars are easier to run as compared to a manual car, but how these cars run entirely depend upon the driver. Similarly, the patient will improve or not. It will depend upon the driver, that is the doctor, who knows about the car, or in this case, the PAP machine. Now imagine a dystopian future where only automatic cars are run, where no one knows how to drive, where no one is taught how to drive. Similar to the situation currently, where no one knows how to titrate a PAP machine because we are not taught how to score or how to analyze a polysomnography. We are not taught how to titrate a patient of OSA, and we rely totally upon automatic CPAPs. We think that if we have prescribed auto CPAP, everything will work properly. You can rely on automatic car only on these conditions. An automatic car will easily take you through these area. But will you risk your life with an automatic car on roads like these? Today, technology is not so smart to take place of doctor. We need to control the technology so as to have better care of patient. We should not leave blindly to automatic machines the care of the patient. So what is the practical solution? I'm not saying that automatic CPAP are useless. It is a useful machine, but we should prescribe if you don't have a level 1 PSG. If you are prescribing it, you should keep the auto-PAP range narrow. You should keep the EPAP minimum at P90 or P95 when you are following up the patient. Even if patient is not improving, then you should refer this patient for a level 1 pH titration. You should always write a full prescription of CPAP as you write of the medicines. And the most important thing is you should not prescribe and forget. You should follow these patients by following up with the symptoms like sleepiness, by improvement in presenting symptoms, be it nocturia, headache, insomnia, the following up with the cardiovascular outcome, more practically by measuring the blood pressure, by improvement in cognitive function and quality of life. What we do in our lab is we follow up after first 2 weeks of usage, then after 3 months, 6 months, and 1 year, and then yearly after these patients are followed up. OSA should be viewed and treated as a chronic disease, and patients should be followed longitudinally. The main indication for which auto CPAP was made was for positional OSA and REM OSA and insomnia associated OSA. For these indications, it is very useful, and for if you are using home sleep testing, it is a useful machine, but it is not advanced PAP. It is an automatic PAP. It is not superior as compared to a manual fixed pressure CPAP. So, to summarize, algorithms, response of events of these machines, of automatic PAPs, of manual PAP, how they behave for different events, how the leak is detected, how the data is analyzed, it differ greatly within the company and between the company. Automatic PAP do work. It is not a useless machine. But it is not superior to fixed pressure CPAP. We should understand how these devices work so as to select the patient better, because some patients will not improve with automatic CPAP. You should know which patient will improve and which patient will not improve. Thank you so much for your time. I will be available online for the questions.
Yeah, Dr. Abhishek actually completed his talk in time, actually, 16-17 minutes. He will be joining us for questions in around an hour or so. So just one message I wanted to give from his talk is that whenever there is a facility for you to refer a patient for an level 1 sleep study and titration, that should be done. But if you don't have the facility for referring a patient for level 1 sleep study, and if you're suspecting that the patient could be having obstructive sleep apnea, a level 3 sleep apnea study, that is a home sleep study, is also sufficient. And when you put them on home auto CPAP machine, as was pointed out by Dr. Abhishek, we need to follow them diligently and see whether
Recording in progress.
whether the apneas and hypopneas are resolving or not. Every time you ask the patient to get the machine, you check the memory card. You can put the memory card in the software and generate an AHI and make sure that the AHI is below 5. It should be controlled, and again check the P90 pressures and everything. So just you can note the questions which you have, and then Dr. Abhishek will be able to answer when he comes online. And the second important point which I wanted to tell you is, especially when you're suspecting a patient to be having central sleep apnea, patient with congestive heart failure with sleepiness, chronic kidney disease on dialysis, patient having sleepiness, and patients who have underlying chronic obstructive pulmonary disease with hypercarbic respiratory failure, do not prescribe auto CPAP. It's going to be more harmful for your patient. So in these kind of patients, when you're suspecting sleep apnea, do a proper level 1 sleep study, titration, and put them on manual CPAP or on BiPAP depending upon your titration pressures. These are the contraindications of putting an auto CPAP machine, these contraindications. And with these few words, I would end this talk, and then I would like to invite Dr. Ravindra Babu sir. Dr. Ravindra Babu sir is a senior most professor in the Twin States of AP and Telangana. He is currently Professor Emeritus Pulmonary Medicine, NRI Institute of Medical Sciences at Vizag. He is very, very passionate about teaching, and is very passionate about teaching basics to the postgraduates, especially chest X-ray, ABG, mechanical ventilation, and he has been a part of numerous workshops. He has numerous orations and awards to his credit. And I request sir to talk on the chest X-ray science and symptom, which is going to be very, very useful for the postgraduates in their clinical practice, science and sports. Thank you, sir.
Good morning, ladies and gentlemen, my dear students.
At the outset, I thank the management of AIG, particularly Dr. Vishwanath Gella, head Department of Respiratory Medicine, AIG, and his team, and also Sun Radiant, particularly Manohar, for successfully conducting so many CMS. This is the 50th CME useful to exam going pulmonary medicine students. Audibility బాగానే ఉందా పెంచాలా కొంచెం ముందుకు వస్తే బాగుంటుంది మీరు మన క్వశ్చన్స్ ఇంటరాక్టివ్గా ఉంటే బాగుంటుంది ఇఫ్ యు ఆర్ అఫ్రైడ్ ఆఫ్ ఆన్సరింగ్ ద క్వశ్చన్ యూ కెన్ సిట్ ఇన్ బ్యాక్ బెంచెస్ బట్ ఇన్ లైఫ్ యూ విల్ బి ఇన్ బ్యాక్ బెంచెస్ ఓన్లీ
Sir, can I ask you questions while the talk is going on, or you want them to ask questions after this?
అంటే నేను ఏమైనా ఇంటరాక్టివ్గా అడిగితే వాట్ ఈస్ ద ఆన్సర్ అని అంటే చెప్పాలి కదా వాళ్ళు
Yeah, please come forward. Don't sit behind. It's okay.
కొంచెం పెంచుతా అట్లా Now, what is the importance of chest X-ray? See, it is one of the most common investigations done by all the practitioners, including pediatric general practitioners, etc. See, for example, if you take a system of neurology, they no more take a skull X-ray, or for that matter, gastroenterologists, they will not take any abdominal X-ray. They go for ultrasound abdomen or endoscopy, like that. See, cardiologists, they go directly for echo. It is only respiratory physicians who use chest X-ray. So, chest X-ray is still the sheet anchor in the diagnosis of most of the respiratory disease. It is not CT. అంటే చెస్ట్ ఎక్స్రే అనేది లేడీస్ ఎక్కువ మంది ఉన్నారు కనుక ఇది మనం డైలీ వేర్ చేసే శారీ లాంటిది సిటీ అనేది పట్టు శారీ ఆఫ్ కోర్స్ nowadays they use pattu saree for every even for routine this thing also. So chest X-ray is very important. See, unless there is an abnormality in chest X-ray, don't go for CT or MRI or something else. Now these two X-rays, these two patients came with hemoptysis. The both X-rays were reported as normal. Anybody can comment whether they are really normal or abnormal? Any findings or anything less? Okay. This is a 50-year-old male with hemoptysis, same patient. Another one, a 30-year-old male with hemoptysis. See, in hemoptysis, it is very, very important to localize the lesion because usually we keep the patient on the side of the lesion because there will not be any spillover to the normal one. Useful about chest X-ray or for any opacity is the border or margin of an opacity is seen only when there is a contrast. If there is no contrast, you don't see the contiguous margins. For example, for X-ray, it is a radiographic contrast. So you can see the beautiful black lungs contrasting with the very elegant white mediastinum. That's why we use chest X-ray more because it gives a lot of detail. If everything is white, you don't get any detail. And if everything is black, then you don't get any detail. Now, what is Islet sign? See, if two opacities of similar density are in contact with each other, then the contiguous margins will be lost. So, this loss of Islet is known as the Islet positive sign and very much propagated by Sir Benjamin. Evaraina? It is one of the books you must read like a Bible or a Bhagavad Gita. It is Sir Benjamin Felsel. It is very, నేను చదివినప్పుడైతే ఐ ఫినిష్ ఇట్ ఇన్ జస్ట్ 1 hour. అంటే బాగా జోక్యులర్గా ఉంటుంది అనమాట. Now, what is its significance? See, if two opacities of similar density are adjacent or apparently adjacent to each other, then if you know the location of one opacity, then you can detect the location of the other opacity. Now, this can be applied to any border in the lung. For example, for both cardiac borders, ascending aorta, aortic knuckle, whole of the descending aorta, both diaphragms, even to vessels, anywhere you can apply. So there are a lot of modifications of the Islet sign. Because it is a general sign, it is a sign of contrast. So unless you understand this sign, you will not understand any details about the pictures. Now, where is it located? The right side opacity? Right side or left side? First one. Is it in the lower lobe or middle lobe? Pardon? What is that opacity? It is consolidation or collapse or mid-external tumor? This is a consolidation, fairly dense lesion without any margins. Usually consolidations, they don't have any margins unless they are abutted by a transverse fissure. Usually the middle lobes, if they abut the fissure, then the upper horizontal border in the upper part, and the upper lobe will have horizontal border in the lobe. Otherwise, most of the consolidation, they will not have any borders. Whereas the other one, lower lobe or upper lobe, middle lobe or lingula, lower lobe, because the cardiac margin is seen. The cardiac margin is presented anteriorly, and the structure which obliterates the left cardiac margin is lingula. Now, where is this? Anybody who answers will get 100 rupees. Anyone can raise the hands? Okay. See, I told you the similarity sign cannot be applied unless it is adjacent or apparently adjacent. So obviously this is not adjacent. You can see the medial border of the lesion. So you cannot apply. You don't know whether it is anterior or posterior. So it should be either in contact with the border or apparently in contact with the border. What is the left side lesion? Is it in lingula or lower lobe? Lingula, good. What is the lesion? Pathological lesion? What do you call it? Pardon? ఇక్కడ ఉంటే నాకు వినపడదు. So it is a necrotizing pneumonia. అంటే pneumonia కర్ణాలు ఉంటే it is necrotizing pneumonia. If you have translucencies in pneumonic consolidation, that is a necrotizing pneumonia. So what is the difference between tuberculous and necrotizing pneumonia? Because both have cavities. See, the hallmark of consolidation is a dense opacity. So in between two cavities, in necrotizing pneumonia, you will have consolidation. The hallmark of tuberculosis is infiltration. So in between two cavities, you will have infiltration in tuberculosis, whether it's lower lobe or upper lobe. So the other one, the right one, the pneumonic consolidation or a necrotizing pneumonia. The pneumonic consolidation in the lower lobe because the left cardiac border is seen clearly. Now, this is easy because you need not go for X-ray to locate. You can clinically detect where the tubular breathing or crackles are there. Now, the most important, practical important utility is, see, the small opacities per se may not be seen on a chest X-ray, but their presence can be detected when they obliterate a known border. For example, the X-ray shown in the first, the 50-year-old male patient coming with hemoptysis. You can see any time, any X-ray, if you think normal, you always look at the borders. See, the left cardiac border is, the right cardiac border is hazy, whereas the left cardiac border is very clear cut. So there's something there on the right middle lobe. You can see how hazy it is. It is not clear. Now you can see the right middle lobe collapse consolidation. So make the patient lie down on the other side, the same side, so that it will not spill over. So if you don't apply this sign, you would have missed it completely. Ultimately, you will be doing bronchoscopy, that is different. Now again a 30-year-old male patient with hemoptysis, again reported as normal. If you see carefully, again the left cardiac border is very clear, but the right cardiac border is very hazy. Now take a, what is this view? Epicogram or lordotic view. So you can see the middle of collapse consolidation, a bronchial carcinoid was found. Again, you can see the right cardiac border is obliterated. After treatment, you can see the right cardiac border is very clear. Again, a child. Usually, we don't take a lateral use in child because of radiation. You can see the left cardiac border is obliterated, and after clearance, you can clearly see. So, the take-home message is always look for obliteration of the known borders before you say any X-ray is normal. Now, what is this sign and what is the lesion? గట్టిగా మాట్లాడండి. So, what is the lesion? Pardon? Good. And if you don't find left shackle sign, you will exclude left upper lobe collapse? No, good. Now, what is this? This is also reported as a normal X-ray. Anything is there? Already lateral చూపించాను. So, if you see clearly, the whole of the left cardiac border is obliterated. You may not be able to see the left skull sign, whereas this border is clear, whereas slight elevation of the dome, whole of the left border. So, whenever you see, there may not be opacity per se, it may be very faint, but whenever it is obliterated, you should suspect left upper lobe collapse. This is also, as I said, it is a Silas sign. What do you call this sign? Some people may ask. That is the bow sign. And anteriorly, it bows anteriorly, collapsed upper lobe. Now again it is clear. It looks almost like a consolidation. There is no left shackle sign, but you can see obliteration of the complete this thing. So it depends on the clinical signs. If there is tubular breathing crackles, then you may think it is this thing. But lateral view is very important. Lateral view we can see the whole of the oblique fissure. It should be here. It is gone anteriorly. So it is a definite left upper lobe collapse. How do you suspect? Because of the obliteration of the whole of the cardiac border and left cardiac border completely. Again, another X-ray reported as right upper lobe fibrosis. But you can clearly see the whole of the left cardiac border is completely obliterated. Very faint opacity compared to the right side. Again, a left upper lobe collapse. Now, what is this sign? Pardon? Very good. Cervicothoracic sign. So, this is also another modification of the Chilaudi sign. See, why it disappears when it goes to the neck? Because there is no contrast. In the lungs, there is a contrast because it is going into the neck and the neck muscles surround it. Neck muscles and the opacity will have both water density. So, it disappears. So, that's why you can interpret that this is something coming from the neck or going from the mediastinum into the neck and anteriorly situated. It is a cervicothoracic sign, usually due to the retrosternal thyroid. Now another one left side, courtesy Dr. Vishweswaran. You can see another one. You can say this is anteriorly present because you can clearly see the aortic knuckle. If it is posterior, aortic knuckle would have got obliterated. So anyway, it is again, it is called Indian rope trick also. It disappears after the clavicles. So this is the cervicothoracic sign. Now what is the lesion? What investigation you will do? CT scan or directly bronchoscopy? Pardon? Huh? ఫైబ్రాటిక్ బ్రాంకోస్కోపీ డైరెక్ట్ అనేవాళ్ళు చేతులు ఎత్తండి. చేతులు లేవా? సిటీ స్కాన్? ఎనీథింగ్ ఎల్స్ యూ వుడ్ లైక్ టు డూ? అయితే ఇంతకుముందు చూసారా లెక్చర్? వెరీ గుడ్. ఎనీవే, సో యూ టేక్ ఎ lateral. So this is a diabetic patient, AB positive, no need to do bronchoscopy చేస్తే మనకి టీబీ వస్తుంది. Now this is the true hilar adenopathy. You can see the lobulated mass. Again, so in the lateral view, this is the area of the hilum. You can see the lobulated mass. దీనికి ఎవరో ఒక సైన్ పెట్టారు. వాట్ ఇస్ ద సైన్? ఒక్కోసారి అడుగుతుంటారు, సైన్స్ కొంతమందికి ఇంట్రెస్ట్ ఉంటుంది. డెఫినెట్ సైన్ అంటారు. నేను మొన్న నేర్చుకున్నాను. సో దట్ ఈస్ వేర్ ద hilar adenopathy is present. Why I am showing is, see, any opacity, whether it is in the lung, pleura or mediastinum, if it is in the same plane of the hilum, will automatically look like a hilar opacity in the PA view. You can see it is in the same plane of the hilum, so it will just mimic a hilar opacity. Likewise, anything anterior, whether in the lung, pleura or mediastinum, it will look like a hilar opacity if it is in the same plane. So sometimes it is, see, what is this sign? Through the opacity, if you see the vessels clearly, that is hilum overlay. Okay, if you see like that, it is okay. You know it is not a hilar one. But even if it is not in the hilum, most of the times what happens is, you may not be able to see the vessels. So you should always take a lateral view. This is the hilum overlay sign. Another hilum overlay sign. You can clearly see the vessels. Now here see, no hilum is seen. This is a patient of asthma. So any patient with asthma, if you see something like that, you should always suspect ABPA. Just dissipate with steroids. No need to do IG also. No need to do any CT scan or a bronchoscopy. So it is not hilar-putty. If you think it is hilar-putty, you will do a lot of investigations. Just take a lateral view. Again, you can clearly see this is the HIV patient with the consolidation and cavity in the right anterior segment, tuberculosis. So take a lateral view whenever you see hilar opacity. Then decide whether you would like to do other investigations. Now what is this sign? Typical air bronchogram. Again a sign of contrast. See, normally the air bronchogram is not seen because there is no contrast with the black lungs. So whenever the lungs are getting filled up with alveolar exudate, then you can clearly see the air bronchogram. So the air bronchogram, if there is an air bronchogram, then definitely the lesion is in the lung, not in the pleura, nor in the mediastinum. So it not only is present in consolidation, but sometimes you can see in lymphomas as well as the alveolar cell carcinomas. Again, a CT patient with typical air bronchogram, ICU patient. Now what is this sign? Pardon? What is the pathology? ABPA. What is this sign and what is the pathology? Pardon? ఏంటి గట్టిగా మాట్లాడండి. దానికి ఎన్ని సైన్స్ ఉంటాయని నేను ఇప్పుడే నేర్చుకున్నాను. 1, 2, 3 సైన్, గార్లాండ్ స్ట్రాడ్ అండ్ పాన్ బ్రోకర్స్ అంటే ఎలా పాన్ బ్రోకర్స్ అన్నారు నాకు తెలియదు. అక్కడ యూనిఫామ్గా ఉన్నా ఇక్కడ యూనిఫామ్గా లేదు. ఎనివే ఎవరిని అడిగితే చెప్పండి. What is the disease? What is the staging? Stage 1 or 2 or 3? That is important. See, whenever you see hilar adenopathy with parenchymal lesions, so you can see these infiltrates. This is not uniform like in miliary pattern. Majula mid-zone predominance is there. So this is stage 2. Stage 1 is normal X-ray. Stage 2 is only hilar adenopathy. Stage 3 is, stage 0. Stage 0 is normal. Stage 1 is only hilar adenopathy. Stage 2 is stage 4 lo only parenchymal opacity. By that time, the hilar adenopathy will disappear. Stage 5 is end stage fibrosis, which usually mimics an IPF. What is this sign? అందరూ ఒకసారి అరవాలండి ఏంటిది. దిస్ ఇన్ ఎక్స్ట్రా ప్లూరల్ సైన్. You can see a convex lesion towards the pleura or the mediastinum with the tapering margins. Usually ఏంటంటే ఇట్ సైడ్ ప్లూరల్ పెరటల్ ఉన్నప్పుడు you should always suspect a rib lesion. Rib erosions ఉన్నప్పుడు అలా కనబడుతుంది అనమాట. ఎక్స్ట్రా ప్లూరల్ సైన్. Another extra pleural sign, you can clearly see the absent, almost first rib is eroded. You can see this is the second rib, even the second rib is eroded. So whenever you see an extra pleural sign, usually the commonest is the rib lesions. Sometimes it can be some hematomas if there is an injury. There are two signs there. What are the two? Two signs related one disease. This is the extrapleural sign. What is this sign? Cervicothoracic sign. You can see this is the trachea pushed up. So this is a thyroid carcinoma giving rise to rib metastasis. This is also, you can say this is a half extrapleural sign, otherwise called incomplete border sign, because the ribs are oblique. Sometimes you may not be able to see the clear cut margin. Again, significance is same. You can see the eroded this ribs. This is clearly seen, this is clearly seen. Both ribs are eroded. Again, another one, half extrapleural sign or incomplete border sign. Another one, you can see rib is completely eroded. What is this sign? Most favorite sign. Reverse S sign. So that convexity is due to the tumor. And that convexity is due to the elevated fissure. అయిపోయింది టైమ్ ఉందా ఇంకా 5 minutes ముందు చెప్పండి. గోల్డెన్ రివర్స్ S sign. This is another case, similar. Another one, subtle and similar. You can see this convexity, again this one. Golden reverse sign. What is this sign? Another favorite? Bulging fissure sign. So it should be, it can be due to, most of it due to necrotic pneumonias, Klebsiella pneumonia. It depends on the clinical picture. It can be a big tumor also. Again, another old X-ray bulging fissure sign. When do you say a lesion is benign? A solitary pulmonary nodule is benign. So when it is stable over 2 years, and when there is a specific type of calcification, like a popcorn calcification, or a diffuse calcification, or a central target calcification, laminated. But if you find a stippled calcification or an eccentric calcification, that doesn't exclude carcinoma. So if you find a lesion stable for so many years, then no need to do any CT or anything like that. Just observe. Always ask the old patient. This is what is the calcification? Popcorn, good. This is popcorn, sometimes laminated. This is central target, usually histoplasmoma. It can be tuberculosis in India also. Again, central target. Complete amorphous, some sort of granuloma. Now what is this sign? Left upper lobe. Air crescent or monod sign. Again, this is hydrated లో ఏమంటారు దాన్ని? వాటర్ లిల్లీ కాదు. ఇలా ఎయిర్ క్రిసెంట్ అంటే ఐ థింక్ కాంబోస్ అయినా అది అంటారు. వాటర్ లిల్లీ ఇస్ డిఫరెంట్. No, this is the air crescent, but it is air crescent is in the dependent port. So you should suspect a malignancy. అంటే అదే ఆస్పరిజిల్లోమ అయినా హెమటోమా అయినా డిపెండెంట్ పార్ట్లో ఉంటాయి అనమాట. వెరస్ హియర్ సి ద మాస్ ఈస్ ఇన్ ద అప్పర్ పార్ట్, ద ఎయిర్ క్రిసెంట్ ఈస్ హియర్. So whenever you see such a lesion, you should suspect a malignant lesion. Another one, you can see mass is there, air crescent is downwards. Very rarely that can happen in hydrated, but hydrated lesions are very clear cut. మన టెన్నిస్ బాల్స్ లాగా ఉంటాయి అనమాట. Now here you can see a cavity with a mass. So whenever you see cavity with a mass, you should always suspect either an aspergilloma or a hematoma. Usually the hematoma disappears after some. See, this is the hematoma, it disappeared after some time. This is not an aspergilloma. Again, you can see multiple granulomas, but again, you can see a mass-like lesion here, but again disappears after some time. So that is a hematoma. You should not suspect it is some solitary pulmonary or mass. Wait for some days. If it doesn't disappear, then you take a CT. What is this? Pardon? What is this? జనరల్గా ఏంటంటే లంగ్ యాప్సిస్ ఎక్స్రే మీకు ఏమైనా స్పాటర్ కింద పెట్టరు ఎగ్జామ్స్లో. వై ఐఎమ్ షోయింగ్ ఇది లంగ్ యాప్సిస్లో క్లియర్ కట్ ఫ్లూయిడ్ లెవెల్ ఉంటుంది హారిజాంటల్. వేరే ఇఫ్ యూ సస్పెక్ట్ సంథింగ్ ఇర్రెగ్యులర్గా ఉంటే దెన్ వాట్ ఈస్ దట్ సైన్? దట్ ఈస్ వాటర్ లిల్లీ సైన్. దట్ ఈస్ ద క్యావిటీ వాల్, వాటర్ లిల్లీ సైన్. Another case, you can see there is no horizontal line, water lily sign. Again, you can see another water lily sign. Water lily అంటే మరి పూల్ లాగా ఉండదు. What is this sign? Quick. You can see the clue is the enlarged heart border. So whenever you see enlarged heart border and such a lesion, that is the phantom tumor. That is the fluid in the ట్రాన్స్వర్స్ ఫిషర్ డిజపియర్స్. దానికి సీటీలు కొట్టేసి ఎఫ్ఎన్ఎస్ కొట్టేసి బ్రోంకోస్కోపులు చేసేకండి. ఫ్యాంటమ్ ట్యూమర్, అనదర్ కార్డియోమెగాలీ, అనదర్ ఫ్యాంటమ్ ట్యూమర్, అనదర్ కార్డియోమెగాలీ, అనదర్ ఫ్యాంటల్ ట్యూమర్. వాట్ ఇస్ దిస్ సైన్? థైమిక్ సైల్ సైన్. దిస్ ఇస్ మిడాస్టనం. న్యూమోమిడాస్టనంలో వాట్ ఇస్ దిస్ సైన్? This is called spinnaker sail sign. ఇది స్పిన్నాకర్ సైల్ అంటే ఐ థింక్ ఇట్ ఇస్ సంథింగ్ లైక్ రివర్స్ స్పిన్నాకర్ సైల్ సైన్ అనమాట. ఐ డోంట్ నో వై దే డిడ్ంట్ నేమ్ ఇట్. యూ కెన్ సీ దాంట్లో రివర్స్ లాగా ఉంటుంది. పెద్ద ఏదో పేర్లు చెప్పారు కనుక మీరు నేర్చుకోవడం తప్ప పెద్ద ఇంపార్టెన్స్. వాట్ ఈస్ ఇంపార్టెంట్ ఈస్ టు రికగ్నైజ్ దట్ న్యూమోమిడాస్టనం. అగైన్ చిన్న పిలకల్లాగా ఉన్నాయి కదా, దిస్ ఈజ్ ఆల్సో స్పిన్నాకర్ సైన్. What is this sign? This is a mediastinal tumor. Mediastinal tumor అంటే ఏంటి? ఎక్స్ట్రా ప్లూరల్ tumor, because mediastinum is extra pleural. You can see the tapering margin, but ఇక్కడ కొంచెం వేవీ ప్యాటర్న్ ఉంది. This is the thymic wave sign. What is this most important sign? ఒక్కళ్ళు కూడా చెప్పలేదు. ICU patient, ఎండోట్రకియల్ ట్యూబ్ ఉంది. ఎనీ ఐసీయూ పేషెంట్ మన ఎక్స్రే తీయంగానే చూడాల్సింది ట్యూబ్ కరెక్ట్గా ఉందా, ఆ కఫ్ సరిగ్గా ఎలివేట్ అయ్యిందా, బాగా ట్రాన్స్లూసెన్సీ ఉందా, లేకపోతే నా డీప్ సల్కస్ సైన్ ఉందా. This is the deep sulcus sign. You can see the translucency here. The sulcus is deeper than that one. So what is the importance of deep sulcus sign? So normally ఏమవుతుందంటే, see in the erect position the minimal amount of air goes to the apex, whereas here this is the most non-dependent part, it will go there అన్నమాట. So that is the deep sulcus sign. Now if you don't recognize it, what happens is this will be the result, same patient. ఎందుకంటే ఎక్కువగా డయాఫ్రామ్స్ విల్ గో డౌన్ బికాస్ ఆఫ్ ద పీప్, లంగ్స్ విల్ నాట్ కొలాప్స్. అందుకనే ద బర్డెన్ ఈజ్ ఆన్ ద డయాఫ్రామ్స్. అగైన్ వెరీ సటిల్ డీప్ సల్కస్ సైన్. ఐదర్ యూ కెన్ డూ ద అల్ట్రాసౌండ్ ఇన్ ద ఐసియు ఆర్ యూ కెన్ టేక్ అదర్ సైడ్ డీప్. చూడంగానే ఏంటంటే దెన్ యూ షుడ్ అడ్జస్ట్ యువర్ పీప్స్ అండ్ లుక్ అట్ ద పీక్ ప్రెషర్స్ అండ్ కీప్ రెడీ the intercostal tube set ready. So if it is something like that, then you can put a tube. Never put a needle. Now what is the lesion? And ekkadaina aap cheyachu meeru. Hello, ekkadaina you can stop it. Okay, what is the lesion? This is the తెల్లగా గోడకి సున్నం వేసినట్టుంది కదండి, పల్మనరీ ఆల్వియలార్ మైక్రోలిథియాసిస్. సో దిస్ ఇస్ ద డీప్ బ్లాక్ ప్లూరల్ సైన్. అనదర్ సైన్ ఈజ్ శాండ్ స్టాంప్ సైన్ అంటారు. బ్లాక్ ప్లూరల్ సైన్, శాండ్ స్టాంప్ సైన్. దిస్ ఇస్ ద కంటిన్యూస్ డయాఫ్రామ్ సైన్ with bilateral pneumothorax and continuous diaphragm sign. Another continuous diaphragm sign. This is ఏంటండి అది? ఏమన్నా ఎక్స్రే చూడరా? మేమైతే బుక్స్లో ఎత్తుకోవాల్సి వచ్చేది రేడియాలజీ. ఇప్పుడు ఇఫ్ యూ బ్రౌజ్ ద యూట్యూబ్ అన్నీ కనబడతాయి. నేనేమేమి ఇష్టం. యూ టేక్ ఎ సిటీ ఆల్వేస్, ఇట్ డజంట్ మ్యాటర్, యూ గెట్ సంథింగ్ అవుట్ ఆఫ్ ఇట్. చిలాడిటీ సైన్. ముందు అబ్నార్మల్ ఉందని తెలుసుకోవాలి కదా. ఇది ఇంటర్పొజిషన్ ఆఫ్ ద కోలన్ బిట్వీన్ ద డయాఫ్రామ్ అండ్ దిస్ థింగ్. దిస్ ఇస్ నార్మల్. ఇది ఎవరన్నా చెప్పండి. దిస్ ఇస్ స్పాటర్. ఎనీబడి? లేచి నుంచి చెప్పమ్మా. ఏదో చెప్పు, తప్పు చెప్తే ఏంటి నష్టం, నాకు అర్థం కాదు. బయటికి గంటారు కదా. ఇక్కడ త్రీ ఇంపార్టెంట్ ఫైండింగ్స్. ద రైట్ డోమ్ ఇస్ ఎలివేటెడ్, హార్ట్ కొంచెం డెక్స్ట్రా పొజిషన్లోకి వెళ్ళింది, అండ్ ద మిడిల్ బార్డర్ ఆఫ్ ద మిడిల్ కార్డియాక్ బార్డర్ ఈజ్ ఆబ్లిటరేటెడ్. ఈ మూడు ఫైండింగ్స్ ఉన్నప్పుడు యూ షుడ్ లుక్ ఫర్ ఎ సిమిటార్ వెసల్. అన్నిట్లో ఉంటుంది. రైట్ డోమ్ ఈజ్ ఉంది, ఇది కొంచెం షిఫ్ట్ అయ్యింది. యూ కెన్ సీ హియర్ ద రైట్ కార్డియాక్ బార్డర్ ఈజ్ ఆబ్లిటరేటెడ్. దిస్ ఇస్ ద సిమిటార్ వెసల్. ఈ కాంబినేషన్ ఉంటే యూ షుడ్ ఆల్వేస్ లుక్ ఫర్ దట్ ఈస్ ఎ స్పాటర్ అంతే. Again you can see the right dome is elevated, heart is shifted, right cardiac border is obliterated. This is the scimitar vessel. Again another one child, the right dome is elevated, there is no artery shifted, dexter position, there is a cardiac border is obliterated, you can see the scimitar vessels. What is this sign? Asbestosis, pleural plaques, diaphragmatic plaques, holy leaf sign. ఇది కూడా అంతే, you can see. What is this? మర్చిపోయి ఉంటారు, మళ్ళీ వస్తాయి, మళ్ళీ వస్తాయి. ఇప్పుడు ఎండిఆర్ టీబీ పెరుగుతున్న కొద్దీ ఇది థొరకోప్లాస్టీ. This is plumbage, not necrotizing pneumonia. ఇవన్నీ మళ్ళీ చూస్తాం. Last one. So whenever you see an elevated dome-like thing, always look for the hepatic flexure. This is the hepatic flexure underlying the inferior part of the liver, almost at the level of the other side. This is because the whole of the liver is elevated. So this is the right-sided eventration. It's quite common in Vizag, I don't know here. Or sometimes it can be diaphragmatic paralysis. I will show another X-ray. Again, you can see the hepatic flexure there. The whole dome is elevated. Again, child hepatic flexure at the level of the. This is the eventration. Whereas the infrapulmonary effusion, you don't see the hepatic flexure. In an amoebic liver abscess, you don't see the hepatic flexure. This is the right upper lobe emphysema. This is the Poland syndrome. Okay, thank you very much. Thank you very much, Vishwanath, for giving me extra time.
Thank you very much, sir, for your very excellent and informative talk. The talk was not only informative for the PGs, but also for us also. Any questions from the PGs?
మీరేం ఆన్సర్ చేయనప్పుడు యూ డోంట్ హ్యావ్ ఎనీ రైట్ టు క్వశ్చన్.
You made it so humorous, sir, actually.
గోపాలకృష్ణ.
Any questions to sir? Anything which you want to ask regarding X-ray? Yeah, thank you very much, sir.
So,
Do we have Dr. Abhishek online for the? Or can we start up with this talk?
Yes,
Dr. Abhishek, good morning.
hello. Good morning, Dr. Vishwanath. Thank you. Do I have to present or you can run my video which I sent yesterday?
You've already seeing your re-recording of.
Okay, fine. So I will be there online. You can run the video. I will be here for questions.
We have already completed seeing that. We have completed seeing that video.
Okay, sorry. So if there are any questions, then I will be happy to answer.
Thank you, sir. So, Abhishek, your talk was very good. Actually, there were some very informative points. Actually, you have made some important points, like especially in the control of blood pressure, manual CPAP scores better over the autopap, and again in autonomic disturbances. Again, you have showed that the data is strong for manual CPAP, fixed pressure CPAP compared to the.
Dr. Vishnu, I won't say data is very strong to favor fixed pressure over auto CPAP. Actually, there are very few studies. Those were the only studies which are available to which compared auto CPAP versus manual CPAP. So we have a dearth of data. We don't have any strong data to support fixed pressure over auto CPAP or auto CPAP over fixed CPAP. So the current school of thought is that probably fixed pressure CPAP is better than auto CPAP, but there are few studies going on. We are also conducting a study on the same lines in which we are randomizing people to manual CPAP and auto CPAP to see the effect on ABPM and as well as autonomic function testing. So, but the data is not very supportive to favor fixed pressure CPAP. But this thing is for sure that auto CPAP is definitely not better than fixed pressure CPAP. It is only convenient for us. That is the only reason it is being prescribed.
So, what is the important message you want to give to the PGs? Because I know you have covered it in your topic actually, but since it's an important topic and we keep seeing a lot of young doctors writing that, even senior most also just write auto CPAP and forget about that actually. They don't follow that patient and then they don't check whether the AHI is getting controlled or not. There are some of the things which I wanted you to specifically tell the PGs actually. When they get in compliance report after CPAP, what all they should see and then what all they should correct after checking the report, compliance report.
So I would like to just say one thing, that there are other fields in pulmonary apart from interventional pulmonary also, so which needs your attention. Just like intervention pulmonary is probably the most glamorous part of pulmonology, But there are other fields like thoracic oncology, pulmonary vascular diseases, sleep medicine. There are other fields which needs your attention. Sleep medicine is just not giving a level 3 PhD and writing a auto CPAP. It is whole a different field altogether, which needs at least 6 months to 12 months of training. So, if you're really interested, you should go to a center where PhDs are being done, and then you should learn over there. This field is still in an infancy. It is the work is still going on. In most of the centers, we don't have manual labs. Manual scoring is not being done. But that is one thing that should be learned from most of the postgraduate students. And if you don't have a level 1 PhD in your facility, the only thing which you can do is do a level 3 PhD and then prescribe an auto CPAP. But you should follow your patient. If patient is not improving with auto CPAP, then you should refer this patient to a facility where manual titration can be done. Because in my experience, I have experience of more than 2,000 clinical patients. Apart from the research, I have experience of around 2,000 patients, and I have seen that in Indian settings, auto CPAP works in 70% of our subjects, and rest you have to either give a BiPAP, either you have to give a position therapy. And if you are talking about only auto CPAP, it won't work more than 70% of your patient. In 70%, yes, it will work. It is a good machine. It is a good alternative when you don't have a level 1 PhD. But you should be vigilant that if patient is not improving, that is the time where you should refer this patient. Just like when you see a mediastinal lymph node, you refer that patient for a e-burst. Just similarly, you have to refer a patient if your patient is not improving on auto CPAP.
Dr. Vinay has a question, please.
Good morning, sir. In high BMI, which one will you advise, sir? Is it auto CPAP or manual CPAP, sir, or BiPAP, auto BiPAP?
I won't, since I have the facility of manual titration, I will definitely start with the manual titration in a patient with a BMI of 35 or more. Most of these patients who have high BMI, they usually require a BiPAP. So now we have also auto BiPAP and BiPAP. So since we have seen that auto CPAP is not better than CPAP, it is only convenient. But if you are patient, if you don't have the facility of manual titration, the only thing which you can prescribe is auto CPAP. Patient will definitely have some benefit, but that benefit is optimal or suboptimal that you can see only in a lab. So the practical thing is give a auto CPAP if you don't have a level 1 PhD, and if after 2 weeks patient is not improving, then you should have a manual titration before prescribing that patient a auto BiPAP or a manual CPAP. That is the practical thing.
In REM predominant OSA, sir, which one will you advise, sir, in REM predominant?
So if REM predominant OSA, there is a significant difference in AHI, then if you have done manual titration, that should be sufficient. But if you have not done manual titration, then auto CPAP can be easily prescribed. For positional OSA also, suppose in supine position, the AHI is significantly high, say is in 40s, 50s, and in lateral position, it is around 20s, 30s. So the CPAP pressure requirement in supine position will be significantly higher than in lateral position. In those cases, auto CPAP will be better. So, as I said, most of your patients, 2/3 of your patients, auto CPAP will work. But in 1/3, you have to be vigilant whether it is working or not. And most of your patients, if they are being referred from cardiology, obviously you cannot do a level 3 PhD. If they are having some arrhythmia, heart failure, any cardiovascular complication, any CVA history, any COPD, most of our patients will have some associated comorbidities. And with associated comorbidities, level 3 PhD should not be given, and auto CPAP is contraindicated. So you should be, but I see many patients who are being referred to us that auto CPAP is not working. The main reason is they were given auto CPAP in the wrong indication. If you choose your patient correctly, then most of your patients will improve with auto CPAP. That is another question whether auto CPAP is better than manual CPAP or not. It is definitely not better. Manual CPAP is probably more useful than a auto CPAP, but it is very difficult in a country like ours where we have dearth of resources to totally rely on full lab titrations. But if your patients are not improving, as I said, they should be referred.
Thank you.
Sir, I have one question. I'm Dr. Deepika. So, what would be your choice of preference? Would it be manual CPAP or CPAP for someone requiring very high pressures, especially more than 10 or 12? Because in terms of comfort, patient wouldn't be very comfortable if they require very high pressures. So
So Dr.
would you
Deepika, 10 or 12 is not a high pressure.
more than
Most of our
Please.
patients usually settle with pressures more than 10. And it
Okay.
was also shown in one of the studies from Europe that the median pressure in their settings was around 10. But I will say the median pressure in our lab was around 14 to 15. Most of our patients usually required pressures more than 12. And 20% of our patients required bypass.
So-
That is the data we have from our lab.
Okay, thank you.
Sir, how do you deal with the patients with claustrophobia?
So suppose a patient we do manual titration in all our patients. I do not prescribe autoseo because I have the luxury of having 4 labs. So if a patient during night we find that patient is having severe OSA, we start titration and we give them option of manual mask, nasal mask, and if patient is not comfortable, mouth leads there, then we apply full face mask. Even then, if some patients are not comfortable, then what we do is in the following few days, we ask them to come during day. Then we consult them. Then we apply the mask during day for few hours. Then we ask them to lie down in our lab during day. So that removes most of their claustrophobia because it is basically the hesitance, the inertia to use a foreign body on their foreign body on their faces throughout their life. That inertia is there in many subjects. But we counsel all these patients before the sleep study that they will require this kind of a device and which they have to use throughout their life. And only those patients who are willing, only those patients we are giving dates because we have a long waiting in spite of having 4 labs.
Yeah, very practical point actually, Abhishek. Actually, this is what we have started doing actually. When people are hesitant to start CPAP, we are just asking them to go to sleep lab in the daytime. Just keep it on for some time and then use it actually, so that their hesitancy goes away. Even when given machine to them, when they take, especially when they don't want to buy a machine, a rental machine and a new mask, and then we ask them to wear on for some time in the morning, daytime, so that they get habituated to that, to remove the hesitancy.
Yes.
That's what we are doing that actually. That's a very
That is very practical thing to do. And nowadays in daytime also we are doing our sleep studies because we have a waiting list. So most of the time we have 1 or 2 patients during day in which we are doing something like this. This is called tap nap therapy, or we are doing split day studies. So our lab is busy throughout day, throughout night.
It's a last question, sir. How will you decide the nasal mask or face mask, sir?
So most of our patients should be given a nasal mask first. And if your patient pressure requirement is very high, and that pressure requirement usually when you have to shift to a full face mask is around 16, 17 of CPAP. But usually if leakage is not high, then you can continue on BiPAP on nasal mask also. Although most of the patients who require BiPAP titration will shift, in reality we have to shift to a full face mask. So always start with a nasal mask. If patient is not comfortable, which happens because patient is having significant mouth leak, then we have to shift to a full face mask. But most of our patients, nasal masks will be sufficient. If patient's pressure requirement is very high, then full face has to be given. But it is a dictum that we have to start with a nasal mask. Don't say that if patient is having patient is a mouth breather, then I will start with a full face mask, because all these mouth breathers are breathing through mouth because they're having that is the area of least resistance to breathe through mouth. Whenever we apply a nasal mask, most of the patients who are mouth breather will start taking normal breath through their nose, and leakage is not a significant problem. Some patients who are having significant central sleep apnea, who are very obese, who are edentulous, in those patients, sometimes we have difficulty in titration. Otherwise, most of the patients are settled with nasal, and I will say 20-30% settled with the full face mask. The problem is is in edentulous patient, and in those we have started doing titration after applying their dentures, because that decreases the leak.
And thank you very much for coming, Abhishek. Sunday morning, I know how difficult whole week you've been working very hard, and then Sunday we usually like to take rest and get up a little later. And thank you very much.
No, I was on vacations, so that's why I couldn't. I was at my parents' home. Thank you, Dr. Vishwanath, for having me there.
Yeah.
Next time I would like to be there in person. Thank you so
Sure,
much.
definitely. Thank you very much. And we move on to the any other questions? If none, then we are moving on to the next talk. Thank you.
So now I invite our next speaker, Dr. M.S. Gopalakrishna sir. He's a consultant interventional pulmonologist at AIG Hospital, Vijayawada, and has got the prestigious Dr. Premanand's Young Scientist Award for the year 2019 for the innovative technique, the role of closed wound suture drain as an indwelling pleural catheter for the management of recurrent pleural effusion. So now we'll be speaking about the same.
Thank you, Gautam, for nice introduction. Good morning, students. My talk is like indigenous Indian IPC. Before going into the IPC, like Indian version, so we should know what is the conventional IPC and what are the indications of IPC in our setup. So I'm going to discuss about like what are the different various causes of recurrent pleural effusions, what are the treatment options available, and what is the role of IPC for management of recurrent pleural effusion. Do we have any alternatives? And what is this surgical drain and how it is useful? These are the things I am going to cover now. Coming to the definition of recurrent pleural effusion that recur despite optimal therapy for the underlying etiology of effusion and typically require multiple thoracensis are a more definitive therapeutic modality to prevent recurrence. So if you look into the different causes, like various causes of recurrent pleural effusion, the most common cause is like malignancy, followed by heart failure, hepatic hydrothorax, chronic lung and pleural infections, inflammatory and autoimmune diseases, post-CABG pleural effusions, and chylothorax. What are the treatment options for recurrent pleural effusion? Usually we'll do first thing is thoracentesis. So commonly we'll go with the thoracentesis. Suppose patient is requiring more thoracentesis, then it depends on the situation. Either you will choose the intercostal drain plus or minus talc fluorodesis, then medical or surgical thoracoscopy and talc powders, and pleurectomy, especially for malignant conditions, and finally indwelling pleural catheter. Coming to the indwelling pleural catheter, so the indwelling pleural catheter is usually made up of a silicone material, which will have a one-way valve at the distal end, and it will have multiple fenestrations in the proximal portion. So it is made up of silicone elastomer, and it will have a small polyester cuff in the center portion of the catheter. The advantage of this polyester cuff is like it will prevent dislodgement of the tube, and at the same time it will form fibrosis. So the retrograde spread of infection will be prevented. And the one-way valve of the pleural, this is the conventional pleural catheter, commonly we use for pleural tunneling. So this will have a one-way valve here, you can see. So this one-way valve will prevent the retrograde entry of the air and fluid into the thoracic cavity. So thereby it will reduce the chance of infection. That is the advantage of one-way valve. And usually these conventional pleural catheters will be available as a kit. So that kit will contain everything. You need not purchase anything separately. So the kit will contain a trocar, needle, guide wire, and insertion sheath. And usually the companies will give 4 to 5 vacuum containers at free of cost. And commonly we'll use the Pleurex catheter here, and other materials like Aspira, Ratchet. There are many Pleurex catheters are available in the market. And this is the video how we'll do the Pleurex catheter. This is the conventional Pleurex catheter, what I am showing here. Sorry. So the technique is very simple. It's like your conventional intercostal drain, but what you have to do is like do a ultrasound before doing the procedure to confirm the site, and you have to look for the loculations, and you need to make the entry point and the exit point. Usually we'll make the entry point in the mid-axillary line, either 4th or 5th space, depend upon the loculation or the site of effusion, and the exit port will be on the anterior axillary line, that is 4 to 5 centimeters away from the entry port. So once we made the ports, then what we'll do, then we'll confirm the fluid level with needle and just do aspiration and confirm. Then later we'll make the incisions like 0.5 centimeters for entry and as well as exit ports. There is a slight difference between conventional Plurex catheter and our procedure. Here we need to introduce the tube through the exit port first, followed by the entry port. But in our procedure, the procedure is little bit different that I can show you later. So usually we'll follow the Seldinger's technique for conventional pleural catheter insertion. So what I am doing, so I confirm the fluid site and then I inserted the catheter. Now I am dilating the entry port with the trocar, and the trocar will have the insertion catheter also. So you can see the guide wire is coming out with the trocar, and the insertion catheter will remain there in the chest cavity. Now I am pushing the catheter into the chest wall. So the green one is the insertion catheter. So that can be peeled off nicely. So just you pull it and it will tear, and it will, you can nicely, it will, you can pull it, you can pull out the insertion catheter. So the catheter is going into the pleural cavity now. With your fingers, you can push the catheter inside. Then we'll make like 1 or 2 sutures to close that wounds, and the exit port wound will be closed with tube anchoring sutures. The advantages of conventional IPC are, like, it is very simple to insert. It's a day care procedure, and it will give 100% symptomatic relief, and definitely it will improve the quality of life, and the failure rate was very, very low, and it's better tolerance. And also you have to look for the complications of IPC. The most common complications of IPC are IPC related pleural effusion. Usually if you do the procedure in unsterile settings, the chance of thoracic cavity infection rate is very, very high. Then catheter tract metastasis commonly we'll see with either adenocarcinomas or with mesotheliomas. Sometimes because the catheter will induce some amount of inflammation in the pleural cavity, so it will form loculations. So adhesions will lead to loculations. So you need to place the drain, or you need to reinsert the catheter at the loculation site. That is another complication. While removing the catheter, sometimes the catheter may get fractured, and you need to open the or you have to do a VATS to remove that catheter sometimes. Catheter blockage is the common complication of pleural catheter, because the small bore of these catheters, usually it will get clogged with the debris, especially if you are using this catheter for infections. Chest pain is okay, but we can manage with analgesics. And the most important thing is the cost, because like India is like, as a developing country, many of the our patients may not afford the conventional pleural catheters, because which may cost around 35 to 40,000. That is the inhibiting factor for IPC. So when I started doing these IPCs, whenever I recommend IPC, either it will be refused by the patient or it will be refused by the oncologist, because most of our IPC indications are for malignancy. So because of the cost factor, so don't want, there are many like attenders or other like family members, they don't want to spend that much amount for the terminally ill patients. So that is the reason just we came with this idea. So actually this idea was given my surgeon friend. So when I started discussing, then he advised this surgical drain. So he told me that why can't you use this surgical drain as a pleural tunneling catheter, because this surgical drain is very economical. It will come with trocar and all connectors, everything will be there as a set, and it's very, very economical. So we can do tunneling like our regular Plurex catheters. So based on his idea, then we started doing using this drain. So prospectively, then we started this procedure 5-6 years back, and to prove that the efficacy of this catheter, the aim of this study was to prove that the surgical catheter is having definitive role in management of recurrent pleural effusions. So we chose 14 and 16 French catheters, because these catheters is available in different sizes. So you can get it like 6, 8, 10, 12, 14, 16. So the maximum size is 16. So you can use, because we choose 14 and 16 because the wide bore, and we can fix that three-way cannula, the wide three-way cannula that I can explain later. Smaller catheters, we cannot fix this three-way cannula, but for 14 and 16, we can fix that three-way cannula. That is the advantage. So we choose this 14 and 16 French catheters. And all these pleural surgical drains, we placed it, subcutaneous tunneling was done and it fixed in the pleural cavity. And every patient after procedure, we explain to the patient and family how to manage that catheter. Suppose if they cannot understand, we call them like weekly once or weekly twice, depends upon the accumulation of fluid. So we used to tap the fluid in the hospital setting. Suppose patient is well educated and they can able to handle, they can do the aspiration procedure at their home. So for every procedure, we need to have a checklist. So like that, we did for every procedure, chest X-ray and CT mandatory, and bedside ultrasound for confirmation of the fluid and as well as the diaphragm level. And based on ultrasound, we'll make the entry and exit ports marking. Commonly entry port in the posterior axillary line and or mid axillary line, and exit port on the anterior axillary line. Under strict aseptic precautions and with the lignocaine local anesthesia, we did all the procedures, and prophylactic antibiotic was given for all the patients, and analgesias like simple paracetamol or tramadol is enough for management of pain. So these are the things we need for this surgical drain. So the surgical drain will contain a two sets of catheters, that is the same size of two catheters will give, and one trocar, that this trocar will have a very sharp edge. You should be very careful. And we need to have one three-way cannula with extension. Why this three-way cannula means? Because this catheter will not have that one-way wall system. So to prevent a retrograde entry of air and fluid, so we'll use this three-way cannula as a safety mechanism. So whenever the procedure is not done, or you just close the cannula, the air will not go inside. And every procedure will do the bedside ultrasound before doing the procedure to confirm the fluid level and loculations. These are the steps of closed wound surgical drain. So we'll make the two incisions like 0.5 centimeters incision for entry and exit port. And for entry port, the technique here it is different, because here we don't have that trocar and insertion catheter and guide wires and all. So you need to insert this drain like our regular ICD. Just dilate the intercostal spaces with your straight artery trocar and insert the catheter like your intercostal drain. Once after the entry port has done, then the remaining portion of the catheter will go into the subcutaneous planes with the sharp trocar. So this is how we'll do. So here I am making the entry port. Now you can see after dilatation, I am inserting the catheter into the pleural cavity. So I made a small opening in the pleura. So the catheter is going into the pleural cavity. And now I am making the tunnel in the subcutaneous layers. So the catheter is going into the subcutaneous layers and it will come out through the exit port. Four to 5 centimeters tunneling is enough, so that can prevent further spread of infection and dislodgement of the catheter. These are the basic steps, and this is how the wound looks like after the procedure. So the band-aid portion is the entry port, and here the catheter is coming out, and we'll use the tegoderm to protect the catheter. And the three-way cannula is fixed to the catheter. So this three-way will prevent further spread of infection and as well as like entry of air into the thoracic cavity. And this is how we'll drain the fluid. You can use a syringe or you can use your ICD bag, so you can connect to the catheter. And because this is a radio opaque material, so you can be seen this catheter in an X-rays also. These are the different catheters. You can see this is the right pleural catheter for hydrothorax. This is for another recurrent pleural effusion. And here you can see the left pleural catheter. This is the one more catheter. Actually, this is a different case. So this is a post-pneumonectomy air leak. The patient underwent many procedures to prevent air leak, but everything failed. So finally, he came with pus discharge. So you can see that because of pneumonectomy, the entire ribs on the right side got crowded. We don't have space in the axilla portion, like infraaxillary area. So what we did here, we placed the pleural catheter in the second intercostal space mid-clavicular line. And the exit port we made just above the nipple. And you can see the catheter is here. So the catheter is going into the pleural cavity in the second space and it's coming out here. So total we use this catheter in 52 patients. Among these 38 are male and 14 are females. And if you look into the etiology, 34 patients are having malignant effusion and 14 are having hepatic hydrothorax and 3 are chronic tuberculosis patients and 1 is chylothorax. In our study, the catheter in situ days was average in situ days were 381. The least catheter in situ days were 8. The mean duration is 46. And we observed a symptomatic relief in all our patients, and we achieved pleurodesis in 28 patients, that is 54%. And the catheter was, we can able to remove the catheter in 28 patients after successful pleurodesis, because these catheters can induce inflammation, so it will cause pleurodesis itself. Or you can use the same catheter for pleurodesis. So you can give a pleurodesis like talc, powders, or like talc slurry or any other chemical substance through this catheter to induce the pleurodesis. That is the advantage of pleural catheters. And we lost follow-up in 3 patients and mortality due to terminal malignancy in 17 patients. And complications we observed in our study, like pain is the most common complication, but it can be managed very easily with simple analgesics. Catheter clogging was seen in 11 patients. Among these, 2 patients needed tube replacement. And remaining patients just we can able to manage with saline flush, and some patients required a streptokinase injection to clear the debris. Infection rate in our study was just 3.8%. Catheter clogging was seen in especially infection patients, like TB patients we placed for 3 cases and 2 patients came with tube block because of the debris. And in malignancy, 9 patients had tube block. And if you look at the cost comparison, the regular conventional IPC may cost around 30 to 40,000, whereas the surgical drain may cost around 1,500. That is the advantage of the surgical drain. And finally, we compared the study with the large data available, which was published in the BMC Pulmonary Medicine. It's a retrospective trial. Retrospective study was done from 2006 to 16 on 395 patients, and the total number of procedures included in this trial was 448. So just we compared our data with their data. It's almost similar with our results. So in their study, the median length of stay was 36 days. In our study, that is 46. And we also compared the conventional IPC of our experience with our own surgical drain. So conventional IPC, so we did in 12 patients and surgical drain in 52. And if you look at the median length of stay, this is 52, here it is 46. And symptom relief is almost same. And pleurodesis was achieved in more than 50% in both trials. And infection rate was comparatively very less, 3.18. And we didn't see any like major infections like empyema and all. Catheter clogging was seen in 11 patients in our trial. And finally, we published this data in WABIB 2022 at Marche. And the same data was published in the year 2019 APSOCON, that is our AP state conference. And for that, just I awarded the best paper presentation. The conclusion: the closed wound small bore surgical drain is economical, effective, and well tolerated, and it can be used in lieu of IPC in low cost settings. I'm grateful if you have any doubts or.
Yeah, that was a wonderful talk, Gopal, and
Thank you.
congratulations. It's a very low cost and very important technique which can be followed at any kind of setting actually, without the constant for constant. Any medical college, I think they can use this, and it's going to be very definitely useful for our patients, especially in recurrent effusions. Sometimes, other than malignancies, we see other
Yes.
other indications of recurrent pleural effusions as well. Actually, these kind of settings. Any questions from the audience?
When I started, like the first case we tried for hepatic hydrothorax. So Initially, it was refused by our medical gastroenterologist. They thought like it will cause more infections, and they're a little bit worried. Then once I started doing, then they started referring like we need to put this drain for hepatic hydrothorax.
I think in our institute we have a lot of cases of hepatic hydrothorax. This is one important feedback which you have given. Thank you. Anybody else using IPC in their hospitals for treatment of recurrent effusions? So this would probably, if you're using it, you should also try to do this actually. The Indian one, maybe reduce the cost and see. 40,000 and 1,500 is significantly different, I think. Significant p-value is very significant.
No, I cannot recommend for everyone. Like those who are not affordable, like economically backward, or medical college, like very few.
No, why can't it be recommended for everyone? Is there any
Because,
drawback why we
like,
cannot recommend?
conventional IPCs will have definitely more advantage than this surgical drain, because that all the safety features will be there in conventional IPC. That one-way wall, that because this is made up with silicon catheter. This is the PVC material. That is the silicon one. So we know that like silicon will have the long durability and less chance of infections risk, but PVC will have some disadvantages. So those who cannot afford, those patients we can try.
Maybe we should collaborate with any IITs or any other Indian institutes and try to make it better actually, this model, so that we can make it available for our patients at a lesser cost. And any question from you, Arjun? And if there are none, then we move on to the
Thank you.
next talk. For the next talk, we have Dr. Ashfaq Hassan. I have the pleasure of inviting him for this talk. Dr. Ashfaq Hassan is a professor and head of department at Deccan College of Medical Sciences, Hyderabad, and he has been a chief editor for the Journal of Medical and Allied Sciences. He has numerous papers, more than 70 papers, and they were cited more than 400 times. And he has written two important books, ABG and on mechanical ventilation. Those of you who have not read this should definitely go through both books, ABG and mechanical ventilation. They have been explained in such a simplified manner. The concepts have been explained very well. And if you read both of these books, then you will be very confident in treating any kind of critical patients. And with this brief introduction, I invite sir to deliver his talk on the ABG made simplified.
Thank you very much, Vishwanath. And good morning to all the PGs. Unfortunately, for the last couple of years, I've had very little contact with postgraduate teaching, but I think you have said it right.
Thank you.
This is, although it's called the interpretation of, simplified interpretation of arterial blood gases, it's hardly simple. And it's very difficult to teach as a matter of fact. But I will, for constraints of time, I will not be going into the details of the calculations, which you will have to kind of look up yourselves. But I'll try to make it as simple as possible for everyone. Now, the thing is that pattern recognition is very important in clinical medicine, because we all instinctively diagnose things. We do our inductive thinking by just looking at certain patterns. This is the clinical presentation, and therefore the diagnosis must be this. It's very intuitive after a particular time, and we get trained in this particular manner. But it's extremely important to understand that before you interpret the ABG itself, you have to look at the clinical scenario and the clinical context. Because unfortunately, most of our interpretations are based on our clinical knowledge, and we need to understand wherever you open a textbook, see the causes of metabolic acidosis, alkalosis, respiratory acidosis, respiratory alkalosis, etc. But you need to also understand that if a person comes with vomiting, for example, or diarrhea, or diuretic therapy, or cirrhosis, or renal failure, or whatever, what are the acid-base disorders that are possible, and particularly if any mixed acid-base disorders are possible. So I will not have time to go into all this. Please pick up a book and read that. If you do not make your clinical correlation at the beginning and at the end, this is the kind of diagnosis we might land up with. So a quick word about, before starting the ABG, you need to understand whether the sample that you are presented with is internally consistent. And actually what I will do is, I will not address this now, but if I finish a couple of minutes before time, then I will get back to this, and maybe you can understand that. But once you determine the ABG to be clinically consistent and clinically valid, then they actually tell a story. I remember one of the first ABGs that I was presented with. I mean, somebody taught me as an undergraduate and a postgraduate, and he unraveled the story of a person who went to took an alcoholic drink, fell down, developed aspiration pneumonia, and so on and so forth. It was absolutely fascinating. But again, like I said, you have to have your basics right. So the first step starts with, is the pH acidemic or it's alkalemic? And we all always know that 7.4 is roughly the cutoff for that. And what is basically the dominant acid-base disorder? Is it respiratory or metabolic? That is the first step to understand what is exactly happening. In case there is acidemia, then you need to look at the bicarbonate. Is the bicarbonate low? In the presence of acidemia in a low bicarbonate, it tells you that there is a metabolic acidosis. In the presence of a high carbon dioxide, it tells you there is respiratory acidosis. Similarly, the alkalemia, if there's alkalemia and the bicarbonate is high, it tells you that there's metabolic alkalosis. And if the carbon dioxide is low, it tells you that there is respiratory alkalosis. So this is something that, I can't keep on reinforcing again and again, but you have to understand. But low, obviously, in any situation where you already find that there is a metabolic or a respiratory disorder, the rule of the thumb is a low carbon dioxide means a respiratory alkalosis, high carbon dioxide means a respiratory acidosis, low bicarbonate means a metabolic acidosis, high bicarbonate means a metabolic alkalosis. So these are some of the basic rules that you have to understand. And there are compensatory formulas. There are formulas that tell you whether there is something that is going on. I don't like to call it compensation, but you can easily uncover a coexisting second disorder when you apply these formulas. And although it is extremely difficult and challenging to remember these formulas initially, you can make flashcards, carry them in your pocket or even on your smartphone, and it will be extremely good ready reckoner for you when you can go into the wards. But let's try to make things easier for ourselves now. The two to three things first before we jump into it. The first thing is the calculation of the anion gap in a situation of metabolic acidosis. Normally it's about 12. Today the automated machines are calculating a lower anion gap because of the chloride values, and even a 10 is accepted to be normal. And if you take the potassium into cognizance, then you can take it as around 16. However, there is a confidence interval here. If you, for example, have an anion gap with about 17 or 18, then you can easily diagnose with confidence a wide anion gap metabolic acidosis. You also need to remember, again, I'm not going to go into that if you have hypoalbuminemia, for example, severe hypoalbuminemia can tamper with the interpretation of the anion gap, and you have to take it under cognizance. The second gap is the bicarbonate gap. It's also called the delta gap, delta gap, and deviation from the 1:1 correction. In wide anionic gap metabolic acidosis, it is principally the decrease in the bicarbonate that accounts for the increase in the anion gap. If the decrease in the bicarbonate is disproportionate to the decrease in the anion gap, this implies the presence of an additional acid-base disorder. So you are already having a situation of metabolic acidosis, for instance, and then you calculate the delta ratio or the bicarbonate gap. If your bicarbonate gap is more than 6, then there is an associated metabolic alkalosis. If it is less than 6, or rather minus 6, I should say more than +6, there is an associated metabolic alkalosis. If it is less than -6, then there is an associated NAGMA, or the normal anionic gap metabolic acidosis. So you've got a metabolic acidosis to start with, and it could be that you have a normal anionic gap metabolic acidosis associated with a wide anionic gap metabolic acidosis in your patient. There are clues to the pickup of metabolic acidosis, either when your bicarbonate is low, as we just discussed, or when the serum chloride is extremely high, or when the anion gap is high. And that's all you need to remember. And of course, at the end of the day, when you make your diagnosis, you have to make an etiological diagnosis as well. And for that etiological diagnosis, you have to remember that there are only very few causes for wide anionic gap metabolic acidosis. For example, lactic acidosis, very, very common in our situation when we have our patients presenting to us with hypoxemia. We've got diabetic ketoacidosis, not so common starvation, ketoacidosis, acute renal failure, uremia, very common, and of course salicylate poisoning, which we see very, very occasionally. Normal anionic gap metabolic acidosis, again, I'm not going to go into the details, but it is possible that there could be a renal cause, like say type 2 renal tubular acidosis, or for example, gastrointestinal loss of bicarbonate, for example, in diarrhea or sometimes a small bowel fistulas, etc. Last slide, we need to understand metabolic alkalosis has different inciting factors and different perpetuating factors, but they may be the same. For example, if you have chloride depletion or potassium depletion, it might start off a metabolic alkalosis, but if you don't correct them even during the course of your treatment, then they could serve as maintenance factors. So these are some things that you need to know. And of course, as I said, in the further importance of the etiological workup lies, if you don't know exactly what is the broad cause of metabolic alkalosis, you could check the urinary sodium, and if it is low, it implies hypovolemia. If it is high, then it implies that there is euvolemia, and you have to commensurately look for a particular cause for that. I think that's enough theory. Chloride, you could also check the urinary chloride, but I think we'll take a break now. So what's needed basically is a method in the madness. And here, the further you simplify things, the better it gets for you. So what we have done is we have made an approach called the alpha 1 approach, which is the alphanumeric approach. And you have to choose one of the two tracks, which is either a metabolic track and the respiratory tract. So I'll spend a couple of minutes on this. If you believe that the person has a metabolic problem going on, then just think of the letters A, B, C, D, E. A for anion gap, B for bicarbonate gap, C for osmolar gap, which I have called as the colloid gap, D for a disorder which is associated, because there's a metabolic problem going on, we need to understand whether there's an associated respiratory disorder there. E for electrolytes in the urine, and like I said, we need to understand whether the problem lies in the bowel or the renal causes. So A, B, C, D, and E. There are formulas for the bicarbonate gap, which we have just seen. There are formulas for uncovering, and if there's a metabolic acidosis to begin with, then you apply an equation called the Winter's equation to understand what is the associated disorder. If there's a metabolic alkalosis there, you apply another formula, which I don't believe has been named by anybody else, but you apply a different correction factor. And based on that, you get the predicted carbon dioxide. If your predicted carbon dioxide is lower, if your measured carbon dioxide is lower than your predicted carbon dioxide, low carbon dioxide washout, respiratory alkalosis. If your measured carbon dioxide is more than your predicted carbon dioxide, high carbon dioxide, respiratory acidosis. So it's pretty simple. On the other hand, if the person doesn't, for example, have a metabolic problem and has a respiratory problem, then you remember the mnemonic O1 or other O.1, 0.2, 0.3, 0.4, 0.5. So O stands for oxygenation. We all are aware of the PF ratio, which we call, we divide the PaO2 by the FiO2. FiO2 is a fraction basically. You don't divide it 60%, you say 0.6 instead of 60%. So PF ratio, your AaDO2, you're all familiar with that? Yes, you ought to be, because you're all respiratory physicians. You have to be thorough with these equations. If you have made a diagnosis of, for example, if you have a respiratory problem, you calculate what is the bicarbonate, what is the expected bicarbonate. And the change in the bicarbonate is basically the change in the carbon dioxide times 1 in an acute respiratory acidosis. So basically, what is your normal bicarbonate? It's 24. So if you have a bicarbonate, which is, for example, 24. So 24 plus the change in bicarbonate is your expected bicarbonate. Correct? All right. So same. So these are formulas which we can't keep on going over and over here. You have to just make a flashcard, keep it in your pocket, and remember this. So the bicarbonate decreases by 0.2 milliequivalents for every 1 millimeter fall in carbon dioxide in acute respiratory alkalosis. So the change in bicarbonate is the change in the CO2 times 0.2. expected bicarbonate is so much. If your expected and your measured bicarbonate is high, metabolic alkalosis is associated. If your measured bicarbonate is lower than your expected bicarbonate, metabolic acidosis is associated. So remember, 0.1, 0.2, 0.3 we can ignore for the time being, 0.4, 0.5. All right, if for a particular bicarbonate, expected carbon dioxide is high, associated respiratory acidosis, low respiratory alkalosis. If for a particular carbon dioxide, expected bicarbonate is high, there is metabolic alkalosis. If it is low, there is metabolic acidosis. Okay. 82-year-old woman with diabetic ketoacidosis has been coughing and breathless for a few days, and a right lower lobe pneumonia was found at admission. pH 7.5. That is to say, it is mildly acidemic. Question is it metabolic acidosis or is it respiratory acidosis? Further refine the question, is the bicarbonate low? If you want to think it's metabolic acidosis, is the bicarbonate low? Yes, the normal bicarbonate is 25, it is actually 18. So there is a metabolic acidosis. So you apply the metabolic tract. On the other hand, is the respiratory acidosis present? Is the CO2 high? It should be 40. It is 25. It's not high. So obviously there's no respiratory process present for the time being. Now, because you have chosen the metabolic tract, go into the anion gap. I'm not going to go into the calculation of the anion gap, but you take away the sum of the chloride and the bicarbonate from the sodium, and in this case you get a anion gap of 34. Like we said, if you use only the 3 electrolytes in the absence of potassium, even a 12 can be considered as a normal anion gap. 34 is in excess of 12, and therefore the anion gap is wide. All right, you're with me? Then you go to the bicarbonate gap, and the question that is being addressed here is an associated metabolic alkalosis present? Calculate the bicarbonate gap, which is the delta ratio, and we've done that. So delta ratio is the change in the anion gap. Like I said, we've taken 12 as a normal. 34 is here. The difference between 34 and 12 minus the change in the bicarbonate. This is normal bicarbonate, and the bicarbonate here is 18. So the sum total together comes as 16. The bicarbonate gap lower than -6, higher than +6. So here it is higher than +6. That means to say there is a present metabolic alkalosis. If it had been lower than -6, it would have been a present non-normal anionic gap metabolic acidosis. So these are things you just have to remember. Then you come to the question of whether there is an associated primary respiratory problem there. Actual carbon dioxide 25. Predicted carbon dioxide, you use the formula, and again you find that there is a primary respiratory alkalosis present. Most important of all, come to the clinical correlation. So please don't get intimidated by this. You know, these numbers, these calculations, they will look a little scary at the beginning, but the more you practice in the wards, the easier it will become, and then you will not need even your calculator. I sometimes still use the calculator, but you probably don't even need it at some point. So the clinical correlation is diabetic ketoacidosis presents with a wide anionic gap metabolic acidosis. However, there is a discrepancy because the substantially widened anion gap suggests a severe metabolic acidosis, which is seemingly out of proportion to the mild depression in the serum bicarbonate. A coexisting metabolic alkalosis was suspected on the basis of this and confirmed. All right, to explain the metabolic alkalosis, because we've already explained the cause of the metabolic acidosis. Now, to explain the metabolic alkalosis, dyselectrolytemias should be looked for, and a history of concurrent diuretic use must be sought, which is quite possible in a person with comorbidities. And of course, you have a respiratory alkalosis here, respiratory alkalosis, which is consistent with the pneumonia. So you have 3 disorders, and you kind of have made that calculation. There is another way. If you want to make things simpler for yourselves, plot your bicarbonate on this axis and plot your carbon dioxide, or you can plot it with the pH also. And eventually, if in this particular patient, if you plot it here, you will get the point which is halfway between the metabolic acidosis and the chronic respiratory alkalosis, which is fine. But in case you sometimes have a triple disorder that is present, then the two-dimensional acid-base map will fail. So that's all I wanted to tell you. You just put your dot here and it's midway between these two. So therefore this disorder is existing and this disorder is also existing. All right. And also we have not done anything about the PaO2. Nevertheless, you do need to look at the respiratory tract. And if your PaO2 here is low for the FiO2 that you're getting, your PF ratio comes to 164, which means that there is a severe VQ mismatch, which is as a consequence of the pneumonia. So there are acid-base disorders that can coexist. Two metabolic disorders can occur together. One metabolic disorder can occur with a respiratory disorder. Two metabolic disorders can occur with a single respiratory disorder. But two respiratory disorders cannot occur together. The lungs can't breathe fast and slow at the same time. Now, this is a patient, 2 minutes, pH almost normal, carbon dioxide normal, bicarbonate normal, sodium normal, potassium normal, chloride normal. Everything normal. Go home, no problem. But just wait a minute. Let's look at the anion gap. The anion gap is wide. It's 30. So we have now begun to think again. You have an anion gap which is wide, and therefore it infers that there is metabolic acidosis. Check the bicarbonate gap. The bicarbonate gap comes to 15, which is in excess of +5, and therefore you have an associated metabolic alkalosis. So why is everything normal? Because your metabolic acidosis is being neutralized, at least on the numbers are being neutralized by metabolic alkalosis. And that's the reason why you're getting this confusing picture. So the bottom line is that the metabolic acidosis is presumably on account of the hypoperfusion and a possible pre-renal component. The metabolic alkalosis can be accounted for by the dehydration and volume contraction. So this same patient, if you use the acid-base map, you will have it sitting right in the center of normality. But we know that it's not normal because you have to mind the gap. All right. So last patient, I get 5 minutes bonus, no, for the question answer time. Oh, great, Vishwanath. I won't take 10 minutes. Thank you. I won't take 10 minutes because I was trying to speed it up, but thank you. So 20-year-old woman with a normal X-ray in the ER for acute shortness of breath. Now you have to focus on the terms acute or chronic because that determines on what formulas you use here. So acute shortness of breath. Normally, if you have breathlessness which is more than 2 to 3 days, you can say that the compensatory processes are coming into play, and therefore you can call it chronic. Actually, you shouldn't call it chronic, but for the acid-base interpretation, you can call it chronic. Before that, acute. So this is the pH, alkalemia. Agreed? Everybody agrees? All right. So you can do this. Alkalosis, is metabolic acidosis present? What is the question here? Is the bicarbonate high? Is it high? No, it's not high. So the bicarbonate is almost on the dot here. So it's not metabolic alkalosis. Is there respiratory alkalosis? In other words, is the carbon dioxide low? Is it low? Yes, it is low. So there is an associated respiratory, I'm sorry about this word, there is associated respiratory disorder and respiratory alkalosis present. Let's go to the O. O for oxygenation. PaO2 is 93 millimeters of mercury on an FiO2 of 0.21. The thumb rule is that you multiply normally whatever fraction of oxygen you're breathing, multiply it into 5, and that should be your expected PaO2. So your breathing room air multiplied into 5, your PaO2 should be 105. It's 100, or maybe high 90s. So this is exactly the thumb rule, which is more or less here. It is more or less acceptable. Where is it? 93, acceptable. However, the sum of the PaO2 and the PCO2 on room air should be approximately 140. That's another thumb rule. Your 100, remember, everybody's PaO2 is 100. Everybody's carbon dioxide is 40. Together, they should be 140. In this case, it is 120. Why is it not 140? Because there is something happening to maybe the oxygen, which is falling down, or the carbon dioxide, which is falling down, and the sum is not equaling 140. So, in this case, 120. The defect in the gas exchange can be better appreciated with this particular formula, which is here. We are actually going into the alveolar air equation, which will give you the AaDO2. So A capital stands for alveolar. And this is the formula. Again, we are not going to this formula. You can read it yourself. But when you calculate the AADO2, it is 23. Normally, it should be 7 to 14 on room air. AADO2 is wide. The amount of oxygen that you're breathing is not getting into the blood, and therefore the gradient is widening. Then see for what's happening, 0.2. Acute respiratory, 0.1 is not relevant because clearly there is no acidosis here. Let's go for respiratory alkalosis because here it is an acute situation. We go for the acute formula. Change in bicarbonate, blah, blah, blah. Eventually, you find that the actual bicarbonate is almost identical with the expected bicarbonate. So the anion gap is also stated to be normal. Therefore, there is no associated metabolic disorder. Look at this. Acid-base map, it is sitting exactly on the acute respiratory alkalosis bar, the band, and therefore does not seem to be a associated acid-base disorder. So oxygenation, clinical correlation, bottom line, there seems to be a potential problem. In the absence of gross clinical and radiological abnormalities, what do you suspect? A normal looking X-ray with slight hypoxemia? Embolism, because there could be something in the vasculature. So you should be looking for that. It's just a kind of a guide. Last, ABG. Come on, tell me, what is this? Alkalosis or acidosis? Alkalosis. What's happening here? Normal. What's happening here? All right. So what is it? All right. Now go back into the history. That's the beauty of finding a story buried in your acid-base, this thing. Now you go back into the case sheet and you find that this was the initial problem here. So 7.23, acidosis, carbon dioxide, high. What kind of acidosis is this? Respiratory acidosis. All right. So here assisted ventilation was commenced either in form of invasive mechanical ventilation or non-invasive mechanical ventilation. What happened? What happened? You washed out the carbon dioxide, and somebody has very aggressively set the settings of minute ventilation, either a high respiratory rate or whatever it is, and the carbon dioxide got completely washed out. Here the carbon dioxide rose over a period of time as the patient evolved into respiratory failure, and because of that, to compensate, the bicarbonate also started rising, and the pH was kind of, maybe it was 7.18 or 16 to begin with. It came up to 7.23, but suddenly you've blown off the carbon dioxide, and as a consequence the pH goes up, but the bicarbonate has had no time to rise. So what you're diagnosing is metabolic alkalosis, whereas it was a situation of respiratory acidosis, isn't it? All right. So this is called post-hypercapnic metabolic alkalosis, and of course, you can read about it. There's no point in my teaching you formulas and formulas and formulas. I can tell you, I can promise you one thing. You make a flashcard, put it in your pocket, do it daily, you will become addicted to respiratory physiology, and that's what the beauty of our field is about. I don't believe even cardiology or gastroenterology or any other line compares. You have got a physiology that's staring you in the face, and it is fascinating. There's no other word for it. So this is my last slide for me. This is Dr. Dariusz Mazejewski. He is the chief of the School of Mechanical Ventilation of Poland, and I was fortunate enough that he translated both my books. Thank you for your patience.
Oh, thank you very much for the wonderful message, sir. I think, and it has been enlightening, and it made our Sunday morning very fruitful, I can say. And thank you for all the thumb rules. One of the important things, point from the talk is that just don't look at the APG on the face of it. Just compare if you have any previous APGs. Look at the trend, is what is happening to the patient over a period of time, rather than just seeing one. If the patient is coming to outpatient and you have a one APG with it, it's okay. So you probably just, I would request you to stay back for. I have one question before the audience. Just be prepared for any of the question. Sir, how do you calculate AAO2 when the patient is on mechanical ventilator?
No. See, the thing is, the mechanical ventilator has nothing to do with calculation of AADO2. The thing is that AADO2 has a Gaussian shape curve. So if you're breathing room air, 0.21 FiO2, or you're breathing 100% oxygen, 1.0 FiO2, you have got a kind of nomogram. Here it should be, let us say, less than, between 7 and 14. On the other side, it should be about 300. But in the middle, if you have an FiO2 of 0.6 or 0.7 or 0.8, it is not possible to make a corroboration. Therefore, your AADO2 is always, there are nomograms, however, but the AADO2 is either assessed on room air or is assessed on 100% oxygen.
The reason why I asked you is because here we are taking atmospheric pressure into consideration.
Yes.
761 is that.
Yeah, so
47 we are
positive pressure is what?
here the positive pressure.
PEEP.
So the reason why I asked you is, can we add that pressure, may convert into mmHg and then use that? That was the
No. See, yeah, absolutely. I think it's a brilliant question here, because you're actually worried about whether the PEEP is actually acting as a increased barometric pressure on the ground. So that's wonderful. But most of the nomograms have not taken that additional PEEP into consideration. That's all there is. It's actually wonderful. I'm sure I'm sure that there is an impact, but it's whether that's clinically meaningful or not is the question.
Maybe we have to check in neuromuscular patients when they're on PEEP, maybe, and see.
Perhaps.
That's just a research point which I got. Yes, Dr. Matin.
Actually, when you come in to Hyderabad on the flight, you see the barometric pressure of Hyderabad printed on the tarmac side of the airport. I suppose many people have noticed that. I noticed it down. Yeah.
Shikhar, any question? Yeah, I think yes.
Good morning. So just wanted to know, when the machine gives us the base excess value on the paper, does it have any significance in
No, you should take it into consideration, because your actual bicarbonate, your standard bicarbonate, your base excess. The thing is, there are two schools of thought. One is called the Copenhagen school of thought. The other is called the Los Angeles school of thought. Now, one of those schools, I don't remember which one, they completely discarded your pH or this or that. They just focus on the base excess. So you don't need to do both. You can do either, but since we are more familiar with the conventional analysis, like I showed you, you take the base excess as a supportive evidence. So if your base is less in excess, then you have an acidosis there. That's all there is.
If there are no further questions, then we can conclude this session. I request Vinay to give a brief.
Thank you, sir, for excellent talk. On behalf of AIG Pulmonology team, I would request chairpersons Dr. Vishwanath Kella sir and Dr. Gautam Bachu to present a token of gratitude and respect and appreciation to the speakers.
Yeah.
Dr. Ashfaq Hassan sir, please come on to the dais. Gopal Krishna sir. I would request Dr. Syed Mahmood sir to present a token of gratitude and respect and appreciation to the chairpersons.
Morning, everyone. After a very informative first session, we move on to the second session of the day, which is roughly about 50 minutes from now. So I would like to request the chairs to take the dais for this session. Dr. Lakshman Babu sir, Dr. Tapasvi ma'am, Dr. Mahmood sir. Lakshman Babu sir is a senior consultant and lead interventional pulmonologist at Sunshine Hospital, Secunderabad. Dr. Tapasvi ma'am is a senior consultant at Gleneagles Global Hospital. Dr. Mahmood sir is a senior consultant at OIC Hospitals. Move on with the session.
I invite Dr. Vamshi Krishna, who is MBBS and MD from JIPMER, Pondicherry, and completed his specialty training in medical oncology from Tata Memorial Hospital, and worked as fellow at All India Institute of Medical Sciences, New Delhi. And he has more than 10 years of experience in medical oncology and hematology. His current areas of interest include lung cancers, genitourinary cancers, and molecular oncology. I welcome you, sir.
Thank you, chairpersons, and thank you to the organizers for giving me a chance to speak on a topic that is very close to my heart, that is lung cancer. And I was told to make sure that I speak of lung cancer in a nutshell, so I'll try and do that. 25 minutes is obviously not enough to teach everything about lung cancer. That's not feasible. What I will do is I'll try to cover most of the lung cancer aspects, and definitely there'll be more questions, and I'm sure we can address that as the time comes. My viewpoint is going to be that of an oncologist viewpoint. So I'm going to give you a kind of an overview as to how lung cancer is dealt with by oncologists. And I'm sure there'll be, differences in the way possibly you would approach it, but that's the reason why I'm doing this talk. Now, we are aware of the lung cancer statistics. Currently in India, it is possibly the 4th or 5th in the list of overall cancers. The incidence is certainly rising. Now, overall, India as such has a lower incidence of cancer than many westernized countries. It comes with a shock to us, given the whole alarming statistics and the hype about cancer in India. The fact is, we are also the largest population by far anywhere in the world, and that's why the number of cases are so many. Across data, when you look at, say, this is kind of 7-8 years old and the number is only increasing, across various centers, the lung cancer proportion is gradually increasing. And as in the West, even in India now, it is constituting a significant proportion of patients of cancer overall. So lung cancer is really the one of the big things for us medical oncologists to be treating. Now, how do I look at a lung cancer? For me, it is all about evaluation, which includes the biopsy and the pathology, followed by a staging, which includes not only scanning or imaging, but also molecular testing. Now, molecular testing has really come into a big way in lung cancers. Now, that translates into the management. When I say management, it's basically very simple. You have surgery, you have radiotherapy, you have chemotherapy, targeted therapy, and immunotherapy, right? These are your essential components, and we mix and match and play around with these, trying to improve the outcomes. That's all there is in lung cancer. End of the day, this is what we do. The only question is, how do we go about it? What do we do? And what are the newer medications and newer things that have come around? When we talk of the initial evaluation, this part still holds true. We need to know whether we are talking about a non-small cell lung cancer versus a small cell lung cancer. That is very crucial. Percentage wise, small cell would possibly constitute around 10%. non-small cell will be 90%. Among non-small cell, again, interestingly, the data says that in India we have 40% squamous, 40% adeno. In clinical practice, if you ask me, I think I would say it is 40 to 50 adeno, 20 to 30 poorly differentiated, and maybe 20% squamous. So squamous percentage is certainly coming down in number, but it is still significant. So that's about the cell type. Next, we go on to the stage of the disease and then the management. The most important part, which is often overlooked, is the functional status of the patient. We need to know how fit the patient is to undergo treatment. That really is one of the most crucial determinants of our treatment. Your diagnosis, your everything comes later. That is important. But the functional status of the patient decides how much aggressively we are going to treat the patient and what treatment we can offer. So then we come to the various investigations. Now, investigations, again, all of you, most of you are postgraduates here. So the easy way to remember investigations, especially in our exam, we used to always say this. If someone asks you what investigation would you like to do, classify. Investigations to confirm your diagnosis, investigations to decide on the management. To confirm, you need imaging, you need histopathology. For the patient's functional status, you need the routine investigations. So when someone asks you what investigation need to be done, please don't start by saying I'll do CBP creatinine. They are important, but put them in their place. They come for the patient routine investigation. For diagnosis and the staging, you need imaging as well as histopathology. So let me talk of imaging. Chest X-ray, I know I'm standing in a room full of pulmonologists who are very fond and are justifiably fond of doing X-rays because that is a simple non-invasive test. However, when it comes to lung cancers, unfortunately, this is neither specific nor sensitive. And next, we cannot follow up with a chest X-ray. You cannot have an X-ray today saying there's effusion and 2 months later do another X-ray and say, oh, effusion is less, so cancer is responding. It does not work that way. We do need more sophisticated imaging techniques, and if you are suspicious of a lung cancer, please do a CT scan. I mean, there are innumerable cases where people have done an X-ray, it's either normal or there is some subtle change which was missed or a subtle change which was considered non-significant. These are important points to remember. When we look at CT scan of the thorax, again, I'm not going to details. You guys are better at it than me. Looking at the type of nodule, looking at how the nodule is, whether there's a lung mass, whether that is extending into the structures. Then importantly, this is where we are very interested, is the evaluation of the lymph nodes in the abdomen or in the mediastinum. That is something that we are interested in. Of course, with any imaging, we would like to image the liver. We would like to image other upper abdominal structures, including the adrenals. And this is not a theoretical discussion. This is what we really look at. This is in real life what we are seeing. So next comes a PET scan. Now, a very false and bad rumor around people that oncologists like only PET scans. It's not the case. We are very comfortable with even a good CT scan. A PET scan is important in its own place. The role of a PET scan is very, very clear for us. It is to detect mostly the staging of the lung cancer. If you want to detect the lung cancer, if you want to characterize a local lung cancer, a CT scan is still the best investigation. To look for distant metastasis is where a PET scan becomes important. That is why we do often ask for a PET scan even after a CT has been done. Remember, we are looking at the PET component. So again, for those who can go back and look at it, there is a PET scan, which is a PET imaging, which is a marker of active glucose metabolism. There is a CT scan, which is the same CT scan which we normally do. Now, the reason why you would find a bit of negativity about the PET CT is because in the Western countries, usually they do only a PET scan separately. Now, that PET does not include a CT. In India, we do a CT and a PET together. So, when you are ordering a PET CT scan, also remember that your CT component is equally important. The CT component is what we will be using to decide the size, decide our further management. The PET is mostly for doing the distant staging workup. So a CT component is very important. So if your CT reporting is bad, your PET CT reporting is bad. That's what it is. Therefore, whenever you get a PET CT reviewed, your radiologist should be able to work on the CT as well. Unfortunately, that does not always happen. You get PET scans being reported from places which would just talk on SUVs and stuff like that, which is useful, but equally important is the CT imaging, right? So that's the reason why we like doing a PET CT scan. Coming to the diagnostic biopsies. Now, in biopsies, we have all of these things. Again, please remember there is nothing absolute. All of them have their own place in the diagnosis. We do a CT guided biopsy wherein a biopsy is done wherever it is feasible. The only reason, because you get enough tissue out of it. Tissue is very important for oncologists. We want more and more tissue because we can run tests on that tissue. And you don't miss often if you have more tissue with you. Which is why, even though the tendency is to do interventions, if you can get a good tissue with a CT biopsy, that is possibly more important than the other tissue, other modalities that I have outlined. Again, this is useful when we have a big mass sitting peripherally and you know you can address it. If you do not have such masses, it happens. That's pretty normal. Then definitely the other modalities are also important. What are these other modalities? Number one, bronchoscopy. For usual malignancies, a bronchoscopy may not be that useful. It is very important when you are having an endobronchial growth. Usually when you do a bronchoscopy, you'll get enough tissue. However, it is very often that we see reports which say tiny tissue, cancer is there, but that's all you can comment on it. That is when we want a CT guided biopsy because we are looking for more amount of tissue from it. So a CT guided biopsy, wherever feasible, is my preferred choice. When not preferred, or if it is more easy to do bronchoscopically, go ahead. TBNA, again, very important and requires a degree of expertise to do it. And unless, at least for me, unless I'm comfortable with my pulmonologist, I will not even ask for this test. Luckily, I am in this place, but not everywhere it is the same case. But if you have good pulmonologists, you can do a TBNA. Again, for me, it is more important in terms of staging the disease. Are those nodes that I'm seeing really significant or not? I do that with a TBNA. Will I do a TBNA to diagnose? If I have a 6 centimeter mass sitting in the upper lobe, easily accessible with few lymph nodes, I would want to do a CT guided biopsy to get the tissue for my diagnosis. That is more useful for me. A TBNA is only for knowing the staging, which is again very important, but that's what we use a TBNA for. Cytology. It is an initial diagnostic method. Nowadays, most centers are doing just effusion testing for cytology. We are even making cell blocks out of it. So it is good to have a cell block, but again, the quantity of tissue, the amount of tissue is usually not the same as a CT guided biopsy. So again, if you see a patient sent to me with a report saying pleural effusion positive, I would still do a scan, try to find a mass and do a CT guided biopsy from it, because that gives me more tissue. So this is how I look at it. Again, like I said, you can debate these and there are enough and more papers which tell you that diagnostic accuracy wise, any of these modalities are as good as a CT guided biopsy. As an oncologist, I want tissue. So that's the reason I go for a CT guided biopsy. Looking at staging. Now, why do we do this staging? That is something which as a fundamental level we have to understand. A staging is something that has been discovered and invented and modified by doctors. Why do we do a staging? We do a staging because it tells us an approach to management and helps to standardize it. Now, this is important. Across the world, if I say this stage, this T stage, this N stage, a person sitting in the US, anywhere can easily understand what I'm talking about. That is the biggest value of a staging system. Secondly, a staging will help us determine the characteristics of the tumor, the risk of metastasis, and the presence of metastasis. You have a larger tumor, well, obviously there is more tendency to spread. How do I know it is a larger tumor? Based on my staging. So staging is something that is essential. It helps us develop a common language for patients across the world. So that is the most important aspect of staging. So beyond the point, staging is like this. You have T1, T2A, T2B, T3, T4. Put a gun to my head right now. If you ask me exactly each one, even I may not be able to tell you all of the characteristics of it. Because it's important to know, we rely on the radiologist to help us go with the staging. Most important is how we manage. And there, the simple way to look at it is an early stage, locally advanced stage, or a metastatic stage. More easy to understand is this way. Most trials, even in NLCLC, have been done in this way. You have an early NSCLC, which is 1A, 1B, locally advanced, which is 3A for sure, metastatic. Now, this overlap areas that I'm showing you, that's where there is a little bit of controversy. Would you call it 2A early or would you call it locally advanced? The boundaries are blurring a little bit nowadays. That's because for treatment wise, early NSCLC, you would have one or maximum two modalities of therapy. Locally advanced, you would include multimodality approach, including surgery, chemo, radiation, everything. And finally, the metastatic, wherein you are going to have only a targeted or a systemic therapy. That's basically why we divide it like this. So rather than remembering T1, T2, T2, I'll do this, T1, I'll do this, easier way to remember, early, locally advanced and metastatic. Again, this correlates with your prognosis. Now, this is a little older one. Things have improved, especially in the stage 4 nowadays, but otherwise this is what it is. Even in a stage 1A, it is not 90% cure or 95% cure. It's still 60, 70, like that. Stage 2, 3, 4, as you keep coming down, the percentages reduce. This is a reality. It's a little depressing when we talk and say early lung cancer and still only 60%, but that's how it is. A breast cancer, early breast cancer, I will say it is 95% curable. Lung, not so much. That's what it is. The other important aspect, I'm jumping a bit here because, to cover important aspects, this is important. The mediastinal staging. Again, very, very important for us in a early and locally advanced stages. To know which station you're covering, to know which station is involved, and to decide whether they're really positive or not. How do we decide? Preoperatively, again, I'm not going into the details of the trials and the guidelines behind this. By and large, do a PET scan. A PET scan is negative. Possibly we do not to confirm this before the surgery. If a PET scan is positive, you would still like to confirm it doing a image, doing a biopsy. Now, whether that biopsy is done on an EBUS before surgery or during surgery in a mediastinoscopy, again, lot of discussion going on. By and large, I think the pendulum has swung to the fact that you will be doing a EBUS preoperatively, and we are comfortable with that. Again, good intervention pulmonologists will get you your nodal stations and will get you your tissue to say whether it is involved or not. Helps us in staging, helps us in the management, right? So what is the management? Reasonably simple management. Early NSCLC stage 1 and stage 2, do a surgical resection wherever feasible. What does that mean? Patient has to be fit for undergoing a surgery. Means medical fitness. Again, the guidelines are pretty clear. You do a pulmonary function test, look at the residual volume, look at the total lung volume, gives you an idea of when you should do a surgery. I'm not going to those details. But whenever possible, do a surgery. After surgery, what do you do? Now, the idea is, like I said, even in a stage 1, your outcome is only 60% 5 year. So would you want to improve that outcome? How do we improve the outcome? By doing something called chemotherapy. How does chemotherapy work? The logic is that as your tumor size increases, potentially they have given micrometastasis in the body. You would give chemotherapy to kill these micrometastasis. Do we have any evidence for that? Again, simple things you need to remember, a LACE meta-analysis which was done by stage, and it showed that across stage 1B, stage 2, stage 3, there was a benefit by adding chemotherapy. No benefit in stage 1A. Therefore, we would not be giving chemotherapy for stage 1A beyond 1B. Now, today 1B is T2 and above, which is 3 centimeter and above, but this analysis said more than 4 centimeter. So, any tumor more than 4 centimeter in size, any node positive tumor, we would be giving adjuvant chemotherapy. What chemotherapy? It's a cisplatin or platinum based chemotherapy. You have different drugs. We use vinorelbine, pemetrexed, paclitaxel, again, depending on the patient's fitness. But important to note, if stage 1B and above, give adjuvant chemotherapy. As of today, there is rarely no data for suggesting the role of any radiotherapy in a resected lung cancer, unless there is a margin positive. If you are margin positive, you would give radiotherapy, otherwise no radiotherapy. Again, it's important that these decisions are taken in an MDT sitting together. If individually it goes to a radiation oncologist, there's a tendency to give radiation, but all decisions have to be taken in an MDT to decide what treatment is to be done. Now, what about the elderly patients and those who are medically inoperable? And this is not an insignificant proportion. Please remember, all patients who come to you will not be medically operable. For those patients for stage 1 and 2, we use radiotherapy. Now, radiotherapy is nothing but high beam X-rays with high energy rays that will go and disrupt the cancer and kill the cancer. It can be given by something called external beam radiotherapy. Now, external beam radiotherapy conventionally is given over a period of 5 to 6 weeks. You can give it twice a day, you can give it once a day. Different trials again, but by and large, external beam radiotherapy. Then nowadays, in the last 5 years, we are doing something called stereotactic radiosurgery, wherein a very high dose is given over a very short time. So you give equivalent dose of 25 days in only 3 days to a very small area of the lung. Now, SBRT is a flavor of the season. Again, a lot of people talk of SBRT as if it's a groundbreaking revolutionary thing. It is not. It's a good technique, well validated by now in specific situations. You have a small tumor confined to the lung, not close to the mediastinum. There are certain no-fly areas. It should not be close to your aorta, not close to your vasculature, not close to the heart. There you can give SBRT. And that will take care in a short period of time equally effectively as your conventional radiation. The other important thing is with SBRT, you will not be covering the mediastinal nodes. The nodes cover, if you have to cover in a more locally advanced stage, you need conventional radiotherapy. That's what is there. This is how it looks. You have this colorful picture which radiation guys show you. Essentially, whatever is that yellow part is what is being radiated. The lines around it indicate the amount of radiation the surrounding lung tissue is getting. The aim is to give all your radiation to that part, not radiate the healthy lung. That's what it is. Now, in this nice scenario, when I showed you the Venn diagrams, remember there were these overlaps. Now, why have I put overlaps? Mainly because nowadays we are trying to improve our outcomes even in those early stages. So we have now new drugs known as immunotherapy. I'll just talk about it a little later. But immunotherapy has come in picture in a lot of lung cancers. And for us, this is a groundbreaking study. It came last year, the Checkmate 816, using a drug called nivolumab, which is one type of immunotherapy. Immunotherapy given prior to surgery. These patients are all operable patients. For us to get operable patients out of the hand of surgeon and say that, look, I'm going to give you some extra treatment before is not easy. But this is what it is. You give immunotherapy and chemotherapy before surgery. Then the response rate is much better. This trial actually has shown a pathological complete response rate of around 15%. When lung cancer is kind of unheard. You're having complete response with just drugs and then you do a surgery and remove the tumor. This is what is the future. We are going to give neoadjuvant treatment, try to shrink your tumor for operable lung cancers. Okay, this is not inoperable. This is not a stage 3B, 3C where you cannot operate. So you want to give disease drugs to shrink it. This is operable lung cancer. Okay, supposing you still go ahead and do a surgery. Is there any role for improving your adjuvant outcomes? Remember I talked about adjuvant chemotherapy. Now we have two big trials. These are the two big trials which included resected lung cancer 1B to 3A, looking at disease-free survival, and in both the groups, it is showing a benefit in disease-free survival with immunotherapy. So things are becoming complicated. 10 years back, we used to hardly operate lung cancer. Now we are talking of giving immunotherapy and then operating, or we are telling do a surgery and then give immunotherapy to prolong the lifespan. This is where the evolution is going on. Again, important to note that all these are now accepted modalities. Again, brings into focus the importance of an MDT. All diseases should be managed in an MDT where the surgeon, radiation oncologist, pathologist, pulmonologist, intervention radiologist, everybody sits together and decides the course of action. If I have decided that I want to give adjuvant immuno, that has to be decided on day one. It is not decided when the patient comes to me. That's the takeaway. Then, anything else to confuse the issue further? We know that TKIs are used in stage 4 lung cancer. There is a very important trial which has come around known as the ADORA trial, which is using a drug called osimertinib in EGFR positive resected patients. You look at the disease-free survival. Now, the top line is those patients who don't get osimertinib. The top line is those who get osimertinib. The bottom is those who don't. Look at the difference. It's huge. I mean, it's a big difference. Whether this is translating into overall survival or not, that discussions go on. But by and large, today, if I get a patient who is fit for surgery, I would not just do a surgery. I would look at the option of giving neoadjuvant chemo. I would look at the option of giving adjuvant treatment. I will do an EGFR testing to see whether I can do osimertinib as well. So that's about lung cancer in the early stages. locally advanced, where you have pathologically proven stage 3 disease, you have N2 disease, you have single nodal station N2, or you have N1 proven. There you would want to possibly do a combined modality approach, radiotherapy plus chemotherapy. Potentially larger tumors, if you don't have nodal involvement, it's a rare scenario. But if you do get that, possibly you might try a neoadjuvant approach, go for a surgery even that time. Would you just stop with chemoradiation in the locally advanced stage 3B, 3A, 3B? No. Beyond that, you still have a standard of care of CTRT followed by another immunotherapy drug called durvalumab. That's the standard of care for stage 3 locally advanced, right? I know I'm covering a lot of territory. I'm trying to cover a lot of things in a short time. This is something you can hear now, and slowly you will, digest it over some time, hopefully. Okay, quickly I'll go into the next 5 minutes. We had started at 4 minutes now. I'll finish in the next 3-4 minutes. Metastatic NSCLC, we need to go for systemic therapy, which is both targeted molecular therapy as well as immunotherapy. Again, very important to note that we just don't look at the disease itself, we look at the patient. Most important points which still determine our treatment is patient-specific issues like age, comorbidities, concerns and preferences regarding testing and whether we will be able to do those testing. Now, I have been talking of testing, molecular mutation, all these throughout my talk. This is why we are doing it. Like I said, adenos are becoming more and more common, and in adenos, now we know that close to 50% of our patients have something called a driver mutation which is causing the cancer to grow. And that driver mutation is what we are going to look for. These are words you keep hearing. By and large, the most routinely tested is this bunch. It's not just EGFR. Look at ALK, look at ROS, look at MET, RET, NTRK, BRAF, HER2/neu, PIK3 and KRAS. And this is not a theoretical discussion. This is something we are doing right now today. Important thing is to know, why do we test it? An example of EGFR, where you have a EGFR pathway which will be affected and cause the cancer to grow. You target this pathway, you get a response to the cancer. And the median survival now in an EGFR positive patient today is around 3.5 to 4 years. We are talking of years in a stage 4 cancer, which is dramatic. What about ALK as another example? You have at least these 4 drugs available in India now, which will treat, and the median survival is more than 5 years. So stage 4 cancer with ALK, we are talking of 5 years of life. We are not talking of 1 year, 1.5 years anymore. This is the difference. Very important point which often people ask, how do you test these mutations? Previously we used to do by IHC, that is out. You can do by a technique called PCR, which is important, but a PCR will look only for 1 mutation or maximum 2 mutations at a time. You can do sequencing. Now sequencing means you read the DNA and figure out where all the mutations are. You can do something called a Sanger sequencing. Now, old biochemistry, in Sanger you go one by one. You take one DNA base, one DNA base, one DNA base, try to look at each individual DNA base. Very laborious, very time consuming and not as sensitive as you would like. So what we do nowadays is something called a next generation sequencing. Now again, NGS is a word thrown around with very, very liberal abandon. Remember, NGS is a technique. Okay, NGS basically means you take your DNA, break it into strands, multiply these strands multiple times, have as many as 1 million cells. Each cell is sequencing a part of the DNA. So you get a small sequence. Small, 20 bases, 100 bases, 150 bases. You get 1 million of these together and then run a very powerful bioinformatics system to sequence all of it in order. It's not as easy as I'm making it sound, but that's how it is done. And that is why the test takes 2-3 weeks to be done. That bioinformatics backbone then gives you a read and tells you these are the areas mutated and then tells us this is the mutation. So this NGS technique can be used for 12 genes. It can be used for 50 genes. It can be used for 350 genes and whatever. So each place there is a cost issue. There is some reliability issue. So again, I would suggest anyone to just get in touch with the oncologist or have an institutional specific policy and say this test is what we will do, which is what we are trying in our institute. We will be possibly starting in a couple of weeks, one in-house testing, which will cover around 25 to 30 genes. Once we have that, there's no confusion. We know that this is the test to be done. Now, beyond that, anything else we have? We do have immunotherapy. Now, what is immunotherapy? Again, very simply, T cells in the body fight cancer cells. Cancer cells use something called a PDL1 pathway and a CTLA pathway to evade the immune response. Normally, our body cells don't get activated by our own T cells, right? They do this through this pathway, PD1, PDL1 and the CTLA. Tumor cells, being very smart, utilize the same pathway. Therefore, if you can block this pathway, the immunotherapy drugs will block this pathway, T cells will become active and they will go and kill the cancer cells. Immunotherapy does not directly attack the cancer. Immunotherapy activates your immune system to attack the cancer. That is the fundamental difference between a chemotherapy and an immunotherapy, which is why the entire gamut of side effects, the entire gamut of results are different. These are the drugs which we have right now. I'm not going to details of each individual drug because, we could spend hours and hours on those trials. Suffice to say that if you have a mutation, use a targeted therapy. If you do not have a mutation, use either immunotherapy alone or a combination of immunotherapy with chemotherapy. That's it. That's the bottom line. As simple as one line management of metastatic NSCLC as you will get. Squamous, the role of mutations less than 3%. Most of them will go for again a monotherapy with immunotherapy or a combination of immuno plus chemo. Second line, once you're exhausted with your first line, use again chemotherapy or use chemotherapy with an immunotherapy if you have not done it before. If you have used an immunotherapy once, usually you cannot use it again. For targeted driver mutations, again, a whole class can be taken on it. In EGFR, you have one drug. Second line, look for new mutations and again do a testing. Third line, again do a testing. So, I have a patient where we have done 8 times NGS testing, each time an expensive test, each time we give him a targeted therapy. He's now alive for 76 months in a stage 4 NSCLC adenoCA. So, that's the advantage and that's the revolution that has really occurred in NSCLC. So there are challenges, of course, and not all patients fit this group. The challenge lies in screening, in getting to detect cancers early and thereby deciding our management for early cancers and trying to make this more of a chronic disease. So thank you. And that's my institute, Tata Memorial Hospital, to which I'll always be indebted. And for all PGs, your teaching place or your alma mater is what will guide you for the rest of your life. That's something we have to remember. Thank you. I don't know if you have time for questions. I'll be happy to take questions outside during tea time or on one-on-one basis. Thank you. Thank you, sir.
Any questions from PGs?
Dr. Vamsi made a very important point about MDT actually. If individually, if a medical oncologist tries to treat a patient, probably he'll tend to give chemotherapy or a radiation therapy by radiation oncologist. So I think Vamshi is very passionate about MDT actually. He heads the MDT and he always makes sure that the patient gets the right treatment. There are a lot of times where he has said that where we have referred him for chemotherapy and then he sits with the MDT and finally comes to a common plan actually. That's the beauty of MDT, and I think every lung cancer in any organization should go through the MDT rather than through one specialist, where there may be an error of treatment. Thank you.
Absolutely. And most importantly, MDT is not just oncologist. MDT includes a radiologist, a pathologist, an intervention radiologist, and pulmonologist. These are very, very important components. I will not decide what biopsy has to be done. Together, we decide where a biopsy has to be done from and how it should be done. I think that's the take-home message. Thank you, Dr. Ishwan.
With the amount of IP specialists sitting here, I think tissue will not be the issue for oncologists. So I would like to call the next speaker, who doesn't need an introduction, probably mentor for many IP fellows here, including me. And we started that flexi-rigid medical thoracoscopy sometime 6 years back in Malakpet. So with that, in I would invite Nagarjuna. Please take over.
Thank you so much. I'd like to thank the organizers for the topics chosen, and I'd like to also appreciate Dr. Vamshi for his very lucid and crystal clear approach to lung cancer. So my talk is on malignant pleural effusion. Again, as Dr. Vamshi has said, even this is a very huge topic So what I would like to do is to just cover the basics. We won't go into all the trials, and I'll just give an overview of three things. Most important is how to define a malignant pleural effusion. This is the most important thing. Second is how to get the correct diagnosis, and then how to decide the management strategy. So it may seem very simple. So how do you define malignant pleural effusion? Is that you have to demonstrate malignant cells. This is very important. You have to demonstrate malignant cells in either the pleural fluid or the pleural tissue. So only when you see malignant cells, you can actually call it as a malignant pleural effusion. So which means that the pleura is involved by the disease, and that has led to the formation of pleural effusion. The mere presence of pleural effusion will not make it malignant pleural effusion. So here comes this stratification. So when a person with a malignancy develops pleural effusion, it can be a true malignant pleural effusion or it can be a paramalignant effusion. So by paramalignant effusion, I mean that there is effusion, but it is not because of malignancy. There is some other pathology which is causing effusion in that particular patient. So this is one example of a 55-year-old gentleman who was from Hyderabad, IT professional, initially diagnosed to have a follicular lymphoma when he had presented with generalized lymphadenopathy, treated with the standard regimen, then developed sudden chest pain one night, then breathlessness, and then this was the CT. So he developed an effusion. So this was thought to be a malignant pleural effusion, and then he was referred to us for evaluation. When we actually did a diagnostic tab, this was what was there. It was a chyle. So, and there were no malignant cells, obviously. So this was not a malignant pleural effusion in a case of lymphoma. This was a case of a traumatic chylothorax. So what are the reasons why a person with malignancy can develop a paramalignant effusion? So one of the most common things is a post-obstructive pneumonia of the pneumonic effusion. Second, as I have shown, chylothoracis. Pulmonary embolism. Patients with malignancy are a high risk for PTE, so they can develop effusions because of PTE. They can sometimes have transitive effusions because of coexisting cardiac or renal problems. Also tubercular effusions. We have seen n number of times where a person of malignancy develops a tubercular pleural effusion. So do not presume that every effusion in a person with malignancy is a malignant pleural effusion. This is the first thing I would want to drive home. Now, second thing is how to confirm the diagnosis of malignant pleural effusion. So this is a case scenario again. You have an elderly gentleman, diabetes, 2 months history of the standard constellation of symptoms, breathlessness, cough, weight loss and appetite loss, and X-ray showed a large effusion with mediastinal shift to the contralateral side. So now how do we confirm a diagnosis? There are 3 tests which can be ordered. One is a pleural fluid cytology. Second is a pleural fluid cell block, and third is a pleural biopsy. So if you demonstrate malignant cells in any of these, you can confirm a malignant pleural effusion. So the first step whenever we have a person who presents with an undiagnosed effusion is an ultrasound guided thoracentesis. I would again stress it should be ultrasound guided thoracentesis. Blind is no longer done. So in the intake's case, ultrasound guided thoracentesis was performed, which showed a straw colored fluid, exudative, lymphocytic, low ADA. Malignant cells, malignant cytology was ordered. It was negative for malignant cells. Cell block also was ordered. Again, that was not showing malignant cells. So, couple of slides, points about pleural fluid cytology. So, if it is positive, it will confirm the diagnosis. But if it is negative, it does not rule out malignant pleural effusion because the sensitivity of pleural fluid cytology is only 45 to 60%. And the factors on which it would depend are 3. One is the type of malignancy. This is a very interesting diagram. If you see, depending upon the type of malignancy, the sensitivity of pleural fluid cytology varies. If you have an adeno of the lung, you have a higher chance of picking it up on cytology as opposed to squamous or small cell. Mesothelioma obviously has the least chance of being picked up by pleural fluid cytology. Even for metastatic malignancies, CA ovary and breast have a higher chance of being picked up on cytology vis-a-vis a biopsy. Also the volume of fluid, if you just send 5 ml, 10 ml, it is not sufficient. It is said the least amount which is required is around 60 ml. But the more you send, the better it is. Also the experience of cytopathologist. All these 3 factors would decide your sensitivity of this pleural fluid cytology. Why cell block is that if you add a cell block to cytology, you have a 10% additional yield in diagnosing a malignant pleural effusion. So in this particular case, the first step was done. The simplest thing is the pleural fluid, but unfortunately it did not show malignancy. So does that rule out malignancy? No. So if you have an undiagnosed effusion, the next thing is to do a pleural biopsy. But how many times would you have to do a cytology before we go to pleural biopsy? This is the gold standard teaching. First time, second time, third time. It is said that the first time if you do, you have a 45 to 50% sensitivity. If you do a second tap, your additive yield is 15 to 20%. If you do a third tap, it is 5 to 10%. But in the current scenario, would you actually do second time and third time? Practically speaking, we don't do. We do first time. If first time is negative, usually we go to pleural biopsy. But there is one interesting algorithm again which says that depending upon your suspected primary, if you have a primary which is more likely to be positive on cytology, you're not wrong in doing a second time. But 3 times is probably something which is not followed anywhere. You either do once or twice before proceeding to a pleural biopsy. Now, this is one of our paper, and just one or two slides on pleural fluid ADA, because again, whenever we have a patient with undiagnosed effusion, in addition to cytology, the role of ADA in determining whether a person needs a pleural biopsy or not. So ADA also we use when we have an undiagnosed exudative lymphocytic effusion. If a person has an ADA of more than 70, the chance of malignancy is lesser. I would not say no, but lesser. If ADA is less than 40, then the chance of malignancy is more. If it is 40 to 70, then it is intermediate. So ADA is also used to stratify patients to decide whether they would actually require a pleural biopsy or not. Now, in the index case also, we have done the pleural fluid once. We don't want to do a second time aspirate. So the next obvious thing to do is to do a pleural biopsy. Now again, when we decide to do a pleural biopsy, we also have to decide what is the technique which has to be used. Now there are 4 techniques which have been described to perform a pleural biopsy. The oldest technique is the so-called closed or blind pleural biopsy by using several needles which are available. Second is CT guided or ultrasound guided biopsy. This is called as the image guided pleural biopsy. Third is what we do as a pulmonologist, that is the medical thoracoscopic pleural biopsy. And fourth is the surgical or VATS assisted pleural biopsy. Now, for a diagnostic procedure, subjecting somebody to a surgical procedure is something which does not sound very appropriate. So A, B, and C will remain the options. Now, when we suspect malignancy, the yield of a blind pleural biopsy is very less. This is because the disease is not uniformly distributed. It is patchy distribution of the pleura by the malignant deposits. So it is said that the yield of closed pleural biopsy is only 50%. So when we have a person whom we are suspecting malignant pleural effusion as opposed to tubercular pleural effusion, we would not recommend a closed pleural biopsy. So we would actually have to resort to either a image guided biopsy or a medical thoracoscopic pleural biopsy. If we have to compare these two, again a thoracoscopic biopsy has a slightly higher diagnostic yield as compared to image guided pleural biopsy. So now in most centers where there is access to a thoracoscopy, now if you have an undiagnosed exudative effusion where you suspect malignancy, thoracoscopy is now considered the initial investigation of choice to confirm the diagnosis. The advantages of thoracoscopy is that it's a combined diagnostic and therapeutic procedure. So you can drain the pleural fluid, you can perform adhesiolysis, you can confirm the diagnosis, and you can perform pleurodesis in the same sitting. So this is the advantage of a medical thoracoscopic pleural biopsy. It is not a very complex procedure. There is one talk dedicated to thoracoscopy, so I would not go into the details of it. Now again, the last question is, now you decided to do a thoracoscopic pleural biopsy in the index case. Now again, we have another question to answer. Which thoracoscope to be used? Again, now we have 3 options. The one is called the conventional rigid thoracoscope, which is around 9 to 10 mm in diameter. You have the flexi-rigid thoracoscope, which is thinner, more flexible like a bronchoscope. And you have what we call as mini-rigid thoracoscopes, which are only 4 to 5 millimeters in diameter. Now, there are several studies which have compared the diagnostic yield of various thoracoscopes. And what is the conclusion? If you can see the percentages, it is almost same. Be it rigid or be it flexi-rigid, if you do the proper technique, the diagnostic yield is going to be the same. However, if you have a rigid scope, you are better in doing therapeutic procedures like adhesiolysis or pleurodesis. So in the index case, it was decided to do a thoracoscopy. That point of time, we decided to do a flexi-rigid thoracoscopy. If you can see the pleural image of the parietal pleura, you can see large nodules of deposit which are there. This is called as, this is very typical of a malignant deposits. Again, by looking at the pleura, sometimes you can have a rough idea as to what it is going to be. Presence of this large or variable size nodules or ulcers is suggestive of a malignancy. So in this particular case, by using a flexi-rigid thoracoscope and a flexible forceps, a biopsy was taken. And this biopsy had actually confirmed it to be a metastatic renal cell carcinoma. It was not a lung malignancy, it was a renal cell carcinoma. And as I have said, after the procedure, if you can see, it was both a diagnostic and a therapeutic procedure where the lung also had expanded. Now, this is about diagnosis. So, some of the take-home messages are, first thing is never presume malignancy. Always have to prove. You have to prove malignant cells either in the fluid or tissue. The first investigation of choice is always thoracentesis. Do not jump to thoracoscopy before thoracentesis. So, this is another important thing. Always have to do a pleural tap first. And when you do a pleural tap, always combine cytology and cell block. Don't ask only for cytology, always ask for cell block also. Then if your thoracentesis does not give a diagnosis, then you have to go for pleural biopsy. If thoracoscopy is available, go for thoracoscopy. If it is not available, you can go for image-guided pleural biopsy. And the choice of thoracoscope would depend upon the operator and availability. So this is about getting the diagnosis in a person with malignant pleural effusion. Now next is how to manage. It is always important to manage. So when we diagnose a person with malignant pleural effusion, what are the implications? In most malignancies except mesothelioma, it would become stage 4, including lung or any other disease. So if you diagnose malignant pleural effusion, it automatically goes to stage 4. So treatment is more aimed at palliation of dyspnea rather than cure. So here it has to be a combined treatment where you also try to palliate dyspnea and the oncologist tries to treat the malignancy. So what are the 4 options we have? 1, 2, 3, 4. First is wait and watch. Second is serial thoracentesis. Third is chemical pleurodesis. Fourth, which Dr. Gopal has already spoken, is indwelling pleural catheters. Now, do we actually have to treat every person with pleural taps? No. So, when a person you have diagnosed as malignant pleural effusion, but it is not very symptomatic, you don't have to do anything. So, if the person is asymptomatic, then wait and watch strategy is also correct. Only if you have a person with symptomatic malignant pleural effusion, you have to do some therapeutic or option to improve his dyspnea. It is said that usually the first thing to do is do one therapeutic tap and see whether the person improves. If the person improves, then you can do a pleurodesis or an IPC. The second strategy which I had said is serial thoracentesis. Again, it is not a very ideal or a patient comfortable way to palliate dyspnea because it would require frequent visits, frequent punctures and higher chance of inducing complications. So when would you only resort to serial thoracentesis is if you have a very frail person with a very short expectancy, you don't want to trouble him too much, you just do serial taps once in a while. Or if you are expecting if you have a very chemosensitive tumor where you expect the disease to respond well, you do 1 or 2 pleural taps to improve his breathlessness. The 2 most important things which we would suggest for a person with symptomatic recurring pleural effusion is either pleurodesis or an IPC. So pleurodesis is something which as a pulmonologist we should all be aware of the various techniques, complications and procedures. This is a whole chapter altogether. But what do you mean by pleurodesis? As the name says, pleura and disease. So you want to stick the pleura so that there is no space for the effusion to come. You're not stopping the tumor, not stopping the disease, you're only preventing the fluid from coming there. So pleurodesis, there is again several types of pleurodesis. What we commonly talk as a chemical pleurodesis, wherein we give some substance into the pleura, a sclerosant, to cause symphysis of the pleura by inducing inflammation. Again, several chemicals have been used. The most commonly used one is the talc, but in our country we also sometimes resort to iodopovidone betadine and sometimes to this tetracycline derivatives, but world over talc is the one which is recommended, talc slurry. Again, I would not go into the details of the technique, so but some of the prerequisites is that the effusion should be drained completely, the lung should have expanded well, where the visceral and parietal pleura will oppose each other. There should not be a significant air leak, and the daily output of the ICTD should be ideally less than 300, because the higher volumes, then the success will be lesser. Before doing the technique, as it is a painful procedure, you would want to give some sort of analgesia and sedation. You would give them parenteral analgesics and also intrapleural lignocaine before instilling the sclerosant. Then the main thing is the giving the sclerosant. Again, doses would depending upon the sclerosant which we use. For the common talc slurry which we give, it is around 4 to 5 grams in 100 ml of normal saline for a malignant pleural effusion. Again, which is the ideal agent for chemical pleurodesis? This is a Cochrane review and meta-analysis. It has said that talc powders appear to be more effective than other options, but there are some studies which have also shown that betadine is equally effective as talc. Most of these had a high bias, so I would say that it would depend upon the center and the person's experience. We generally use talc slurry. And now there's also some debate about talc slurry versus talc powderage. Some people do thoracoscopy for the purpose of doing pleurodesis. Are we justified in doing that? There is one trial which has been published recently. This is the TAP study, where people with diagnosed malignant pleural effusion were randomized to receive either talc powderage or talc slurry, and 4 grams of slurry talc was used. And the pleurodesis failure was similar in both the groups, 22 to 24%. So, for the purpose of performing pleurodesis, you don't have to do thoracoscopy only for instilling talc. You can do talc slurry also. Earlier, there was this notion that talc powderage is slightly better than talc slurry, but this study has shown that that is not the case. And again, the second important thing is that the success rate of all these chemical sclerosants is not 100%. It is usually around 75 to 80%. This is something which we have to tell the person also, that the success rate is only 75 to 80%. This is about betadine. This is from our own country, which is a meta-analysis, which has said again that the success rate of betadine or idopovidone is around 90%. And there is no difference between the talc versus idopovidone in this particular meta-analysis. Now that is about chemical pleurodesis. This IPC I would not talk because it has already been covered excellently by Dr. Gopal. This is another option for treating dyspnea, which is because of malignant pleural effusions. Now coming back to the index case, you have done the thoracoscopy, you've done the biopsy, you proved the diagnosis, the lung is expanded. Now how do we treat this particular case? How do we prevent the accumulation of pleural fluid? So this person didn't have a very chemosensitive tumor, lung had expanded well, and the daily drain output was around 250 ml. Now, whether to choose chemical pleurodesis or indwelling pleural catheter, this is a debate which is ongoing for several years, and it would probably continue also. Now, some people have started using this combination approach where they would put an IPC and then do a pleurodesis also. Now, whether to choose a chemical pleurodesis versus an IPC, there are several algorithms which have been proposed. The simplest thing is that if you have an entrapped lung, so if you have a person where there is malignancy, you put a chest drain but the lung is not expanding, then you cannot do pleurodesis. So the only option you have is to put an IPC. If the person has an expanded lung, like in this case, then both chemical pleurodesis or tunneled IPC are said to have to be equally effective. So this is the simplest thing which you have to understand. The lung is expanded, then you can choose either IPC or pleurodesis. If the lung is not expanded, your only option is to put a IPC. So and this is the studies which have compared IPC versus chemical pleurodesis. Whatever data is there, it says that IPC as compared to chemical pleurodesis has a shorter hospital stay. That is the only advantage of IPC over chemical pleurodesis. But it also comes with its own set of problems, that the cost is higher. There is a higher rate of local cellulitis and local infections, and also it needs some sort of social support for maintenance of this drainage systems. So at our center, what we do is if the person has an expanded lung, we would give an attempt of chemical pleurodesis. If the pleurodesis is successful, we'll remove the tube and send him home. Only if the pleurodesis fails, we would consider an IPC. This is what we do at our center. So IPC and chemical pleurodesis are equally effective at controlling breathlessness in person where the lung is expanded. If we want to do chemical pleurodesis, talc is the preferred agent for pleurodesis. Talc slurry is as good as talc powderage for the purpose of doing pleurodesis. If talc is not available, talc cannot be afforded by the person, then cheaper alternatives like betadine or doxycycline can be used in place of talc. So in the index case, we performed a talc slurry pleurodesis with 4 grams of medically graded sterile talc. The drain output decreased, the chest chain was removed in 48 hours and he was sent home. So this is about, in brief, about the management strategy which has to be followed. Now things are becoming more and more complicated. There are studies where they have done IPC followed by pleurodesis. This is called the IPC plus strategy. Then there are centers which do everything in the same sitting. So in our case, we didn't do talc powderage in the same sitting. We could have done talc powderage also. So you can do a medical thoracoscopy by your assessment of the pleura, if you feel that it is malignancy, you can do talc powder in the same sitting. You can do thoracoscopy, do powderage, then place an IPC. Or you can do thoracoscopy, do a frozen section, then decide on pleurodisc in the same sitting. So there are various permutations and combinations. I'm already almost done. So the take home message again, as far as therapy is concerned, is that treat only if they are symptomatic. Do not treat the effusion, treat the person. Second, if the lung expands completely following pleural fluid drainage, both pleurodesis as well as IPC are reasonable options. If the person has an entrapped lung, then IPC is the only option which you have. And always combine definitive treatment of malignancy along with your control of this pleural effusion. This is always important. You should not forget that the disease also has to be given some importance. I think with this, I will end my talk, and thank you.
Thank you, Nagarjuna. That's a lucid presentation. I'm not the villain who is pressing the bell. Actually, Gautam Bachu is signaling me to press the bell. So there is 2 points I need to add. There are 2 situations where we have to keep our eyes open. There is something called lymphoma, which most of the times the pleural effusion figures mimics tuberculosis, where ADA levels will be high. Look at the mediastinum in young patients. Whenever you come across a massive pleural effusions, because most of the times the lymphomas are missed and they will be started on ATTs. So there probably simple flow cytometry, adding simple flow cytometry will give you the diagnosis. Instead of not even, you don't require even a biopsy. Most of the times the another situation where we come across patients who are 40 to 50 years old with equivocal ADA levels, where people tend to start ATT again. So these are the situation probably you have to, where ADA levels are low. You go ahead and do a biopsy, even if it is tuberculosis, confirm the biopsy of tuberculosis and then treat the case. Probably Nagarjuna will agree with that.
I think very valid points about ADA. I think as he has rightly said, lymphoma is one of the malignancies where ADA is high. And also there is something about ADA that low ADA, lesser chance of tuberculosis. As the level of ADA increases, the chance of TB keeps on increasing. But there's also another thing, which is that the ADA levels are very high. Suppose you have ADF around 150 or 200, again that is said to be a subtle pointer towards a non-tubercular cause or a lymphomatous involvement of the pleura. So that is about ADA. So ADA in isolation should not be used to direct therapy, but it should be interpreted in the clinical context, because you have both the false positive ADA and false negative ADS. So that is important. Second, whenever in doubt, you always better to confirm and treat. So as he has said, if the ADA is in the gray zone, that is 40 to 70, so it is always, if you have the facilities to confirm, I would always say you confirm and treat. Suppose you're not able to confirm and you're starting him on a trial of ATT, it is always important to educate the person, tell the person that, see, your diagnosis is not confirmed, we are not sure, but we're giving a trial of ATT. So if you're not responding in 1 to 2 months, we have to redo a biopsy. So the patient has to be told. Second, it has to be documented that you are giving ATT only on a trial basis. So these two are very important. So whenever you are not confirming the diagnosis and giving treatment, both documentation and informing the patient are equally important. Otherwise, what happens is he will take for 6 months and then come back after 6 months saying that the person that I'm still not good, and by that time the malignancy would have even become bad. Yes, so this is what I had said that see, I think if you go 10 years back, people used to say 3 pleural taps have to be done. But then now I don't think that which is practical, and any center is doing 3 pleural taps. So whatever I could see, there is no scientific data to say that you have to, this is the ideal number of taps which have to be done. But the algorithm which I had said has been published in COPM journal. It was very logical that first tap is compulsory. Then the second tap, they have said you do a second tap only if you feel that you have a tumor which is more likely to be diagnosed on pleural fluid cytology. Again, that is a subjective opinion. It is not an evidence-based algorithm. It is the algorithm which they have proposed. So if you have you're suspecting an adeno or a CA breast or something, which is probably not possible before you do a diagnosis, they recommend doing a second pleural tap. At our center, if the first tap is inconclusive, we do not waste time in doing a second pleural tap. We directly go for pleural biopsy. This is what we follow.
Thank you.
Great. So now the IPC plus is a new concept. So the indwelling pleural catheter per se is supposed to cause pleurodesis by mechanical effects. So it is supposed to cause pleurodesis. But the number of patients in which pleurodesis actually happens is not 100%. It is at around 40 to 50% only. So what people have done is they put an IPC, they wait for the lung to expand, they keep draining the fluid, and once they feel that the lung is completely expanded, through the IPC, they will instill a chemical sclerosing agent and then leave the IPC again. So they'll wait for the drain to decrease, and then they'll check by ultrasound whether the symphysis has happened, and then they remove the IPC. So this is called the IPC plus regimen, where they put an IPC first and then do the pleurodesis. This is one regimen. Then there is another school of thought where they do thoracoscopy, do talc powder etch, and then put an IPC. So even if the lung doesn't expand, you have an IPC. If the lung expands, then the already pleurodesis has been done. So as long as the effusion is there, they'll keep draining, and once the effusion resolves, they'll remove the IPC. So this combining pleurodesis and IPC is also things which are being tested. So again, the choice of the agent, I think, would depend upon the socio-economic zone where we are. The whole concept of IPCs is more in the Western world, where the cost of each day of admission is very high. So in those countries where if you have to put the person in the hospital for 3 days, 4 days only for doing a small chemical pleurodesis, it was not working out for them. So they want to do it as a daycare procedure, put an IPC and send them home. So that is how probably the IPC actually come into the picture. So in a country where 2 to 3 days of hospital admission is not a major problem, I would say that we do a pleurodesis, remove the tube and send him home happily.
Comparative data for one over the other procedures.
So there are data. I think I'll just go back to that slide. This is the RCTs. So there are several RCTs. I've only showed RCTs where this is not presented, where the number of patients are more than 100. So there are 3 RCTs which have been published from way back as 1999 to 2017. So whatever RCTs are there, if you look about the palliation of breathlessness, which is the main goal, you do pleurodesis or IPC to palliate breathlessness. So the rate of palliation of breathlessness is similar for IPC and chemical pleurodesis. So why is IPC better? In some countries, what they say is that because the duration of hospital stay is better. That is the main proposed advantage of an IPC, is that the duration of hospital stay is better. But the disadvantages of IPC, as I have said, are that the person goes with the tube home. So definitely local complications are higher. Especially in a country like ours, where if they don't take care of the tube properly, you might end up seeing more cellulitis and more complications.
Even cultural beliefs also. Most of the patients, they don't like go with the tube.
Exactly.
So,
Yes, please. Yes, I think a very, very good question. So you have done pleurodesis once. You remove the tube, send the person back home. The again person comes back with a pleural effusion. Are you justified in doing a pleurodesis for the second time? There is nothing wrong in doing a pleurodesis for the second time.
Considering pleurodesis, you have to think of even prospectively also. Sometimes they may need to go for decortication. These things, once you do pleurodesis, these are the tough cases. So that also one point you have to keep in your mind before contemplating pleurodesis. Surgeons may find very, very difficult.
I think here the only disease where we would want to think is a mesothelioma. Because generally, if it's a malignant pleural effusion, it would become stage 4 and you wouldn't want to do a surgery. So there is, as Sarai said, there's no, in a general lung cancer, you don't want to do a surgery if you have malignant pleural effusion. The only thing is if you have a mesothelioma, then I think before jumping into pleurodesis, if you have a surgically resectable malignant mesothelioma, you wouldn't want to do a pleurodesis. So mesothelioma is the only malignant pleural effusion where you would not want to do fluorodesis head on. You would want to take the opinion of a surgical oncologist, medical oncologist, as Dr. Vamshi has said, sit in an MDT and then decide whether to do fluorodesis or send him for a radical pleurectomy or any surgical procedure. Dr. Vamshi, any comments on this point?
Or any future time lung transplantation, these cases also you have to be very careful.
Yeah. So again, most important part of malignant pleural effusion is going to be the systemic therapy. If you have a mutation and it's a driver mutation, your effusion is going to dry up. You give good systemic therapy, it's going to dry up. So I think that answers a lot of questions. Just don't hang on to the patient, keep giving all these things. Get the treatment started for the systemic part. And often we have seen you put in ICD, give the first dose of chemotherapy, within 1 week it dries out. You don't really need to keep doing all these if it's a malignant effusion responding to treatment. All these other things are very useful when you don't have it responding or it recurs. So that becomes very useful.
I think this is again very important thing. So some of the malignancies where the disease melts to therapy is one, lung cancer with targetable diseases, or if you have something like a germ cell tumor with pleural effusion, or an ovarian malignancy with pleural effusion, or a lymphoma with pleural effusion. These are some of the malignancies where even if the person is having a large symptomatic effusion, you need not do a pleurodesis. You wait for the systemic therapy to act, and usually the disease response. I think this is very, very valid, which I had already commented also, that if you have a chemosensitive tumor, while waiting for the chemotherapy or systemic therapy to act, you are justified in just doing 1 or 2 therapeutic pleural taps and improve his breathlessness. So I think that is again a very, very valid point which has been spoken by Dr. Vamshi.
Thank you, Dr. Nagarjun. It was an excellent talk.
Thanks.
And I think the USP for a pulmonologist while managing a malignant pleural effusion would be they come to you at diagnosis and come to you when you have to manage stage 4 disease. So the session went very well for students. I believe any more questions you could come up with. If none, we'll hand over the stage to next session.
Thank you so much.
Sir, 1 minute. I would request the chair to hand over the mementos for the speakers today. I would call upon Dr. Vamshi Krishna sir first. Dr. Nagarjuna Mathuru sir. I would request Dr. Matin sir to hand over the mementos to our chairpersons next. As we come to the end of second session, we can move on for a tea break now. It will be about 15 minutes. We'll gather back for the next session.
Yes. Yesterday, phone number and
ఇలా రావట్లేదు క్యాన్సిల్ మళ్ళీ ఒకసారి నాట్ వాలిడ్ అండి. అదే తెలిసింది. చూడండి కాదు సరిగ్గా క్లిక్ అవ్వదు. ఫోన్ PPT కూడా ఒకసారి మళ్ళీ ఒకసారి check చేయండి.
I would request everyone to kindly settle down. So we will start with the final session for the day. To moderate the session, I would like to request the chairs to kindly come on the dais. Firstly, I would like to request Dr. Gangadhar sir. Sir is Senior Consultant Pulmonologist at Yashoda Hospital, Secunderabad. Dr. Shrikar sir, Consultant Pulmonologist at Apollo Hospital. And Dr. Samuel sir. He is a Consultant Pulmonologist at KIMS Hospital, Secunderabad. Over to chair to kindly introduce the speaker and start of the session, sir, please.
A very good afternoon to all of you. I once again welcome you all for this last but very interesting session. Now I request my co-chair, Dr. Samuel, to introduce the first speaker.
Yeah.
So it's an honor to invite Dr. Matinuddin sir, who is a senior consultant pulmonologist at KIMS Hospital and is a former director of pulmonary and critical care at Mahavir and Basvi Hospital. And he's going to talk about basics and interpretation of cardiopulmonary exercise testing.
Good morning, everybody. It's nice to see a good gathering of the postgraduates here, and I commend the efforts taken by Dr. Vishwanath and his team to organize this. As Dr. Ashfaq in his lecture suggested that a pulmonologist should have sound fundamentals of physiology, and we can really enjoy physiology when we are dealing with pulmonary medicine. This is a relatively new topic for us, though people contemplate on it for more than 50 years. I try to give you the basics of cardiopulmonary exercise testing, and as far as interpretation is concerned, it's a huge topic. Basically, even for fundamentals of cardiopulmonary exercise testing, usually 2 days workshops are organized and a minimum of 12 to 15 lectures are organized for basics of cardiopulmonary exercise testing. It's not that tough if we know the physiology appropriately. So today what we'll do is we'll insist more on what is cardiopulmonary exercise testing, what are its usages, and how it is being done. Our learning objectives have to be stepwise. I'll try to deal with all these 7 points, but as far as interpretation is concerned, we'll be very superficial or rather skip it. But I'll be very glad if all of you know what is cardiopulmonary exercise testing and you understand how it is being done and what is the importance of it. What is cardiopulmonary exercise testing and what is the need of it? For evaluating pulmonary functions, all of us know we do pulmonary function testing, but that's not sufficient enough, because for any exercise, all our systems are involved. Pulmonary system, cardiovascular system, musculoskeletal system, psychological support, everything is involved when there is stress, physical stress or mental stress. So, in the performance of an individual, doing a simple PFT or a simple 2D echo to know the cardiac functions, or clubbing a 2D echo and PFT, because both these tests are sedentary tests, means the subject will be at rest, he will not be performing. So whatever functions you do, those functions will evaluate only the physiology at rest. But when the person is exerting, when the person is under physical stress, at that time that may not be of much help. So dynamic tests are designed. A 6-minute walk test, but in 6-minute walk test we make the person walk, not exert too much. So it definitely a poor man's cardiopulmonary exercise test, but it doesn't provide all the required parameters for various reasons to completely assess the physiology. But it is a definitely valid dynamic test for the performance of the individual. Then comes the cardiopulmonary exercise testing and what all we do in it. Because we make the patient or the person or the subject to exercise to the maximum capacity possible and record various parameters. Because metabolism also comes into play when the person exerts. So, clubbing physical exercise and doing metabolic evaluation is also important to assess where the problem will lie when the performance is compromised. The advantage of CPET is it's a non-invasive test, but it is also fraught with some dangers. I'll enumerate later on, but right now what we do is we assess how much oxygen is consumed by the patient and how much carbon dioxide is liberated at what level of exercise. So this gives a broader picture of the homeostasis where the person is functioning optimally and which are the systems which are compromised we can corroborate. As all of us know, the work of lungs is ventilation and to provide oxygen from the atmospheric air, then it is diffused across the lungs into the blood and the blood transports bulk oxygen with the help of the heart to various peripheral tissues and there it enters into the cells by diffusion again where it is utilized by the mitochondria for the production of energy or ATP. What are the uses? Where all we can use the cardiopulmonary exercise testing? It can be done to assess the performance of a healthy individual, or it can be done for clinical evaluation of the patient for diagnostic purposes, follow-up purposes, or for preoperative fitness purposes. Risk assessment while doing a surgery. So its utility is there in sports medicine, occupational health, in universities, in pulmonary rehabilitation program and cardiac rehabilitation programs also. In fact, these rehabilitation programs have to be clubbed, cardiopulmonary rehabilitation it has to be called, and then only if a combined approach is there, then the results of rehabilitation will be much better. To start the test, the technician has to be well trained and the technician should detail the patient and counsel the patient before the test. Ask the patient to wear comfortable clothing because patient will be exerting a lot, because when we come to the office we dress formally, but when we go to play we dress in such a way that we should perform the best way. So on all these things, and if the stomach is full we cannot play much, so patient has to be instructed to be on a light meal, but he should not come fasting or starving. There should not be any caffeine usage because it alters number of things. There should not be any smoking, or there should not be alcohol usage within 12 hours of performance of the tests. I'll skip this slide because it is repetition. Because of the cellular metabolism and production of ATP, we are using this. So, in cardiopulmonary exercise testing, we have gas sensors which analyze how much oxygen is consumed by the body and how much carbon dioxide is liberated by the body. I'll show you those slides also. So oxygen consumed by the body means oxygen delivered to the tissues or consumed in the taken inside, and minus oxygen liberated out of the body. That is the oxygen consumed in the body. Similarly, carbon dioxide liberated is also assessed because of high speed gas sensors. When all these systems work in tandem, the oxygen uptake is assessed and carbon dioxide liberated is also assessed during exercise. And the relationship between exercise and consumption of oxygen gives us number of things. So the measuring of oxygen uptake versus exercise is important to assess the functioning of the body or physical exertion. The basic thing is the doctor responsible should take a detailed history, do a physical examination, perform an ECG and basic pulmonary function test to prepare the patient for exercise testing. Because here in exercise testing, patient exerts a lot. Indications for CPET for evaluation of dyspnea where you are not able to diagnose easily in pulmonary rehabilitation. There are certain contraindications for performance of cardiopulmonary exercise testing or stressing the patient to the maximum. Absolute contraindications are a recent MI, unstable angina, unstable arrhythmias, acute endocarditis or myocarditis or pericarditis, history of syncopal attacks on exertion, especially aortic stenosis. Patient may be asymptomatic coming to you comfortably, but in aortic stenosis, when you stress the patient, it may prove to be catastrophic. So, aortic stenosis, when patient is symptomatic, is absolute contraindication. If the patient is not symptomatic, then it's a relative contraindication. Uncontrolled congestive cardiac failure, you should never venture to perform a cardiopulmonary exercise testing. Similarly, history of recent pulmonary embolism or deep vein thrombosis is an absolute contraindication, because when the patient start exerting while cycling on a cycle ergometer or on treadmill, they may get dislodged and land up in the lungs, and it may prove catastrophic. Similarly, uncontrolled asthma or a saturation of less than 85 to 88% is an absolute contraindication. If the patient is a psychiatric case or an uncooperative patient, you cannot perform a cardiopulmonary exercise testing. So that also comes under absolute contraindication. There are a number of relative contraindications where if you are confident that you can manage any untoward incident, you can perform, like pregnancy or moderate stenotic valvular heart disease or electrolyte abnormalities, which you are confident that if any untoward incident occurs, you can manage well, or it may not occur. Then you can, on your clinical discretion, you can opt to do the. As I told you, clinical exercise testing, CPET, cardiopulmonary exercise testing, is fraught with certain dangers and complications, because even though it is generally safe, but has a definite risk of fatal and non-fatal complications. World authorities who are doing CPET for a long time have recorded 1 in 10,000 deaths. Means if you are performing aggressive cardiopulmonary exercise testing on 10,000 individuals, on an average, there is about 1 death. I am not telling this to discourage you. I am telling you, if you are opting for this, you have to be extra cautious. And at least 2 persons should be present, 2 medical personnel should be present when you are performing cardiopulmonary exercise testing. So for optimal patient safety, 2 persons should ideally be present in the exercise room during exercise tests at all times. And your resuscitation trolley and equipments have to be there to deal with any untoward incident. And people have assessed complications. Approximately 1 in thousands tests result in a major morbid event like myocardial infarction, major dysrhythmias, or severe hypertension, and you have to discontinue the study. Now coming to methodology, equipment, modality, and what are the protocols and how to conduct the test. This is the photograph of person performing the test. What are the equipments over here? We attach a leak-free mask which has a flow sensor in the form of pneumotachograph or turbine, depends upon the machine which we are using, but it's like a spirometer which is attached to the mask. So there we record all respiratory, tidal volume, breathing frequency, flow, everything. Then there will be a twin tube attached to the mask which goes to the sensors, oxygen sensor and carbon dioxide sensor, they analyze carbon dioxide level and oxygen level on breath by breath level, because nowadays earlier the sensors were delayed, but now we have advanced sensors which can record these levels breath by breath. Then you continuously record the blood pressure, and if there is major change in blood pressure, you may have to discontinue the study. You have online ECG where any dysrhythmias or any ischemic episodes, you have to discontinue the study. You have oxygen saturation, and if the saturation is falling less than 80 or the patient is very much distressed, you may have to discontinue the study. This is ergometer, means the bicycle. You can make the patient stress on various machines. It can be a treadmill, it can be a cycle ergometer, or if the patient has trouble with the lower limbs, there can be a hand ergometer also. So these ergometers, they have capacity to increase the load gradually, a calculated load, and how the patient is performing on the increasing load, that is gauged, and how much oxygen is consumed and carbon dioxide produced against a particular load, that is also assessed. Nowadays things are simplified because everything is computerized. You get the results on a computer easily. So these will have flow sensors, carbon dioxide analyzer, oxygen analyzer, pulse oximeter, 12 lead ECG, and blood pressure monitor. Taking ABG will be optional. You can attach it for calculation of lactate in various calculations. And how do you increase the load? You can gradually increase the load, which is called continuously keep increasing the load with the time, that is called ramp protocol. Or every minute or two, you can stepwise increase the load, make the patient perform against more resistance, that is called step protocol. Both are valid, this incremental or step protocol or ramp protocol, both are valid. I'll come on to that also. This graded or incremental protocol it is called, and this is called ramp or progressive protocol. So when we plan for a study, we have to do some homework before starting the study. We have to design the study, whether you are choosing a step protocol or a ramp protocol. In both the things, work is gradually increased, and it is found that in ramp protocol, the performance of the patient is slightly better when compared to step protocol. When you are performing the test, you make the patient sit and record the data at sedentary level. Then after 2 to 3 minutes of sedentary recording, you make the patient walk without resistance or cycle without any resistance. Then over a period of 7 to 10 minutes, you gradually keep increasing the load. how much you have to increase the dose, we have to calculate depending upon the performance of the patient. If you are doing in an athlete, you have to increase the load enormously. If you are doing in a patient who is supposed to be submitted for heart transplant or a heart and lung transplant or a lung transplant, then the load has to be gradually increased to a limited level. There are various nomograms to calculate that. We will not go into the details of that. First, you understand what is cardiopulmonary exercise testing and how it is performed. Now, coming on to measurements and graphic interrelationships, how do you do that? When you perform a CPET, you are measuring the amount of work patient is subjected to or subject is subjected to. You are calculating what is the oxygen consumption of the patient per minute, what is the carbon dioxide output per minute, anaerobic threshold. Anaerobic threshold is when the body is continuously performing. After a particular stage, your glycolysis oxygen will be insufficient for production of energy. At that time, anaerobic metabolism sets in the cells and they start liberating more carbon dioxide. So when you plot carbon dioxide against time and oxygen consumption against time, then at a particular stage, the carbon dioxide shoots up. That indicates that is called anaerobic threshold. When the anaerobic metabolism sets in, the carbon dioxide liberation increases. It will be easily depicted in the graphs. Then you see, monitor ECG, BP, respiratory rate, SpO2, ABG is optional to put on lactate. Then you clinically gauge dyspnea and fatigue. If the patient refuses to do after a particular time, then you may have to discontinue it. So this gives maximum work capacity, peak oxygen consumption and work rate. Cardiovascular limitations can be if the heart rate reserve is less. Mechanical ventilatory limitations when the breathing reserve is less. Oxygen delivery problem will be there when lactic acidosis increases enormously. So now coming on to relationship of oxygen consumption and exercise, because as the exercise increases, the oxygen consumption increases, but that will have a particular limit. If you try to further increase the exercise, then oxygen consumption cannot improve. So you plot for oxygen consumption, if you keep increasing the work and plot oxygen consumption in ml per minute. As I told you, initially 2 to 3 minutes of resting recording will be done. Then without any load coming onto this, the oxygen consumption for basal metabolic rate will be different with different weights. So oxygen consumption by a thin individual with about 60 kg weight may not be as high as a huge individual, though the performance of the thin individual may be much better. I may slightly exceed the time. I am trying to skip as many as possible. So oxygen consumption at rest will be roughly about 3.5 ml per minute per kilogram of body weight. This is at rest. So if the patient is heavy, the oxygen consumption at rest will be more. If the person is thin, that has nothing to do with the performance of the patient. When you put some exercise, means if the patient is walking, that's an exercise. If the patient is cycling unloaded also, there will be some amount of work. So at that time, the oxygen consumption gradually increases. So for a 70 kg individual, at rest, it may be about 245 ml of oxygen. But when the patient is performing unloaded, it may increase to about 7.5 ml per kg per minute. So the consumption may increase to about 525 ml. you need not remember these figures, but try to understand what I am trying to say. As the exercise increases, the consumption of oxygen increases. And how we are calculating that? We have a tubing which senses breath by breath, how much oxygen is consumed at this point of time and how much oxygen is liberated. So, means released. So, consumed, taken in minus discharged will give the oxygen consumption. Similarly, carbon dioxide, atmospheric carbon dioxide is negligible. So, it is not. Whatever carbon dioxide is liberated, that is calculated. Here, you are increasing the load on the patient. It can be in the form of a ramp protocol or it can be in the form of a step protocol. Gradually, when the patient is doing, patient will realize that gradually it is becoming tougher and tougher for him to perform. So during exercise, as the exercise increases, it may go to about 10 ml of oxygen per minute per watt increase. Means once you are increasing the load, it is a calculated load and load is calculated in watts. As per watt increase, person will consume about 10 ml of more oxygen per minute. So if a 100 watt load is there, a 70 kg individual may consume around more than 1.5 liter of oxygen. If you give 200 watt resistance and the person is performing, then persons will start consuming more and more oxygen. They will consume more than 2.5 liters of oxygen per minute. So from where oxygen will come? By our breathing. So the rate of breathing, the depth of breathing increases. And if the respiratory system is compromised, then the patient cannot perform optimally. And once the maximum load is achieved over a period of 7 to 10 minutes, then you gradually decrease the load. Drastically you can decrease the load, but ask the patient not to rest. If it is treadmill, the treadmill will go on at rest and patient has to keep walking. If cycling is there, you remove the load, but patient has to keep cycling. Otherwise, there may be severe hypotension and patient may collapse. So, after maximum performance, you need to give a time for recovery. At the time for recovery means you are not asking the patient to lie down or sit down. You are asking the patient to continue walking on a treadmill or continue cycling without load. Otherwise, that will prove catastrophic, and this is important for your diagnostic purposes also. So, initially there will be a resting phase for 2 to 3 minutes. Then there will be a reference phase where you give basic load. You ask the patient to do basic activity without any load, either basic cycling or basic walking. Then you gradually keep increasing the load and plot oxygen against it, against the wattage. After the maximum load, then for 2 to 3 minutes or 5 minutes, there has to be a recovery phase. Every step is important in this. And all these results are plotted against each other because the maximum accepted thing is the 9-panel plot designed by Wasserman. Wasserman is a person who is alive still and he has dedicated his life to cardiopulmonary exercise testing only, and he has a book written on cardiopulmonary exercise testing. So this 9-panel plot gives cardiovascular performance, ventilatory performance, gas exchange performance. Even if the ventilation is normal, the exchange of gases may be inadequate, and metabolic parameters. So I am intentionally avoiding going into what are all the plots and how we have to read it. If we plot oxygen consumption against the wattage of exercise we are subjecting the patient, then you deduce what is the physiological nature of limitation of exercise capacity, whether it is his circulatory system, whether it is his gas exchange, whether it is his ventilatory system, whether it is his metabolic system. Even if all the things are good, the patient may not perform up to the physical capacity if the patient is not motivated properly. So motivational issue also is involved, because even if I can exercise more, if I am not motivated to exercise, I may feel tired early and I may ask to discontinue the test. So in evaluating exercise limitation, you have to define ventilatory limitation and also cardiovascular limitations. For ventilatory limitations, you have to determine what are the contributory factors for limited ventilatory capacity, whether it is the decreased breathing reserve or dynamic hyperinflation, mechanically disturbed breathing system, ventilatory system. Now, normal reference values are also important, because until and unless you know what is normal, you will never determine what is abnormal. So, oxygen consumption at rest, as I mentioned, it is about 3.5 ml per minute per kg body weight, and it is called a MET. That is metabolic equivalent. So, strategic interpretation of cardiopulmonary exercise testing will have, we have to assess what is the maximal exercise capacity, what is the predicted peak oxygen consumption, whether a patient has reached or not, then whether the patient has adequate circulatory capacity, whether heart rate is adequate or not, whether heart rate is shooting up. If the heart rate is shooting up beyond 200, you have to be cautious and you may have to stop the study. Similarly, any ventricular ventilatory limitation means the patient becomes dizzy, hypoxemia occurs, then you have to discontinue the study. Similarly, severe lactic acidosis also can be a limitation if the at tissue level patient is not able to utilize the oxygen adequately. I have tried to skip the things which may not be easily understood, and it can be studied theory wise. Now, regarding performance of and utility of CPET, if any questions are there, then I'll try to answer as per the best of my capacity.
That was an excellent talk by Dr. Nritin. So this is a new technique, though it had been there in the clinical practice since past decades, but of late we started using it in our clinical settings. So there may be a lot of questions. We are all learning. I think with the lack of time, we'll skip on the questions. Sir will be available. Whoever wants to have more clarity, you can discuss with him. So now we move on to the next talk. Thank you, sir. Now I invite upon for the next talk, that is basic bronchoscopy, bronchoalveolar lavage, transbronchial lung biopsy, endobronchial biopsy by none other than Dr. Balaraju Tadikonda. It's my privilege to introduce Dr. Balaraju, a brotherly figure to me, And whoever know Balaraj, I think is a very friendly nature. I never heard any no from him for anything. So basically, to become a good interventional pulmonologist, one should have a passion towards it. Those who are handling the equipment may not become a good interventional pulmonologist. You should have empathy, you should have concern for the patients. So, after listening his talk, you all agree with me that what Balaraju is one of the doyen in the interventional pulmonology field. So, without taking much time, so Dr. Balaraju, please start your talk.
Thanks for the very kind words, sir. So first of all, I'd like to thank Team AIG for inviting me here. So this is what we're going to do in another 20-25 minutes time. So we are going to discuss about all these four topics. So a normal airway anatomy, steps of basic bronchoscopy, bronchoalveolar lavage, transbronchial lung biopsy and endobronchial biopsy. So this is going to be very, very basic. I just want to put it as basic as possible. So just bear with me because we're going to speak about anatomy, all that stuff. So first of all, we need to understand the complex endobronchial tree and its different segments. So while able to correctly navigate the desired segment and subsegment is a cornerstone in being a good bronchoscopist. So this I could only understand when I started doing a radial EBUS. So why this is very, very important? Unless and until you know the bronchial tree, basic bronchial tree, segments, subsegments, you will not have access to the periphery of the lung. So what we used to learn prior is to do with a therapeutic bronchoscope, you can hardly go to the lobes or a segment. So after that you can't reach anywhere. So if you learn the right bronchus has upper lobe, intermediate bronchus, middle lobe and lower lobe, that's more than sufficient. But once you go to the periphery of the lung, so you need to have a very good idea where you are navigating your scope. Unless and until you have a good idea, you will not understand where to go and from which part to do a segment. So not knowing where to go or improperly oriented in the same time as driving is just like a driving a new place without a GPS or a proper direction. So you will not have any clue what you're trying to do inside the maze. So this is a neglected part. When we do bronchoscopy, we generally don't see this upper airway much, but it starts from nostril and ends with larynx. So being able to navigate through these structures isn't enough. So we need to identify any structural defects, mucosal changes, pathological features, and document it in the final report. So I'm not going to go in details of what are the different lesions that we noted from right from the nose to the larynx or from the oral cavity to the larynx. So there are different aspects there. So coming to the steps of basic bronchoscopy, and I feel this is most important. First, you need to calm the patient before the procedure. So remember, we are posting a patient for a bronchoscopy, they will be very, very apprehensive. So you need to just take time and explain the procedure, give a good topical anesthesia like oropharyngeal and laryngeal anesthesia. So nowadays we don't do transtracheal, we only do topical lignocaine sprays. So I feel this is what is very, very important when you start doing your bronchoscopy. First, basically explain the patient that this is what you're going to do, and try to give a good local anesthesia. And I always prefer to do any kind of bronchoscopy procedure, whether it can be a just diagnostic bronchoscopy, bronchoalveolar lavage, anything without a sedation. I generally don't do it because it is not so easy to do, because as we are taught that just talk to the patient and do the procedure, but it is okay for a quick diagnostic bronchoscopy. But when you want to take some time to assess the tracheobronchial tree, I think you should have a good sedation so that the patient is calm and your procedure is smooth. So always have an IV access, attach a monitor with ECG, SpO2 and blood pressure. Then position of the patient is important. Just that I'll come to it in the next slide. So you need to select the bronchoscope for the procedure. So when we started our bronchoscopes nearly 15 years back, we used to have only one bronchoscope. So that's a therapeutic bronchoscope with a 2.8 working channel. For any kind of procedure, it is the same bronchoscope, but that doesn't hold good if you want to do many cases. So with a therapeutic bronchoscope, it is not so easy to do a good bronchoalveolar lavage. So that we'll come to that point later. So you can prefer nasal or oral route. So
I prefer to do with a nasal route with a thin bronchoscope. If you want to do a nasal route with a thick bronchoscope, generally it's painful. Always remember, don't cross the outer diameter of bronchoscope 4 mm if you want to do a nasal route, because most of our patients and even us, we have a deviated nasal septum. The room of the nasal cavities are low, so it is a pain when you're doing it. So oral route is much easier, but only thing, if you want to do an oral route, you need to take the patient to a bigger sedation level so that they will tolerate the oral route. But oral route is very, very tolerable. So always spray with lidocaine. So this is what we do: spray as you go technique once you cross the vocal cords and the tracheobronchial tree. And you negotiate the bronchoscope in the tracheobronchial tree and try to be in the center as much as possible and examine all the bronchial segments. So this is what I was trying to tell you, the position of the patient. So we generally practice this, that is called a posterior approach. We stand behind the head end of the patient and you do a bronchoscopy. So this is called as posterior approach. But there is another approach called an anterior approach. This can be done either in supine position or in a semi-recumbent position. So we need to have an idea of doing both ways, because predominantly we will do in this position, but we need to do have an idea in this way, because whatever we see in the monitor is all reversed if you do in an anterior approach. And this is how it's going to look in an anterior approach. The epiglottis is this side, whereas in a posterior approach, this is what the epiglottis looks, and this is how the vocal cord looks in an anterior and posterior approach. This is what we are routinely used in doing it. But we need to have this idea also. This is generally useful when you want to do a bronchoscopy in ICU patients. They are semi-recumbent, they can't lie down. So it is not so difficult to do it, but you should have an orientation of the structures before doing the procedure. So coming to the head position, this is more usually talked when you are doing a rigid bronchoscopy. So when in supine position, you have oral axis, pharyngeal axis and the laryngeal entry axis all in different planes. So when you do head elevation with extension, and all these three axes come in one line. So why this is important? You can ask me, sir, we are doing a flexible bronchoscope. What is the big deal in doing in this position? But remember, when we do, even though we do in a flexible bronchoscope, and this is what our head position in most of the cases, even we know or unknowingly will put in this position. The reason being, so remember, this is a flexible bronchoscope, and doing a basic bronchoscopy with a flexible bronchoscope is not challenging in this position. But the only problem comes once you use some kind of accessory inside the working channel. So when you're using the accessory inside the working channel, so that's the time where you can damage your bronchoscope when there is more bending happening. So always remember, as much as possible, keep in one line so that the bronchoscope is in doesn't have major curves, and your whatever you are doing passing inside the working channel doesn't have a problem. So coming to the larynx, so this is what we see once we cross the oropharynx, and this is called the laryngopharynx. And in the laryngopharynx, what we see is the epiglottis. Once you cross the epiglottis on the left and right side, you have the pyriform fossa, and anterior to the epiglottis, you have the vallecula. These are the structures needs to be visualized before entering inside the vocal cords. So why? There can be a pathology there, or there can be some kind of findings. You can easily find it and document it. If requires any necessary thing, you can do a biopsy or brushing and whatnot. So once you cross the epiglottis, and this is how you see the laryngeal structures. So this is the entry part of the larynx, where you see the posterior side of the epiglottis. That's the left and right aryepiglottic folds. That's the arytenoids and cornicate and cuneiform cartilages. And this is the posterior part of the cords, and this is the anterior part of the cords. The anterior part of the cords called anterior commissure, and you have the true cords, right and left true cords. And just above the true cords, you have the false cords. And between the true and false cords, you have the vocal fold. So there can be lesions anywhere in the larynx, something like a simple polyps, lung cancers, or granulomas, or anything like that. So this is what we are more worried of. So how to negate our bronchoscope inside this maze? So to make this simplifier, so this is why we have that bronchopulmonary segments. So we all know that the left and right lung has 10 segments. We're not going to go in detail. So we all know the anatomy, how the lung divides and all. And this is how the segments, bronchopulmonary segments look in the two sides of the lung. So how does the nomenclature of the bronchial segments come? So you have first the lobes. So after the lobes you have segments, and these segments are numbered as 1, 2, 3, and the subsegments are numbered as ABC, and after the subsegment the number as I, and after that it is X and Y, and after that is alpha and beta. So this is how these subsegments are numbered. So if you want to go only to this area, so your routine bronchoscope is more than sufficient. That bronchoscope can go to till at least to the segments, and you can do whatever lesion is available there, you can target it. But once you cross the segments and you enter the segments, you need to have an idea where you are going, and you should know the path. Unless and until you know the path, you will get confused. And this is what the routine system which is followed. You basically start naming the segments with from apical, posterior, lateral and medial. Apical, posterior, lateral and medial. So let us think there are different segments available, and this is how you start naming it. So you can start as 1, 2, 3 or A, B, C, and this is what the rule you follow. You start apical, whatever is in the apical comes first, then posterior, lateral and medial. So the trachea divides into right main bronchus. The right main bronchus has the right upper lobe. The right upper lobe has 3 segments, RB1, RB2 and RB3. RB1 is the apical. As I told you, apex comes first. RB2 is the posterior, next is posterior, and RB3 is anterior. So there is no medial in right upper lobe. So again, the right main bronchus after right upper lobe takeoff divides into right intermediate. So intermediate has right middle lobe bronchus. So middle lobe bronchus has medial and lateral segments. So RB4 is the lateral segment, RB5 is the medial segment. Again, lateral, medial, and that is how you do nomenclature. So right lower lobe, so that's the basic pyramidal bronchus. So that divides into right basal bronchus, that is RB7, 8, 9, 10. So RB7 is the medial basal segment, 8, 9, 10 is apical, lateral and posterior subsegments. And next is the superior segment or the RB6 segment. So in the left main bronchus, you have the left upper lobe bronchus divides into left upper division. So again, it's same LB1 plus 2 and LB3. LB1 plus 2 is apico posterior, LB3 is anterior. So left lingula is superior and inferior. So again, superior is LB4, inferior is LB5. So left lower lobe bronchus, there is no medial basal. So it is 6, 8, 9, 10. So there is no medial basal. There can be a variation, but usually this is what it is. So this is what we're going to see in next couple of slides. Please bear with me. I'll just be as brief as possible. I don't want to take much time in this segments and all. So this is the same repetition what we have seen. So this is the same repetition what we have seen. So that is the right upper lobe bronchus apical, posterior and anterior. Just 7 minutes. I'll just go faster. So I feel that these segments everybody knows. I don't have to go in detail. So I'll just go to the other topics. You can take some time. Okay. So again the same repetition. The right main bronchus, the right upper lobe, the intermediate bronchus, the right upper lobe has RB1, RB2, RB3. Intermediate bronchus divides into middle lobe and the right pyramidal bronchus. Middle lobe has RB4, RB5, and the pyramidal bronchus, that's the segment 6, the superior, and lower lobe basal segment bronchus, that is RB7, that is medial basal. RB8 that is anterior, RB9 is lateral, and RB10 is posterior. So this is the same which holds for left also. So this is the left upper lobe and lower lobe. So the left upper lobe upper division is LB1 plus 2 and LB3, that's apico-posterior and anterior. So this is lingular bronchus, LB4 and LB5, that is superior and inferior. So this is the left lower lobe bronchus, again the superior segment LB6. So pyramidal basal pyramidal bronchus LB8, 9, 10. So anterior, lateral and posterior. So this is the same thing we are trying to identify all the segments in bronchial tree. So I'll just skip to the main part. So once you cross the vocal cords, you enter the trachea, you go down inside to look at the carina. So you rotate clockwise 90 degrees to enter the right upper lobe, apical, posterior, anterior. Then after you see the right upper lobe, you rotate your bronchoscope counterclockwise. You enter the right intermediate bronchus. Then you see that's the middle lobe bronchus, 6 segment, 7, 8, 9, 10. So just going to skip this. So coming to the bronchoalveolar lavage, what is this? This is a minimally invasive technique for evaluating the immunological, inflammatory and infectious process, taking a sample from the alveolar level of the lung. So originally described in 1970s, referred to as liquid lung biopsy. Why? Because we are collecting samples from the many parts of the millions of alveoli. And remember, this is not bronchial wash. So when we were postgraduates, we used to just do bronchial wash and say it is bronchoalveolar lavage, and that was wrong. So why? Because in bronchial washing, you just hardly require 10-20 ml. So you put your bronchoscope at the bronchus and you just do a washing. So this doesn't have a good yield, neither in sensitivity or specificity if you have a distal peripheral lesion. So what we need to focus is on bronchoalveolar lavage. The key technique in how to do bronchoalveolar lavage, we'll just come to it. In whole lung lavage, we use 20 to 30 liters of saline. So why this is performed today? For routinely in patients with pulmonary infiltrates with presumed infectious etiology or suspicious of neoplasm, not for solitary pulmonary nodules, if there is something like a bronchoalveolar lavage that has the highest sensitivity for doing a ball, and also for alveolar filling process like alveolar proteinosis and alveolar hemorrhage. So training is essential in order to do a proper bronchoalveolar lavage. So avoid the procedure related complications, learn to protect your equipment and do it. So what we require? You require a bronchoscope, you require a mucus trap and you require a syringe and a saline, normal saline at room temperature. That's more than sufficient. So these are the steps to be followed if you want to do a good ball technique. You require good sedation and cough suppressant. You should select your bronchoscope, your target lobe, how to wedge the bronchoscope, how much amount of fluid to be instilled, and how to recover the fluid. We'll just come to it one by one. So again, I've told you, bronchoscope selection is priority because you need to wedge the bronchoscope inside the segment. If you want to wedge the bronchoscope inside the segment, you need to select the bronchoscope. So your therapeutic bronchoscope that's 6 mm outer diameter is not going to good enough to wedge inside the segment. You need to go for a lesser diameter scope. And target lobe is very important. If you are doing for diffused lung diseases, right middle lobe and lingula are the best target lobes because it is gravity dependent areas. You have the maximum recovery of return fluid. So what is a wedge technique? So basically you need to pass the bronchoscope inside the segment and wedge the scope. Please do not remove the bronchoscope while aspirating. So this is the common mistake everybody does do when they do a bronchoalveolar lavage. They instill the saline and they do suction and try to come out proximally. So once you come proximally, there is contamination of return fluid with the proximal airway secretions. So how do you say adequacy of the ball? You can see a supernated fluid which is white in color, and this is what is documented. The recovery should be more than 50% of the installed volume, but you can get a good diagnosis even if it is less than 50%. But remember, the cornerstone, what we need to understand is to do a good wedge technique. If you practice a good wedge technique, your recovery will increase, your recovery fluid will increase. So in cytologically, how do you say? You have fewer than 10 alveolar macrophages per high field level, contains excess number of epithelial cells, contain mucopurulent X-rays, polymorphs. If you have less alveolar macrophages, that means your sample is not so adequate. So what is the role of ball in lung cancer, especially for bronchoalveolar carcinoma, but not so great for solitary pulmonary nodules? And it for peripheral pulmonary lesions, don't do a bronchoalveolar lavage. You are hardly, the positive rate is less than 25%. It's not going to serve any purpose. And remember, now getting a cytology positive is not going to help anyway in patient management. So what are the complications and adverse effects of bronchoalveolar lavage? So mostly hypoxemia, because you are instilling fluid. There can be a transient hypoxemia which is reversible. Fever is documented. and there can be an increased density in the chest radiograph or CT. If you do a chest radiograph post procedure, there can be few alveolar, there can be a few crackles or alveolar infiltrates, and obviously because there is a fluid instilled, it will take some time for recovery. There can be a decrease in spirometric levels, and if you do a very bad bronchoalveolar lavage, there can be pneumothorax also. There is documented. So coming to the next point, that is transbronchial lung biopsy. So as the name says, basically it is a procedure performed with a flexible bronchoscope with the use of biopsy forceps. You go inside the peripheral part of the lung and take a lung samples from the peripheral tissue in order to diagnose the interstitial lung disease or to specifically characterize a peripheral lung lesion. So you have something abnormality in the peripheral part of the lung. You pass the biopsy forceps deep inside and try to take a biopsy of it. So that's called transbronchial lung biopsy, where it is indicated in diffused or localized lung infiltrates. So there can be any of this, or in pulmonary nodules or masses, you can pass your biopsy forceps inside the nodule or the mass and get a biopsy. So what are the contraindications? So if you don't have any good equipment, insufficient training, if you have coagulopathies, thrombocytopenia, so all these are relative contraindication. You can easily correct them and do the procedure. So what can be the complications? Yes, if you pass the biopsy forceps much distally touching the pleura and you take a biopsy, then there can be a chance of pneumothorax or a bleed. If there is a neighboring vessel which is bleeding, there can be, these are the two main complications what we see after transbronchial lung biopsy. The most commonest is pneumothorax. Usually it is very transient. There can be bleed, there can be a normal bleed, but few cases there can be moderate bleed also. So how to tackle the bleed, we'll just come to it next step. So you choose your biopsy forceps. So this is what is very important. The regular biopsy forceps, what we use regularly to do procedure is the 1.8 mm biopsy forceps, and this is not a very good biopsy forceps if you want to do a transbronchial lung biopsy. Always prefer to do with a 2.2 or a 2.4 mm biopsy forceps. There you can get a bigger amount of tissue. So this is very important if you are doing TBLB. So you can start doing with 1.8 mm biopsy forceps, but the biopsy bits are very small. There can be more crush artifacts. So is fluoroscopy needed to do a TBLB? Definitely it will aid in probably decreasing the amount of pneumothorax, because in your fluoro you are able to see the biopsy forceps. So the best segment to do transbronchial lung biopsy is segment 8, because it is the lateral vessel segment, because in line of the fluoroscopy, the bronchoscope can be seen touching the pleura or not. So that's the best segment if you are doing for a diffuse interstitial lung disease with a fluoroscopy. So that is the main advantage if you are doing with a fluoro, and also you can document pneumothorax if there is a pneumothorax. So avoids need for post bronchoscopy chest radiograph, basically to see whether there is a pneumothorax or not. So coming to the technique, so this is what everybody follows. That's called the wedge technique. So what we need to do is to select the target lobe. So you pass the bronchoscope so that wedge inside the segment. So once you wedge the bronchoscope inside the segment, you pass your biopsy forceps with cups closed. So pass the biopsy forceps with cup closed till you feel the resistance, or you switch on the fluoro and you see whether you have reached the pleura or not. So once you feel the resistance, you can just pull a 1 centimeter inside proximally. So once you pull 1 centimeter inside, then you can open the forceps now and push gently 0.5 centimeters. Then you can close the forceps and extract the tissue. And this is what is classically described for transbronchial lung biopsy. So this is a very easy technique. If you follow the steps properly, this can be done in good sedation, doesn't require intubation or any extra airway. But what is important is to minimize the amount of complication, that's bleeding, pneumothorax, and the rare cause of death. So once there is bleeding, so what we can do, you can do a tamponade, because remember we are wedging the bronchoscope inside the segment, so that itself can help in minimizing the bleed. So you can instill some vasoconstricting agents, but I always feel that you should have some kind of balloons in your bronchoscopy room, so that you can pass it and safely secure that segment. So Fogatis come in different sizes. Nowadays you have Fogatis which can pass inside your bronchoscope working channel. So easily you can pass inside the bronchoscope working channel and wedge the segment so that the bleeding is controlled. Most of the times if you wedge the bronchoscope for a couple of minutes, bleeding will stop. Fogati is always handy. So in some cases when you have a huge amount of bleeding, you can isolate the you can isolate the main bronchus with what is called as bronchial blocker, Cook's on bronchial blocker. These are not passed through the bronchoscope but has to be passed beside the bronchoscope. But they are good balloons so that you can isolate one lung if there is a massive bleed which is happening. The first thing what we need to do when there is a bleed, first intubate the patient, control airway. If you have rigid, that will be very handy. If you don't have a rigid, at least pass an endotracheal tube, then you pass an balloon bronchial blocker and control the bleeding. Coming to the last topic, that's endobronchial biopsy. As the name suggests, what we are trying to do is to biopsy inside the airway. So you can do in two ways with a biopsy forceps. You can use a needle biopsy forceps or a cup biopsy forceps. Ideally use a serrated biopsy forceps where you can have a very good amount of tissue. So this is the straight on approach and this is the angulated approach. These are very easy to do because it is you don't have to bend the tip of the bronchoscope, just pass the biopsy forceps and get a tissue. Whereas these are technically difficult because you need to bend the distal part of the bronchus and get a biopsy. But the challenge happens when you have to do a mucosal biopsy. So if your biopsy part is in line with the bronchoscope, that is in parallel with the bronchoscope, then that is the part where it is challenging to do a biopsy. The best way to do is to shear technique. Just hold the mucosa before removing it, just pull the bronchoscope with it, the whole mucosa shears it up. So just a few points on how to do an endobronchial biopsy. Basically, you will have two different varieties. One are fungating lesions and other smooth surface lesions. Fungating lesions are easy to biopsy. These are the more fragile. They can easily biopsy. You don't have to go much deep inside the lesion to get a good tissue. But these are very tricky. So this smooth surface lesions, which are very red in appearance, even if you do a surface biopsy, most of the time you will get only fibrous tissue. So in these cases, you need to go inside the tissue and get a biopsy. And this can be challenging, especially when you are dealing with a carcinoids. So they can bleed a lot. So just be cautious while doing a procedure. To summarize, we should know the airway anatomy. That's a cornerstone for any bronchoscopist. So BAL is an effective tool for diagnosing non-resolving pneumonias and certain alveolar conditions. The best is a good wedge technique, and minimal amount of saline is required is 100 to 150 to 200 ml amount of saline, and with a recovery rate of more than 50% of the instilled saline. And I always feel manual aspiration is much better than suction. The reason being, if you do manual aspiration, the bronchus doesn't collapse immediately, and you have a good amount of return rather than the suction. Because remember, the suction, wall suction, what we use is a very high suction. It doesn't it collapses the bronchus. The recovery is very slow. So TBLB is easily performed in outpatient procedure in bronchoscopy room. Fluoroscopy eliminates the needs of post-procedure chest radiograph and also patient safety, because you can see whether you are touching the pleura or not. So the chance of pneumothorax decreases. Always use a larger biopsy forceps when you are doing a TBLB. And endobronchial biopsies, especially for smooth surface lesions, it's better to get a deeper biopsies. Otherwise, your biopsies are going to fail. And always remember, whatever you do, always have a Fogarty balloon in use, because once there is a bleed which is happening inside the airway, it is you who has to manage the bleed. So Fogarty will be of great use, especially if you encounter a massive bleed. Thanks for a lot, patient listening. I took more time, I feel.
That was an excellent talk, Dr. Balu.
I'm very sorry I rushed in many things. I didn't want to trouble you putting all those different segments, how the segments look in bronchoscopically.
Still, message is very clear. So proper patient selection, proper selection of the equipment and technique, and before applying proper learning. So you should be very much thorough of these techniques. Then only you apply on the patients. So we can take one or two questions if anything, because this is basic in bronchoscopy. So you postgraduates, you may be having some questions. You can clarify with Dr. Balu.
Good morning, sir. I just have one doubt. What is the proper sedation dosage required? Most of the time it is under dosage or
Yes.
is fear of overdosage.
Yes, yes. So I didn't go to that part because now I start explaining all the sedations. It will be a big deal. So this is what I do in my practice. So first, no bronchoscopy without a sedation, unless and until I feel that airway is a difficult airway. In mean to say, are you dealing with a difficult airway, or it is a stridor or a near collapsing airway? If these 2 points are not there, so every bronchoscope is with sedation only, period. So I generally don't do any bronchoscope without sedation. Let it be diagnostic or simple bronchoalveolar lavage. Especially bronchoalveolar lavage, you can't do awake. It's very, very difficult. You will not have a good yield. So coming to the what kind of sedation I use, I always combine. So I use benzodiazepines with narcotics. That's a fentanyl. So this is my standard combination. So this is what I've learned in many years. What we are taught, like you just give 1 mg midazolam, that's more than sufficient. You do your procedure, and that is a blunder. I feel that once you do your bronchoscopes with 1 mg midazolam or 2 mg midazolam, is not going to work. So always, this is what is a cornerstone. You titrate your dose. Very, very simple. Titrate your dose. You give a dose, you observe the response, and you see how the patient is responding. If the patient is more awake, active, and if he is more coughing, you give one more dose. So this is what I practice. So you start with the lowest dose. I generally give 2 milligrams of, for a healthy adult, 2 milligrams midazolam and 50 micrograms of fentanyl. So basically, once you give this drug, please don't immediately do the bronchoscope. You need to wait at least 5 minutes time. And this is another mistake everybody does. So once you give immediately, they go inside. No, that's not going to work like that. Midazolam and fentanyl will take time because we are not doing thiopentone or propofol. They are very rapidly onset, but this will take some time, at least 3 to 4 minutes. So once you cross that, then slowly you can do your procedure. Then after every incremental dose is only response. Let us think my procedure is just less than 3 or 4 minutes. With that dose, I am good enough. I don't repeat the dose again. So there is no standard dose for a patient. That's what I believe. So you give a dose, you see the response. If you feel that that response is not good, and you increase the dose. I generally increase by 1 milligram midazolam every 5 to 7 minutes.
Thank you, sir. Thank you.
Yes.
Yeah, these are the words of wisdom, which the periods of lot of experience over decades, this you don't find in any textbooks. This is a fantastic talk, Dr. Balu. Just I have one question. See, in one of your slides, you said transbronchial lung biopsy from lingular and middle lobe. I think some controversy also there in that.
My point is bronchoalveolar lavage lingular and middle lobe, sir.
Not for biopsy.
No. No, biopsy, I always go for the lateral basal segment.
Yeah.
Because invariably, this is what I do before doing a cryolung biopsy. Now I've given up transbronchial lung biopsies. So before doing cryolung biopsies, even for cryo, it holds good. Because if you want to get a good fluoro image, so if you want to see the probe touching the pleura or not, see, remember, so whatever is anterior or posterior, it is not good for fluoro. So whatever is lateral is very good for fluoro, because you will have a very good idea whether your forceps or the cryoprobe touching the pleura or not. So if your probe is going like this and your fluoro is this, you will absolutely have no idea whether it is touching or not. At the end of the day, what we are trying to do, we are trying to minimize the pneumothorax, and we don't want to go and touch the pleura. So if you want to do that, and if you have diffuse DPILDs, I always feel that either you select left or right, segment 8. So that's the lateral basal segment. So that's the best. Segment 8 or segment 9, both works well. So the lateral part of 8 or 9. So they will give you a very good fluoro image. And till now in all my biopsies, I didn't encounter a pneumothorax. The reason only being because you need to be very, very cautious when you are doing. So you can ask me, should you not do a procedure if you don't have fluoro? Answer is no. No, you can do your procedure even if you don't have a fluoroscopy, as long as you stick on to the principles. So once you have a resistance, please don't insert the biopsy forceps further. Once you feel the resistance, just pull proximally, open the cup, push 0.5 centimeters inside, and hold the biopsy and get it out. So the answer is very clear. Have fluoro, use it. Don't have doesn't mean that you should not do your procedures.
Excellent, excellent. A lot of information. I think with that we close. A big round of applause to Dr. Balraj.
Thanks a lot, sir.
Yeah. Now we move on to the next session.
So it gives me immense pleasure to introduce Dr. Harikishan Gonuguntla. He is a senior consultant interventional pulmonologist at Yashoda Hospital, Secunderabad. So as we are all aware, Dr. Hari is extremely passionate about procedures in pulmonary medicine, and he shares a vast amount of expertise and experience in right from the basic procedures to the most advanced procedures in interventional pulmonology. With this, I hand over to you, Dr. Hari, to share your expertise on the basics of medical thoracoscopy.
Thank you for the introduction, and I thank AIG Hospitals and the organizing committee, Dr. Vishnath sir, Gautam, Deepika, Vinay, Chandan, and Nishant and Raghav for the opportunity. So I was asked to talk on basics of medical thoracoscopy, and I'll keep it very simple because it's a PG class. So our objectives will be knowing the anatomy of the pleura, skills, what are the skills you need before performing thoracoscopy, how do we select the patients. I think this discussion was done yesterday already by Kedar on, that means already we know what kind of patients we will take up for thoracoscopy based on the pleural fluid analysis that was extensively dealt yesterday, and what type of anesthesia is safe during medical thoracoscopy, and how do we monitor these patients during the procedure and also after the procedure, and what are the currently available instruments that are available for thoracoscopy, and what are the procedural steps, and also we will talk on few complications regarding to thoracoscopy. So coming to anatomy of pleura, we all know there are two pleural surfaces, one is visceral pleura and parietal pleura. So the idea of interest when it comes to medical thoracoscopy is mainly on the parietal pleural surface, where we examine the parietal pleural surface and take biopsies for a diagnostic thoracoscopy. And whatever fluid forms between these two spaces, we call it as pleural effusion. And also you should know some understanding on the intercostal nerves and vessels, their placement, and also the layers of tissue starting from skin to the pleural margin. You have your external and internal intercostal muscles and all these things. So basic anatomy of these things is necessary before you start to learn how to do medical thoracoscopy. And what are the skills required? Skills required, if you look at the training competence, at least you should be able to do 20 procedures under an observer. And to maintain that competency, every year you should be performing at least 10 thoracoscopies in your institute individually to maintain the competency of medical thoracoscopy. For beginners, it is easy if you do more number of therapeutic thoracentesis so that you understand how the needle puncture and all happens and what are the different, the tactile sensation comes the more you do more of pleural procedures like chest tube insertion and all. So chest tube insertion, again, when you are doing with the trocar, it is a little less helpful when it comes to medical thoracoscopy. When you do the incision technique, that is almost the same as how you insert the trocar in thoracoscopy. And use of biopsy forceps, again the same, since if you use a semi-rigid thoracoscopy, the biopsy forceps and the mechanism of how you maneuver the scope remains the same as a flexible bronchoscopy. So those who have a good skill of performing bronchoscopy also will have a skill of doing semi-rigid thoracoscopy. And how do we select these patients? So diagnostic procedures, usually pleural effusions of indeterminate interval. So whatever diagnostic evaluation you do in pleural effusions, 20 to 25% of these patients doesn't have a proper diagnostic end. So those are the patients you choose to do a biopsy after discussion. And also in patients who are on chemotherapy or patients who have like on treatment resistance to TKIs and all, then also you might need a pleural biopsy to help your oncologist. And in TB, especially for biopsy and culture, and also some used to do thoracoscopy in pneumothorax also. But again, we can discuss in our practices because VATS remains the primary mode of treatment option there. Coming to therapeutics, again, it depends on the operator. Some restrict themselves performing diagnostic thoracoscopies. I usually do only diagnostic thoracoscopies because I have a good VATS unit. Some aggressive intervention thoracoscopists, they do these kind of paraneumotic effusions and local adhesions and all these breakage, those things. Again, it depends on place where you are working. If you don't have a surgeon, then you have to do those procedures. Coming to the contraindications, these are the basic contraindications not to perform thoracoscopy in these patients. Especially before starting thoracoscopy, you need to have a checklist and then see these medications are not being used by the patient on or before the day of procedure. So stop these blood thinners as per these protocols. This you can find it in the textbooks. And pre-procedural evaluation. So we all will have an X-ray already by the patient comes to you. Ultrasound becomes mandatory to do before starting a procedure. And ABG and PFT not routinely done for all patients, but if the patient is like a moderate respiratory failure, then you can ask for these investigations. Again, there is no hard rules like you only have to do these investigations and all. ECG is mandatory before the procedure, and coagulation parameters INR more than 2, usually 1.5 is the cut, and around 2 up to 2 we can safely do a thoracoscopic procedure. And electrolytes and serum creatinine, especially those patients who undergo hemodialysis, also is a very important thing. How when to do thoracoscopy in these patients who are on dialysis, because they have they have the tendency to deteriorate if the dialysis time is after your thoracoscopy. And coming to patient preparation, important to take consent, because there is a very low mortality also associated with thoracoscopic procedures, and some patients can have prolonged ICU stays. Though the incidence rate is very less, but it is important that you mention these complications in the consent, and then also the NBM protocols as per your anesthesia protocol. If you are doing whether you are doing under conscious sedation or you are doing under general anesthesia, and the comorbidities like especially CKD to be well controlled using HD before the procedure. And coming to anesthesia, again it depends, like those who prefer to do semi-rigid thoracoscopies, some do on bedside. Preferably it is not recommended to do thoracoscopy in ICU setups, but we see a lot of hospitals perform thoracoscopy in ICU on the bedside of the patient, because there is a chance of infections in these patients. So those who perform semi-rigid thoracoscopy, they prefer to do under conscious sedation. Most widely used agents are midazolam and fentanyl. Some use propofol, but there is a chance if the patient is like a OSA patient, or if he is having some comorbidities or very obese, there is a chance of hypoxia in these patients. So again, a discussion with your anesthetist on what kind of anesthesia you use is also very important. Coming to conscious sedation, midazolam combined with fentanyl is the preferred agent in our setup, but again it depends where you start to do. And monitoring these patients, oxygenation, SpO2 monitoring, cardiac ECG is mandatory during the procedure. And depth of sedation and pain, sometimes you may have to monitor EtCO2 levels also in these patients, especially patients who are very obese. Coming to the equipment for an thoracoscopy, you need to first localize the site for the procedure. You can do an ultrasound examination, and then the thoracoscopy table is very important. The height of the table should match yours and your assistant's height. That because if maybe that day it will be very easy for you to do procedures, but if you don't adjust the table heights on a long term, you will have health problems. And the choice of thoracoscopy based on availability, and also some conditions, like if you have a clinical suspicion of mesothelioma, preferably it is advised to do with a rigid thoracoscopy than going for a semi-rigid thoracoscopy in those centers who have both these facilities. And all the basic instruments. And when it comes to positioning of patient, always the patients, you will lie on the patient side with the head towards you. There should always be two monitors. One monitor where the operator who is doing the thoracoscopy will be looking at, and the other monitor, the assistant who is standing in front. So usually the assistant stands with a table. So he will be standing with a table, means a foot table under him, and then he will be assisting the procedure, and he also should be able to see what the operator is doing in these cases. And you see here, C is the anesthetist, he will be standing there, and one nurse will also be useful for you to help for your procedure. Coming to differences between rigid thoracoscopy and semi-rigid thoracoscopy, there is no difference of diagnostic yields, especially in common conditions like TB or malignancies for diagnostic purposes. But again, your experience, your training, and utility where you work, these things will determine what kind of scopes you use. So rigid thoracoscope usually are less expensive. They're very robust and large endurance, means they don't usually break or cause any damage, how the semi-rigid thoracoscopes are sent for repairs. And if you look at semi-rigid thoracoscope, it is more easy to learn the thoracoscopy with this because you already do flexible bronchoscopies and it's almost the same technique what we use in this procedure. But breakage and maintenance costs are more when you do rigid thoracoscopy, and it's also a very costly equipment. And if you look at the parts of rigid thoracoscope and semi-rigid thoracoscopy, the trocar, again, there it will be a metal trocar, and here you have a flexible plastic trocar. And then these are the basic differences between an optical forceps that we use for rigid thoracoscopy and the normal flexible forceps that we use for flexi-rigid thoracoscopy. So coming to the procedural steps, so first examine the integrity of the thoracoscope, and then position the patient, lateral decubitus position, and then these are the recommended sites where you can put your trocar. But again, it depends based on, because nowadays we don't do thoracoscopy without an ultrasound guidance. So based on the ultrasound, you can mark your incision site. There is no mandatory rule like how we teach PG students during MD that ICD has to be put in this angle and all. It's because it's under control, like we can control what happens during medical thoracoscopy. And it's not that fluid is always generalized in the pleural cavity. And USG is being made mandatory before doing the puncture for medical thoracoscopy. Usually, again, incision depends on what type of instruments you are using. So lignocaine, infiltration, and then incision followed by expansion of the incision, and then putting the trocar and then inserting your thoracoscopy. So the basic steps that you should follow is before putting the thoracoscope, if you have a large volume effusion, ideally it is recommended that you remove some amount of fluid with the suction catheter so that the visibility with the advantage here with the semi-rigid thoracoscopy is that it has got a suction along with it. So you can visually suction and then remove the fluid. And then you should remove most of the fluid, because in some generalized diseases like TB, you will see the adenocarcinoma and all, you see the pleural cavity infiltrated with nodules or anything throughout the pleural surface. But on the radiology, if you are suspecting, you don't see much suspicious lesions on the radiology, it is better you remove all the fluid before so that you can examine the entire pleural cavity. And most of the times what happens is clinically, some people tend to not to suction or remove the costophenic rhesus fluid. Like they will think that the intercostal drain will take care of that fluid. But what happens is once you finish the procedure and then take an X-ray, that area will not expand because there are loculations underlying in that area. So that is also very important to clean out all the secretions as much as possible, all the fluid what is possible in this. And then biopsy technique, we know it's like try to do biopsies on the ribs so that you don't cause injury to the vessels. Grab and pull motion, just open the forceps just before you see the lesion and then touch it and then grab and pull to the side. So if it is a semi-rigid thoracoscopy, 6 to 12 biopsies are recommended as per the textbooks. But again, with a rigid thoracoscopy, 1 to 2 biopsies also will do. So there will be some areas where you have doubt whether this is adenocarcinoma or TB, because some overlap exists between these two. So there is something what we also, I learned from one of my friend. What we do is when we do a semi-rigid thoracoscopy, you just use the same brush what you use for cytology. Try to brush the pleural nodules or the areas where, and then you can take a decision based on the brush cytology. Like if you do a rose on the thoracoscopic brush, most of the times if it is a malignant infiltration, you will understand that there is malignancy and you can continue doing your talc pleurodesis. So this is one very important thing where we can work and do something. And coming to procedural steps, post procedure you have to put an ICD, and some common appearances. Malignancy usually is a diagnostic modality on a thoracoscopic appearance. You will understand most of the malignancies by looking at. Some may be in isolated nodules like this. And coming to medical thoracoscopy in pneumothorax, there are some centers which do this, but if you look at the literature here, some practice doing look at the success rate of management of recurrent spontaneous pneumothorax using medical thoracoscopy as the primary option. It's almost coming very close to that of thoracotomy and VATS. May not be the same in all conditions, but this paper has described a good success rate of medical thoracoscopy also in recurrent spontaneous pneumothorax, but not ideally recommended. And following the patient after a medical thoracoscopy in malignant effusions, on-table fluorodesis is better than doing a talc after you put an ICD and send the patient to the ward. So that is how you do. And looking at the complications nowadays, because of the talc properties, we don't see any complications. And a neoplastic invasion of the thoracoscopic tract is documented in some cases. Even I have seen one patient where we have an MP-NST which got infiltrated into the thoracic cavity. So for this, it is better not to do too much of manipulation. When you do and also ultrasound, what happens is on the ultrasound, if you have a large nodules, try not to puncture at the site of the nodules. That is where some people put the trocar exactly next to the nodule or onto the nodule, and then that infiltration happens onto the wall of the thorax. So that one thing we can prevent if we are careful. Subcutaneous emphysema, a minimal subcutaneous emphysema is common after the procedure, but better not to make the patient cough too much during the procedure or after the procedure to prevent this complication. Usually is a mild complication, nothing much to worry about this. And complications of chest tube placement, if you look at this one, if you put a small bore chest tube, malpositioning of chest tubes is less common compared to placing large bore chest tubes after medical thoracoscopy. So preferably it is better we keep small bore chest tubes because there is no difference in the efficacy of these chest tubes. And how to make thoracoscopy safe? The mortality rate is very, very less, even less than your transbronchial lung biopsies. So early chest tube, so whatever complications that happen after a medical thoracoscopic procedure is because of placement of these chest tubes for a longer time and causing infections. So infection remains the most important complication that can happen after medical thoracoscopy. So it is better to remove chest drains. And if you look at, what is the ideal time to remove these chest drains? Like you can even remove the chest drain immediately, like 4 to 6 hours after the procedure in most of the diagnostic thoracoscopic procedures. There are some centers, they just remove the chest drain immediately 3 hours after the procedure and send the patient home. So in this way, you can prevent complications. There is also a paper that studied this and found that early removal of chest tubes is more useful than keeping the prolonged chest tubes after thoracoscopic procedures. So just briefly, I'll present 1 or 2 cases. So first we'll look at the common appearances. So again, yesterday I heard the talk from Kedar, like too much ADA is not a very diagnostic of, like very high ADA levels are not very diagnostic of TB. Leave the papers and all these things, but what happens is when you misdiagnose based on ADA and the patient turns out to be malignancy after some time, it's going to be a medical legal issue. So it is very important to document a tissue when it comes to pleural effusion when you are in even 1 to 2% of doubt whether it is malignancy or TB. So there is nothing like you are doing some very big invasive procedure trying to avoid a medical thoracoscopy that will sometimes burn your hands also. So this is a patient. So usual tubercular appearances will be like the classical appearances of those grains what you see, but sometimes this can be, so looking at this thoracoscopic appearance, what do you think this patient is having? A very diffuse infiltration of the pleural cavity, and also you can see on the visceral pleura also is also studded with nodules on the borders. You see these borders. So again, these are cases where you have an overlap between, because the clinical picture of pleural fluid analysis may not be completely. I am very pro towards doing a medical thoracoscopy in such cases. Again, this turned out to be TB, but such a huge infiltration usually we don't see in tuberculosis. And then coming to malignancy, usually malignancies are very straightforward cases. So on the CT also sometimes you see nodules here and there, and then when you do the thoracoscopy, you see these kind of these things. So in these cases, doing a brush, like if you are in doubtful cases like TB versus doing a brush, doing a rose, and demonstrating malignant cells on rose at the on the day of thoracoscopy also will help you in doing talc fluorodesis in this patient. This is a case of round cell neoplasm, and two cases I will show you some rare neoplasms what we have come across during medical thoracoscopy. So this is one patient who had got a melanoma of the skin some time back and then treated, again comes with a very rapid accumulating pleural effusions, and you can see the type of nodules. Like if you do more and more number of thoracoscopies, you also visualize and understand what is the pathology here. And these nodules were very soft to touch, not very hard. So this is a case of malignant melanoma metastating to the pleural cavity. And then so I had this patient. You look very closely at this patient. Like this patient had a single the other pleural. He is a case of neurofibromatosis, and then you see that pleural cavity throughout the examination remained normal, but on the side of the trocar, you see there is a large nodule here. So sometimes you can extend your incision and even under local anesthesia also you can put one more under vision. You try to infiltrate, you see the infiltration of lignocaine here. This is how it happens when you infiltrate lignocaine. You can see in this case very clearly. And then put your telescope from the other side, and then you see there is a this is a large malignant proliferation of this NST. What happened in this case was during the procedure, after 3 to 4 months of this procedure, this patient was subjected for a VATS excision of this single lesion, and then after 3 to 6 months, this patient comes with complete infiltration of his thoracic cavity because of during the surgery. During VATS, what happens is the trocar goes in directly hits the neoplasm. So that is not very uncommon. So it is very important for us, especially when you have this kind of large tumors, not to put your trocar into the lesions and try to avoid these areas. And the last case, like recently we had a patient who had a sarcoma and then comes to the pulmonary department with the pleural effusion. When we do a thoracoscopic examination, you see a large sarcoma metastasizing to the pleura. Sent him to the surgeon, but since there is a diaphragmatic and liver infiltration, they said he's not a candidate for surgery. So in this case, what happened is we did lot of biopsies with flexible bronchoscopy, not able to get hold of the tissue because of its lobulated and soft nature. Even cryobiopsy, 3 to 4 seconds, it was not freezing well. Looks like a very cryo-resistant like of tumor, but finally we got a diagnosis. It's a metastatic sarcoma from the pleura. And then other concept, like if you see the previous textbooks that mention that contraindications in medical thoracoscopy without any fluid. So this is from my students. So this is a patient, you see this is suspected malignancy, and then on the chest X, on the CT scan and also on the ultrasound, you don't find any pleural effusion. So in such cases also, you can safely do a medical thoracoscopic procedure under local anesthesia without doing any double lumen intubation and all, if you are performing it carefully. So in this case, it's a dry pleural effusion, what we say. In this also, you can document pleural cavity and also give a tissue diagnosis with medical thoracoscopy. So these are the common things what you should understand during thoracoscopy. And my take home message for today's lecture is medical thoracoscopy is a very safe procedure, should be learnt and done by all MD residents during their course. Minimum numbers are 20 procedures during the course and 10 numbers to maintain the competency. And the most reported major complications are bleeding. Knowing indications and contraindications will help you to avoid these complications. and especially CKD patients know when to do thoracoscopy before or after dialysis. That is very important. And monitoring after the procedure and during the procedure is very important, because some people just after finishing the procedure they leave the patient, and then you get a call from outside saying that these patients have are like having respiratory failure and all. So that is also very important. So with this I end my lecture, and any comments from the audience I'm happy to take.
Okay, thanks a lot, Dr. Hari, for that lucid presentation. We are open to questions, please, from the audience. Okay, I have one basic question for you, sir. It's like, when exactly do we take a back step when it comes to deciding about a medical thoracoscopy or VATS for a patient? Just a few clinical scenarios, if you could suggest.
VATS, again, it depends. Like if you, some people are very pro on doing what I believe is, it may not be true. We as a pulmonologist, however good we are, we will not be able to give 100% result when it compares to a surgeon. So in cases where even there are 20% left out additions, that might impact morbidity of patients. So if you have a good unit where you can perform VATS, ideally those patients need to be sent to them, like doing something to relieve those additions. Because most of the times what happens is, in a moderate parapneumonic effusions, 100% you will not be able to relieve. Again, you have to go for a STK and all these things. If you look at the cost that is involved with all these things and the hospital stay, a single session of a VATS procedure can be, most of the times, even in our center, since the VATS is done very frequently, once we just give an incision and put the trocar and see that, okay, we cannot handle this patient to 100% result, we call the surgeon and ask him to take him directly for the thoracoscopic VATS procedure. This should be the rule. Sir, I don't have that much volume to compare and see how much is the failure. Yes, thoracoscopy, our volume is less. I think Gangar sir has more volume on thoracoscopy. My volume is very less on thoracoscopy, but failure, again, what happens is, most people I see thoracoscopic talc insufflation, they just spray here, there, and then close the cavity and come back. That is where most of the failures happen. So uniformly, if you spray talc procedure, good results will come. Now again, the concept of talc with IPC and all coming up, we are more towards IPCs nowadays. So that much volume with me is not there to say exactly this is my failure rate and all. Very less cases of talc fluorodesis I have. Again, in that concept also, if you see, compare VATS talc insufflation to a thoracoscopic talc insufflation, because practically, if you speak, everybody might have these problems. When you start doing talc fluorodesis, something you should understand, all the PG students, like wearing appropriate glasses and all, because this talc, if you put close all the lights in the room and then put one single light and see, the talc after you insufflate in the pleural cavity, it will be around you in a very big this thing. So exposure to talc is very, very common, and it goes in the eyes. We don't know what happens, and we don't look at these complications. And when they press the talc, the operator, I tell them very clearly that not to stand straight. Sometimes what happens is, this talc, there will be 2 or 3 holes for the medical thoracoscopy. Sister tries not to close one hole. So once you press this, the whole talc splits on, and 2-3 people will be there, students will be there, and they all get exposed to this talc. So it's a very complicated material. So we should also talk on safety during medical thoracoscopy, wearing appropriate glasses to prevent this talc contamination also. So this is one thing. No, nowadays we actually do like that only. During talc, no, I cross check, because recently I had exposure in my eyes. You don't know if fluorodesis happens here. What happens? You put talc in your eyes.
Yeah.
No, it is something we usually miss. Even if you do a proper talc with a closed incision, you close your lights and see how much talc will be there around you. Single port in the sense the semi-rigid small one. The rigid semi-rigid thoracoscope, mini thoracoscope from Wolf. No, what I am saying is even if it is a single port thoracoscopy, there is a suction at that attachment. You have to attach the cap. So what happens is these are small areas. If we don't look into, like, the talc has to be kept in a bottle and it has to be better. If you keep some small leak also, there will be spread of talc into the atmosphere.
Okay. Yeah, one question from the audience, please. Yeah, go ahead. Yeah, please go ahead.
Good afternoon, sir. Thank you, Vishnath sir and team, for this wonderful CME for us. Sir, I have a question regarding can we perform medical thoracoscopy in cases of massive pleural effusions, and how much fluid is safe to remove on the table during procedure of medical thoracoscopy to prevent pulmonary edema?
See, pulmonary edema is something that you, it's not that it is not there. It happens during procedure, but very rare. How much to remove? If you ask me, my experience, like malignant pleural effusion patients usually tolerate even if you remove large amount of fluids in them. So there are instances where we remove 2.5 liters on table also. Most of the times they don't have, because most of the times their lung parenchyma, lung is not expanding. So in those patients, like if there is a parenchymal lesion or some restriction where the lung doesn't expand, in those patients, even if you remove the full thoracic cavity fluid also, they don't experience these problems. But when you have a very minimal parenchymal infiltration of the malignancy and then a very acute pleural fluid that happens, like a large pleural effusion which happened very short time, and then you try to remove that fluid, then these are the instances where. So textbook says so many things, like you have to remove 1.5 liters, and then after that, because pleural fluid pressure measurement during thoracoscopy is not easy, even if you use those manometers and all, because it is a variable thing that happens during thoracoscopy, because there is again some amount of pressure equalization when you open the cavity and then keep it to the atmosphere. So there is no definitive thing. What you can do is, like, it's not an essay question. Like when it comes to practice and learning is different. In theory, in a Viva you may answer all these things, but when it comes to practical scenarios, how to prevent these things you should understand. So what you do is, if you are considering that this patient might have some problems, so better you do a thoracentesis, just like you post the procedure in the afternoon, you remove like 1.5 liters in the morning, and then take him for thoracoscopy. And another problem here is, the more needles you put, the more problems as an interventional pulmonologist or the thoracic surgeons will have. So every area you poke the thoracic cavity, there will be an adhesion that will form. And some patients will develop rapid adhesions because of 2 or 3 punctures. So PGs do prick 3 or 4 times, no? So what happens inside you don't see. Inside what happens is, every area where you prick wrongly or properly also, there is an adhesion that will form with the lung. So that point also we should understand.
That is very nice question. The apprehension of when we are removing more, there may be a re-expansion pulmonary edema. But mind you, even if you take out 3 to 4 liters also, nothing will happen. This is our experience. Because while you are going into the pleural cavity, you are also creating some positive pressure. Pulmonary edema develops because of the rapid expansion and there is more negative pressure. But you are putting a cannula, all air is going in and there is some positive pressure. This apprehension will be there, but we have seen that even up to 4 liters also you can remove, nothing happens, because positive pressure is going on. So this is general apprehension, but you need not worry. But the thing is, patients do develop pulmonary edema, but they start coughing. That is the first instant you must suspect. So there you can stop draining and give some time, then again you try. So that is a very relevant question.
So one other additional point which we add here is, to your question, it is, I know the textbook description is about the negative pleural fluid the pleural elastin should be less than, 20 is the cutoff or something. But what happens is, if your visceral pleura has a rind or a peel around it, even if you remove as less as 200 ml, you'll notice, like if you see any article on trapped lung or lung entrapment, you'll notice that there's a steep drop in pleural fluid elastance. And just as Sir said, the patient would either start coughing or the patient will complain of a sharp chest pain. It won't be localized, it could be a central chest pain also. So when you're doing a pleural tap, especially for a malignant effusion or maybe a rheumatoid effusion or any long-standing pathology, you decided to do a pleural tap for some reason, just make sure that you instruct the patient to inform you as soon as they feel this central chest pain, or when they start coughing, obviously you'll make out. But a subtle chest pain, just wait and make sure. And you can also obviously connect the saturation probe and make out, but these are late signs. Clinical signs come before the desaturation.
One last point I forgot to tell you. How many of you had this experience? Like you go for a effusion in a young lady and then you remove the fluid. By the time you go for a biopsy, again the lung will be coming up to the pleural cavity and you will not be able to take biopsy. So what do you do there? So this is one common problem that happens during basic bronchoscopy, basic thoracoscopy. So you keep the patient deeply sedated at that point. So the patient starts to take low volume breaths. Now the lung starts to collapse down. This is very common thing that happens during routine thoracoscopies. So we remove the fluid and then we go in with the biopsy forceps and the lung is already up to the pleural cavity. So this is just give fentanyl dose, wait for some time and then again go inside to take the biopsies. Thank you.
Okay, thanks a lot, Dr. Hari, for your enlightening session.
Coming to the last talk of this session, tips and tricks for history taking and physical examination, a very important topic. To discuss about this is, I would like to invite Dr. R. Sunil Kumar sir, who is a professor and head of the department of pulmonary medicine at Andhra Medical College. He also is a serving superintendent of Chest Hospital, Vizag. He has more than 20 publications to his credit. Please, sir.
Thank you, sir, for this wonderful word. And I personally thank Dr. Vishwanath sir team and AIG team for giving this excellent opportunity. The ambience that the postgraduates can going to learn a lot of things here over the last 2 days. And thank you very much, sir. Today I'm going to take the topic of Vishwanath has given me the tips and tricks of pulmonary medicine case taking as well as physical examination also. So, I would say the government hospital for chest and communicable disease, Visakhapatnam, and this is around 10 acres area, sir, and we are having exclusive 250 bedded pulmonary specialty hospital. And this is a brainchild of so many doctors, especially the earlier superintendents of the hospital, namely Dr. Ravindra Babu garu, who has spoken already here, and it is manned already by Dr. Kotlingam garu as well as others, and myself as well. Balu is also coming from this institute. There are so many, experts in the across India. They are trained here, sir, and we are having 250 bedded hospital. And thank you, sir. We are having exclusive IRL lab as well as a nodal DRTB center apart from that. And at any point of time, we are having around 120 to 150 inpatients of the pulmonary. And this is a exclusive pulmonary postgraduate teaching institute. And I request all the speakers to come to our hospital and give lectures also the period. Thank you, sir. Thank you very much. And we are providing the excellent service and intervention procedures to all our poor and needy patients like medical thoracoscopy, bronchoscopy, rigid and fiber optic bronchoscopy, and even for rigid as well as for cases also. We are extending support of the anesthesia from the Department of Anesthesia, and twice in a week we are posting most of the cases like Thursday and Friday. And thing is that we are having 14 pulmonary postgraduates of MD intake per annum, sir. So that is how we are having 42 postgraduates at any point of time. Even in this hall also we are having 25 of my postgraduates. All of you please lift your hand. Yeah. Actually, I would have sent all the postgraduates also, but because at any point of time we are having 100 plus cases on the board, So I could not send every postgraduate here, sir. So regarding the coming to the topic, am I audible? Yeah. So regarding the topic, of course, we know the mechanics of patient's history, like chief complaints and history of presenting illness, past medical history, medication, allergy, family, so on, and social history. These are all the things we usually see in come across even case taking right from the undergraduate days to the postgraduate exam preparation also. But my tips are on how to do a good job on getting it, and clinical examination become now a very obsolete. Many of my residents are also coming with radiographs in their CT in their cell phones only before I see the cases, and they are telling every finding also in relation to this. And we have a excellent WhatsApp group where all the X-rays are coming to the WhatsApp group. Not only X-rays, all the CT scans, all the in the form of films and videos also coming. So there is no great chance of doing clinical examination, but yet we still very insist on doing clinical examination on every patient, and we have a class on every day between 2 to 4 compulsory right from the Monday to Saturday. So the first and foremost thing I would like our postgraduates impress upon on this PG meet is that engage the patient and get comfortable with you, and introduce yourself first by the name and the position, and what are you exactly. I'm a postgraduate or a consultant, like that, and smile and try to communicate warmth and effectiveness, because there's a lot of apprehensions are going around in the minds of the patient. So you have to make the patient comfortable before you are taking an examination, and ensure the patient is comfortable, like just like offer a pillow or a blanket if they need one, and inquire about their bed comfortable, and just as importantly, make sure they are comfortable. Just pull over chair and get down to the eye level, so that they feel that they are very close to the doctor who is examining. So you have to make a rapid of these things, and make it a habit to close in touch with your patients. So set the scene. Tell the patient the purpose of being here. I am here to get some information about your chest pain or the dyspnea, or some complete examination of the respiratory system. And if you anticipate, you will get calls or get pages sometime. So tell them that I want to let you know the advance in what I am, and I'm on call for emergency in the hospital, and may have to answer my cell phone during the discussion also. So make sure that you are very inclined and you are interested to take the next 20-30 minutes of his time, as well as to make a impression upon taking the. So building a rapport is quite difficult. What we are seeing in 15 to 20 minutes of this thing, connect to patients at the human levels is quite a difficult task. So taking some social history first, and for example, what you do work and what you do used to do for the work and all like that, so that you make a rapport with them. And such an information is very useful in establishing a cognitive and educational baselines also. But importantly, it may reveal some shared interest also. The very interesting fact that we place the patients mostly on the bronchoscopy table, but they're very apprehensive and all. So when I go to them, I ask them, "Ye ఊరమ్మా నీదని?" They say Parvatipuram, something like that. Oh, మా ఊరే అని చెప్పి అంటాం. So that they feel that they are very close to the consultant as well as that. So you have to give some kind of a verbal anesthesia, something like that, before you do bronchoscopy in most of the cases. So likewise, before taking the clinical history as well as the physical examination also, be important that you might reveal some shared interest also, and let the patient speak initially. So usually all the patients, they will very keen on telling their history as well as the problems and all. So you should have a patient hearing, and then interrupting a patient early in their opening of the statement and reverting rapidly to closer questioning often prevents the patient from disclosing relevant information. So you have to give the time for the patient to interact with you. So he will open some statement like that, and something description about his disease as well as the problems. So you have to give a patient listening. The doctor is allowed the patient to finish their opening statements. More medical issues will be raised. and there was reduction in the late rising problems. Most of the patients, if you don't give time, so before they're going out of their chambers as well as consulting chambers of the examination place, they say that they're having a mild or a moderate cough pain, and sometimes during the presentations. So it is very, very trivial to them, but it is very serious for us to make a note of the pulmonary thromboembolism like that. So it is always better. You have to give them a good, time to speak, and you have to listen to them patiently. So before going to patients, I feel I allowed my postgraduate to present papers as well as the others also in the posters in the Upsacon State Conference. We have the biggest presentation squared, as well as we got the prizes also, and even the NAPCON also we got the medals in presentation as well as. And this is the different postgraduates. So we are there in this hall. They got the best paper presentation in NAPCON. So clinical examination history taking is also very equally important. They always tell their symptoms in non-medical terms. So they started enumerating their problem in their own language. Only thing is you have to be attentive, and you have to give them a patient listening, and you have to convert them and interpret all them to the medical terms and draw the differential diagnosis, something like 4 or 5 or 3 or 4, whatever it is. And basically when you approach your patients, you make sure that the pathology is starting either in the parenchyma, either in the pleural level or the airways level, or the combination of the level like pleural effusion, how it starts, and the pneumonia, how it starts, like a cough, fever, as well as expectation also. And some patient who is telling the chest pain, but the chest pain is decreasing and he is having increasing of dyspnea, that means patient is going for a massive pleural effusion right from the minimal pleural effusion. So these are all the things which you have to make a note when you are taking a clinical examination as well as a case taking. And there are different points to ponder, and differently there is an approach to the patient of the stable patient as well as the critical ICU patients in the respiratory examination is totally different, I suppose. So you have to make a necessary changes in your approach also. So by the end of the first year of the medical school, most of us would like to memorize important headings like past medical history, allergies, medication, something like that. But as you become more senior, you will also add more subheadings of this major heading, and like for instance, a background of medical tissue like diabetes or high alcoholism. Subheadings can include the treating physician when they are last seen, and how well the COPD or asthma are the conditions which is control or complications of conditions like hospitalization and acute exacerbation. So when you see a patient, I think you have to retrospectively draw some kind of conclusions or imagination this after 2 weeks or 3 weeks, how this patient is going to be, whether going to recover or going to land in some kind of complication or something. So you have to anticipate all this kind of future happenings in the patient's condition. That is what we are supposed to do. And what is important in view of clinical examination, and what is the role other than judging the clinical efficacy and expertise of exam going students. Always our patients are coming with a radiograph, and after evaluating from different places. So you have to make sure that should not get biased by the radiograph, and keep starting taking the history as well as a keen physical examination also. So there are also special components of history which might give you important clues to the diagnosis, but often get missed also, such as something like a pet animal exposure ethnicity, the recent travel history, and the developmental defects in the history also, pregnancy, so forth. And clinical examination history taking is also equally important, because you have to draw a case sheet where you can grab the diagnosis very easily. Something you have to ask them sometimes, like what is the origin of the cough? Is it the throat level or something like a lower chest level? They may be able to tell sometimes, and it's very difficult. It's not very difficult them to differentiate when you ask them. So always ask for a worthwhile to ask about snoring also, even there is no non-obese patient, because there is an undiagnosed OSA like presentation very often in the society actually. So don't be afraid of to change up your diagnosis at any point of time. The patient may come with one diagnosis, whereas your diagnosis will throw some other thing. So don't get biased and don't get afraid to change the diagnosis also, because it's a dynamic state of events that patient is having anchoring. The pneumonia may to go in for empyema or something like that. Empyema may go in for pneumothorax. So always keep open your eyes regarding the physical findings as well as the outcomes. But one thing is that you should always keep noticing your senior clinicians how they are and how they're going to come into arriving into a particular diagnosis also. So I suppose all of you should explore lung just like a window for many systemic disorders, especially skin and interstitial lung disease, which is very often we come across in our practice as well as in the exams also. And you should always make note, lung is not a single individualized as a isolated organ. It has its connections to all the diseases. So you have to explore just like it's a lung window is a window of many systemic disorders. Sometimes the mild hemoptysis is more dangerous than the massive hemoptysis, because massive hemoptysis sometimes because of bronchiectasis may happen, but it's not going to kill the patient unless it is asphyxiating the airways. But mild hemoptysis, which the patient may ignore, is most likely leading into the case of a malignancy. Like that, you have to make sure that each symptoms is having its own implication. Always make a habit of tracheal auscultation as a part of auscultation at the end, and identify the cardiac disease and to differentiate from the pulmonary and cardiac pathology. I request all our postgraduates to impress upon this program and like to point. No person can become a good chest physician unless you are able to differentiate the cardiac pathologies also. So cardiac pathologies are also easily missed and get worse also in most of the cases. So you make sure and keep an open eye for making a diagnosis of a cardiac disease, and then never jump into put in ICD and trauma cases, because in most of the times while patient once upon a time, and in my duty also, one patient came that in the tribal hostel they're playing kabaddi also. They went for canting and somebody grabbed from behind. So he had some kind of a pain chest and he came to us. After taking X-ray there, they said fluid level in the chest. So they came to me. So but they are thinking that we're going to put some ICD for the pneumothorax or hydropneumothorax. But after taking careful history, I found that he might have a diaphragmatic rupture. So we had went into the CT scan and all. So take home messages for any traumatic hydropneumothorax or hemopneumothorax. Try to place a rail tube in the rail tube and go for an X-ray or a CT scan also before putting an ICD if the patient gives a time to do that. So likewise for all the thoracoscopic cases, for our residents, we tell them to take a CT scan in the real picture on the table. It's like a ultrasound support is there on the table. So likewise, it is not there in any paper or any literature. But I think it's very useful tips also to take a CT scan on the, a particular position where the movement of the fluid can be easily assessed on table. Most of the, I think, thoracic surgeons are, pulmonary intervention pulmonologists have the luxury of having ultrasound in the CT, in the theater. I think that is also going to help a lot. But it is always prudent to provide a ultrasound, and on-table ultrasound is very, very important. So ambiguity is the enemy. Learn to summarize also. This is a very single thing that all the postgraduates should always keep an open mind, and don't be in in confusion to put some diagnosis. If you are in such a clear-cut confusion, then make a 2 or 3 diagnosis, differential diagnosis. And throughout the history, it is important to stop every now and then, and again and reflect back to summary and what is the patient has told to you, and it's aid to your memory, and make sure that you understood the information and sequence of events also. So know your cognitive bias. So don't get biased with ultrasound reports or a CT scan, whatever it is you hand. You take your own history as well as the physical examination, because it's a dynamic event. lung hemodynamics like that, pulmonodynamics also, you have to make sure of taking into your mind. And this is the World Asthma Day celebration in the Vizag. We have done in 22, and we are a large gathering of public awareness campaign in the beach road also. And this is got identified and notified in the GINA website also. We are very happy to announce that GINA has published in their website about the general awareness activity on the asthma from India. And there are 4 centers in India. They have done this program on that day. And coming to the proper topic, the latter version of the history taking is highly shaped by the experience and knowledge. That is what all allows to certain physicians to become very efficient. However, we have a different kind of bias like overconfidence bias, confirmation bias, availability bias, and wisdom. So you should not get carried away by the different kind of bias. You should be always make a diligent and a clear cut diagnostic things. So knowledge is the key. You cannot efficient and balance history. Without knowledge, taking of history and physical exam is not also useful. So you should have also up to the mark and build up a knowledge. So not know what aspects of history are relevant and which questions to ask also very, very important. I think you should always go to textbooks before you complete your 6 months of residence in post-graduation. So deep understanding of all conditions is impossible, especially when starting out. However, there are some things you can do help. And likewise, whenever you have a problem and interpreting cases, just like it's a pain origin as well as the site onset characters, whatever the undergraduate programs you learn, you apply that and come to a conclusion also. And watch your patients always is very, very important, because most of the patients, most of the doctors and the physicians, as well as post-surgery also, they don't give a patient time to observe the patient when they're coming to your consultation chamber or to the casualty also. This is very, very important. Why? Because I have a very immense, vast experience because of my guru and Dr. Nageshwar, who works in NIMS hospital when I worked in way back in 98. Whenever a patient of dyspnea comes into EMD, emergency medical department, he used to tell that the origin of dyspnea is just like a renal or a hepatic or pulmonary, cardiac, whatever it is. He has such a sense of catching that kind of thing. So the next 2-3 hours as a residents, we are then duty to prove or disprove. So it is always prudent to watch your patient, and a subtle eye change in eye contact or timbre of the patient's voice is just a right instant is sometimes only clue and otherwise misdiagnosed also. So patients are always not very clear with you sometimes. So you have to make every possible observations by the patient's actions. So interaction with the patient partners as well as family members is also very, very important. And sometimes when the patient turns into attender for the answer and all, then you can think of that some state of mind of the patient also. So enjoy taking the patient's history as well as a thorough clinical examination in every case of and wherever you get a chance, enjoy it and build up a very great amount of something like a walking encyclopedia in your mind. So wish you all the best. And this is our Department of Pulmonary Medicine. And we are also doing foreign body removals in pediatric patients. We do post our pediatric department colleagues. They are posting most of the cases in our hospital also. And these are some of the this thing. Lot of thanks from the Pulmonology department. Thank you very much. Thank you, Dr. Vishwanath, for giving me an opportunity. Thank you.
So that was an excellent talk, sir. Your students are very much fortunate to have such a great clinician. There are many great teachers are available, but because of the lack of time, they may not be teaching. But you are very much fortunate to have a good teacher who is very much clinically oriented, Dr. Sunil Kumar, sir. So this all the tips that has come from over the many years of experience, you should utilize all these findings. So you are very much fortunate. And with that words, I conclude this session.
Thank you, sir. Thank you.
Sir, thank you for lot of relevant points actually brought out. Actually, I like that last slide. Actually, enjoying and doing with passion will never make you feel tired. Actually, even history taking,
Yes,
clinical
yes,
examination, everything. Maybe if you put your heart and soul into that, definitely you will enjoy
Yes.
it. Thank you, sir.
Yes, sir. Thank you, sir.
So with that, we are coming to the end of this session. So I once again extend my sincere thanks to Dr. Vishwanath and his team for arranging certain question.
Sir,
Yeah.
a very good presentation, sir. Sir, I have one experience I want to share. Because when you talked on hemoptysis and history taking, no, nowadays I am seeing many patients in like last 5 years. I have seen 4 patients who don't have hemoptysis, but they come to the OPD with a huge number of files, and they mimic hemoptysis. So retrospectively, I have digged into these 4 patients. 3 of them proven to be this factitious hemoptysis. So in one patient, mother was cutting the hand of the daughter, and then they were chewing. When the father comes, they spit out that blood and they show it as hemoptysis. So it is the strange scenarios we are seeing when it comes to hemoptysis. History also sometimes very difficult. They won't give proper history. So some clues for this is like usually these patients will have 10 to 20 files. One fellow has spent around 5 to 6 lakh rupees for investigations. 3 times CT angiogram done. And they like, because of their mental problem, they keep roaming around, and if you say there is nothing, then they will change the doctor. So these kind of scenarios have you come across?
What I want to impress upon our associates, sir, as a consultant, Vishwanath and you may not have enough time to go into the detailed history of each of the symptoms. But the postgraduates, they had a very good time, so they can stay back rather than 9 to 4 program or something like that. Even in a hospital, also our hospital, they go usually around 7 o'clock, 8 o'clock to home, even though they don't have any, what you call duty and all. So detailed history taking and interacting with each symptom is very, very important by our postgraduates. That's what this PG meet is meant for. Thank you for throwing the light, sir. Thank you.
So
Thank you.
Thank you, Dr. Vishwanath and your team for excellent arrangements. I congratulate once again on behalf of all our chairpersons. Thank you once again.
Thank you, sir. Thank you for sharing your clinical experience. I now request Dr. Gangadhar sir to kindly felicitate Dr. Mathinudin sir. So please come on. Thank you, sir. I request Dr. Samuel sir to kindly give the token of appreciation to Dr. Harikishan sir. Dr. Harikishan sir, kindly. I request Dr. Srikar sir to kindly give the token of appreciation to Dr. Sunil Kumar sir, please. I request Shailaja madam to kindly honor the chairs of the session with a small memento. Thank you, ma'am. We now break here for lunch. In the interest of time, we will be gathering here after 30 minutes for the clinical discussion.
ఎక్కువ ఎవరు తీసే ఫోటో I request all the delegates to come forward. The ones sitting in the back. Please come to the front because this session is very important. It is on history taking and clinical examination. So we have come to our final session, which is the history taking and clinical examination. As you all know, medicines can only cure a disease, whereas a good doctor cures a patient. So in order to become a good doctor and a clinician, you need to be thorough with your history and clinical examination. So we'll be starting with the first session, and to present this, we have Dr. Kiranmay and Dr. Kirti, and chairing this session, we have all the senior consultant pulmonologists sitting here. So Dr. Gangadhar Reddy sir, Dr. Pradit Wagre sir, Dr. Narendra sir, and Dr. Shailaja ma'am. Thank you. Yeah.
Good afternoon. From 4 medical colleges, 4 students are presenting. So no one student should get panic because this is a simple presentation. Get as if you are presenting, how you are presenting in your college to your teachers, present like that. Whatever the questions we ask, it will be sometimes will be harsh, and don't take it into the heart, and answer those questions and take it light, and don't get afraid of presenting the case. Okay. Best of luck to each and every student. Thank you.
AV team, can anyone send the hand mics, please? Ganesh? They've gone, eh? They've gone to collect.
Good afternoon, friends. Just to introduce ourselves to you, I am Dr. Gangadhar Reddy at Yashoda Hospital, Secunderabad.
I am Dr. Pradit Wagre, Professor HOD of SVS Medical College, Mehboob
I am Dr. Narendra, Professor HOD, Usmania Medical College.
Dr. K. Shailaja, I am from Medicity Institute of Medical Sciences. What's that case?
Please introduce yourself.
Good afternoon, everyone. My name is N. Kiranmay, final year PG resident from Usmania Medical College.
I'm
Dr. Kirti from Usmania Medical College, final year postgraduate.
So what is the first preparation whenever you are going to the exam? What is needed most? Before day night, you take good night sleep, take rest, don't go on referring till late midnight. Okay, so covering all the entire subject with 1 hour. So these things should not be done. And at the time of presentation also should be very calm, cool. Then only all your thought process will come. Why I am telling this is you are little bit panic. Just relax. Just present like as if you are presented to your regular teacher. And the other purpose of keeping 4 or more examiners is each examiner will have his own way of asking the questions or approaching the patients. So just to sensitize you, there may be 3 or 4 more examiners in the exam. That doesn't mean that you are being inquired in every detail, or you are just like questioned or put in embarrassment. It is not like that. Just to take out the best in you. So some may be good in examination, some may be good in a clinical exam, some may be good in some certain investigation. If 4 or more examiners are, they will be assessing you in comprehensive way. That is the purpose. Just relax, start your presentation. Why both of you are standing there? Okay, go ahead. Any introduction? Please start.
Good afternoon, everyone. When coming to case proper, a 35-year-old male patient named Rajesh, resident of Hyderabad, who is painter
Sorry
by...
to interrupt. No names. You are not to use names.
Okay.
No, but that is a, you should not tell the name. You should not.
Okay.
It is to protect his confidence.
Okay.
That's okay. No names.
Resident of Hyderabad, who is painter by occupation, came with the chief complaints of fever since 1 week, a cough since 5 days, and SOB since 5 days.
Once again, don't say SOB, say
Shortness of breath.
I don't know what SOB is.
Okay. History of presenting illness. Patient was apparently asymptomatic 1 week back. Then he developed fever, which is insidious in onset, high grade, intermittent in nature, associated with chills and rigors, associated with sweating. There are no aggravating factors. Relieved after taking antipyretics. And there is no history of any burning micturition, loose stools, or vomitings. And complaining of cough since 5 days, which is sudden in onset, not progressive, associated with scanty sputum, which is yellow in color, mucopurulent in nature, non-foul smelling, and not associated with hemoptysis. There is no postural or diurnal variation, and
Start from the beginning.
presented with the chief complaints of fever since 1 week, cough since 5 days, shortness of breath since 5 days, history of presenting illness. Patient was apparently asymptomatic 1 week back. Then he developed fever, which is insidious in onset, high grade, intermittent in nature, associated with chills and rigors, associated with sweating. There are no aggravating factors, but relieved after taking antipyretics. There is no history of burning micturition, loose stools, or vomitings.
So what are the predominant symptoms?
High fever, cough, and shortness of breath.
So with those symptoms, what is the system you are going to thinking?
Of
interest you want to see?
Respiratory system. Cough since 5 days, which is sudden in onset, not progressive, associated with scanty sputum, which is yellow in color, mucopurulent in nature, non-foul smelling, not associated with hemoptysis. There is no postural or diurnal variations, and there are no aggravating or relieving factors.
Okay. Till that time, these are the main complaints. This is the history of present illness. What are the possibilities which are there in the mind, which we are going to further elaborate and taking further history to minimize the differential diagnosis? So with these chief complaints, with this history of present illness, what are certain things it should come into mind? What are those things?
Fever and cough. There is a we can think of infective etiologies, and cough with expectoration is there, so there may be involvement of parenchymal involvement, and cough with expectoration, also SOB is also there, and we can think of in airway diseases can also be included. Fever with cough with SOB, there can be possibility of community acquired pneumonia since it is acute history, or there can be a possibility of acute exacerbation of obstructive airway diseases, or there can be a possibility of acute exacerbation of ILDs also, and there can be a possibility of aspiration pneumonias, sudden acute onset.
So broadly, there may be airway involvement, there may be parenchymal involvement. So you said purulent secretions. Anything striking in your mind?
Lung abscess can be there, bronchiectasis can be there.
That should be the first thing you should think of when there is purulent secretion. Go ahead.
Acute exacerbation of ILD, the patient's age, there's no other history which is suggestive of that.
Yes, ma'am.
And aspiration, the patient is a young male.
Yes,
ma'am. That should maybe be the last. Like what Dr. Gangadhar said, bronchiectasis, these things should be on the top.
Yes, ma'am.
Those will come way down on the list.
Yes. Complaining of SOB since 5 days of grade 3 MMRC, which is sudden in onset, progressive in nature, associated with wheezing, and it is not associated with orthopnea or paroxysmal nocturnal dyspnea. There is no postural or diurnal variation, and shortness of breath is aggravated after walk and relieved by rest.
Is this the history?
Yes, ma'am. History of presenting illness.
So does the patient say, I don't have paroxysmal nocturnal dyspnea? The history should be in the patient's words.
Oh.
You don't, and the patient doesn't, and you don't say the patient doesn't have postural variation. He doesn't know these words. The history has to come in the patient's own language.
Okay.
I'm not.
See, if you are unable to see, that's trick in the examination. If you are unable to say and explain what you want to say by PND, you can say suggestive of paroxysmal nocturnal dyspnea, so that the examiner will think. So that the way of best is to say in the patient's own words. Okay, but if you cannot do it, instead of fumbling, you can say suggestive also. You can still get away.
When coming to past history, history of similar complaints of SOB since 5 years, which is having seasonal variations and diurnal variations, and patient was initiated on ATT 10 years back, for which patient doesn't know, and there is no documentation also available. He took ATT irregularly, not adequate dosage. He took Cat1 ATT fixed dose combination, but 2 tablets in the morning, 2 tablets in the evening for 6 months. But there is no documentation available about that, and he is not a known case of any hypertension, diabetes, coronary artery disease, cerebrovascular accidents, asthma, and epilepsy. Past history. When coming to personal history, history of similar complaints of SOB, which is having seasonal and diurnal variations, can go in lines of obstructive airway disease like asthma. About intake of ATT, which might be started for a pulmonary tuberculosis, but he took it irregularly.
Present complaints.
Yes, sir. It might be any PTB sequelae leading with the secondary infections, or any post-tubercular obstructive airway diseases.
So some people, this whatever treatment history you have mentioned, some people prefer to hear in the treatment history. Okay. Some people hear in the past illnesses. Generally, we expect past diseases, any history of diabetes, hypertension, or any childhood illnesses. These things are better in the past history. Okay. When you come into the treatment history, then you go for other detailed history. That is generally examiners expect that.
Okay. You are using SOV a lot. You used it 3 times after we corrected you.
Sorry, ma'am. Shortness of breath.
Yes.
Personal history, he takes mixed diet, and he is occasional alcoholic and tobacco chewer since 10 years. Appetite is normal, sleep is disturbed since 5 days, and bowel and bladder habits are regular. Personal history. in coming to family history, there is no history of similar complaints in the family. Born to a non-consanguineous marriage, he has 3 siblings, all are doing well. Occupational history, he is a painter by occupation, working since 18 years. Priorly, he used to work as an office boy. Marital history, he is married since 8 years, but there are no children. Allergic history, there is no history of any allergy to food or drugs. Drug history, history of intake of drug or treatment history of intake of ATT 10 years back.
Does him not having children have any significance?
Yes, ma'am.
How?
Any ciliary dyskinesias with bronchiectasis.
So your initial suspicion was that it could have been an acute exacerbation of bronchiectasis. So this definitely has a bearing on our diagnosis and our workup.
Yes.
So you have to keep these things in mind.
Yes.
Now that you have completed the history, what are the likely diagnoses on the history point of view?
PTP sequelae like fibrosis with any secondary infections, or bronchiectasis with any secondary infections, or there could be post-tubercular obstructive airway diseases, and we can also think in lines of relapse, TB relapse, and any occupational lung disease also we can think of, since he's a painter by occupation. And we can also think of malignancy, since he's having exposure to tobacco chewing for 10 years, and also some occupation with painting also can be associated with malignancies.
With respect to this disease, which type of relapse you can expect in this patient? If you're suspecting a relapse of tuberculosis, which type of relapse do you expect with this history? Suppose you have a drug history, has taken irregular ATT. So what do you expect with this relapse?
Drug resistant TB can be suspected.
Yes, drug resistant TB can be possibility, because he has split the dose and taken in it, which is not at all advisable in anti-tuberculosis treatment.
Enumerate 2 or 3 clinical conditions can fit all this, because your next general examination, next systemic examination will be confirming these 2 to 3 diagnoses. By the end of history of these illnesses, should be able to come to 1 or 2 differential diagnoses, because complaints history should give 80% of the diagnosis. So now briefly enumerate 1 or 2 conditions which you are thinking most, and these things are confirmed in the next general examination and systemic examination. This is the point of the 3 parts of examination: history, general examination, systemic examination. By that time 90%, only investigation should help to confirm 10%. So now we have completed history. Now give me 2 or 3 differential possible diagnoses.
PTB sequelae like fibrosis or bronchiectasis with any secondary infections, and post-tubercular OAD with exacerbation.
By PTP sequelae and
Same.
post-tubercular.
Same.
Mostly post-tubercular sequelae with secondary infection. He is painter. He has smoking, tobacco chewing. Any other possibility?
Malignancies.
Second possibility with secondary infection, not simple malignancy. Secondary malignancy with secondary infection. PTB sequelae with secondary infection. Malignancy with secondary infection. He also said he has BC and tobacco chewing, painter. Any other possibility?
COPD.
Yes. These are the 3, at least 3 working diagnoses. Based on this, you will build up further. This tubercular sequelae could be malignancy, could be COPD associated, or a combination of all 2 or 3 can be there. Now you are going to the general examination.
General examination will be dealt by Keerti, sir.
Good afternoon, everyone. On general examination, the patient is well built, well nourished, and height of the patient is 168 centimeters, weight is 75 with BMI of 26.5. There was no pallor, no icterus, no cyanosis, no clubbing, and no lymphadenopathy. JVP was not elevated. Vitals, pulse rate was 90 per minute, regular in rhythm, normal in volume and character. There was no radial or radiofemoral delay. Respiratory rate was 26 per minute, abdominothoracic type. Saturation, SpO2 was 88% room air with 4 liters of oxygen per minute with nasal bronchs. It was 97%. BP was 120 by 70 mmHg, right arm in sitting position. Temperature was 98.9 degree Fahrenheit. Examination, respiratory system examination, sir. Yes, sir.
Nothing significant on general examination.
Yes, sir. Yes, sir.
But he is well built, well nourished, no clubbing, no sinus, nothing.
Yes, sir.
Take it with pinch of.
Saturation or 4 liters is quite a bit.
Patient has 1 week history, ma'am. He had past history of shortness of breath, ma'am, since 5 years, but no documents were available with him. So at the time of presentation, only the saturations were same.
What was the saturation when he came?
88% room air, ma'am.
So 4 liters does he really require?
With 2 to 3 liters. Mind.
No. Don't say 2 to 3. It is either 2, it's 3 or it's 4.
His respiratory rate was high, ma'am, and patient was tachycardia was also there.
Okay.
And
could be the acute the hypoxemia also will cause all that. So like what Dr. Gangadhar said, there was no clubbing, there was no cyanosis, so no pallor. So this seems to be something very acutely which is happening. If you have chronic hypoxia, you expect all those things, right? So it seems to be something very acute, right? Yeah. Oh.
Yes, sir.
Except hypoxia.
Okay, sir. Yes, sir. Respiratory rate and heart rate is high, sir. Yes, sir.
Shallow breathing. Shallow breathing?
Ma'am. Respiratory rate is 26 per minute. No. No, sir. Overweight.
Difficult to comment. Different. Oh. Go ahead.
Upper respiratory tract examination. Examination of nasal cavity. Mucosa is normal, septum is normal, turbinates are normal. Oral cavity, mucosa and tongue are normal, teeth are stained. Oral hygiene is maintained. Oropharynx, tonsil and postopharyngeal wall examination seems to be normal. Lower respiratory tract, on inspection, there is an asymmetry of chest in the form of left-sided drooping, and left nipple and axilla are at lower level, and left supraclavicular fossa hollowing is seen with prominent medial border of left scapula and decreased left spinoscapular distance. Trial sign is positive on left side. Apical impulse is not visible. Spine is normal. There is usage of accessory muscles of respiration.